morning. A hearty welcome to all of you. Braving the rains, you have all come, each and one of you, and to contribute your part to this conference, and that is indeed commendable. And I would like to appreciate the efforts of Ethicon and J&J for their initiative in the making of this conference. And I pray to Almighty that all of us will benefit a great deal from this conference in the coming 2 days. So with this short introduction, let me call the first speaker for the first session, Dr. Unnikrishnan. He will talk on pancreatic anatomy relevant to the surgeon. And to chair the session, I call upon Dr. Ramesh Rajan and Dr. Pratapan.
Good morning, ladies and gentlemen. Greetings from Amrita. Am I audible? I can't. Yeah. As I was walking in, I met Arun, and Arun told me, first thing you should say is, pancreatic anatomy is highly variable. So I'll start with that. It's one of those areas where any vascular structure can vary in many ways. So let us go on. This is just an introductory slide. Basically, very few surgeries before the beginning of 20th century. First description in 300 BC, and then you can see the big names coming in: Vesalius, Versung of the duct, Santorini of the second duct, Vater of the ampulla, Odi of the sphincter, and these are the two people who found that it has endocrine function also, when they found that dogs who had pancreatectomy had diabetes. So basically, most of the development, most of the finer anatomic points and its implication on outcome has been developed over the past 20 or 30 years rather than other organs maybe decades back. So surgical anatomy, again, this is a very basic introductory slide. Located in the upper part of the abdomen behind the stomach, divided into head, uncinate, body, tail. Head and body are retroperitoneal, and tail, you can call it intraperitoneal. Head and uncinate occupies a C loop, and the neck is a thin portion lying over the aorta, and of course in front of that portal vein, that area. Tail is defined arbitrarily as a distal 1/4 of the organ from the tip. And that is a diagrammatic representation. And then the uncinate can be very variable, with forming a nub stopping just to the right of the superior mesenteric vein, and then it can extend behind the vein and or even cross across all the way into the behind the superior mesenteric artery. This area we will come in discuss in little more detail later on. Even in cases where it stops short of the vein, there might be a facial ligament called uncinate ligament which extends behind the artery, which will need to be dissected off during a head resection. And bile duct, one of these slides says that it is of 3 types: outside, in a groove, and buried. Actually, there is an older paper in 1978 where anatomy was mostly descriptive, which says there are 5 types. But irrespective of that, it is not one of those things that makes a huge difference, whether the bile duct is inside or outside. As you all know, developmentally, there is a dorsal pancreas and ventral pancreas, and they undergo rotation, and then along with the stomach and duodenum rotates again. So that is a ventral pancreas, duodenum, dorsal pancreas. The ventral pancreas rotates first, and then the whole thing falls back onto the retroperitoneum. The key factor is that most of the planes around the pancreas are not very vascular. It is as long as you take care of the vessels in the central part, SMA to the portal vein, bile duct area, the rest of it is relatively avascular. The facial investments, as you can see, it is covered by a loose fascia, which goes all around like this. Fusion fascia of treats is in the back of the head of the pancreas. Fusion fascia of told obviously is over the body and tail of the pancreas, and there is a loose connective tissue membrane which you can actually mobilize fairly easily. Now comes the concept of mesopancreas and total mesopancreas excision, which was first proposed in 2007. It is not a well-defined anatomical structure, that you can pick up with a forceps and say, this is mesopancreas. It is a fibrofatty tissue with a lot of lymphatics and nerves located behind the head of the pancreas. And quite often it may be the area where your resection fails. And to take it out requires that you dissect in detail just outside the supramesenteric artery, go behind it and clear out the tissues completely to get an en bloc R0 resection. The mesopancreas triangle is bounded by the posterior surface of the SMV portal vein axis, and the apex is made by the anterior surface of the aorta between the celiac and supramesenteric artery, and each sides by the celiac trunk and SMA plexus. Here, this would be the mesopancreas area. You can see that if you take a sagittal section, it will be in this area that it comes. And on a CT scan, again, it is not a well-defined area. It is arbitrarily defined as 2 centimeter below the origin of the superior mesenteric artery in this particular space. Clearing that is important because it is a common area for failure and common area for recurrence after resection of head pancreas cancer. Many of these margin statements are applicable to head pancreas rather than obviously periambulary lesions. And total mesopancreas excision does not mean that you don't do the standard lymphadenectomy. That is also included with this. Then the attachment, then there are 1 or 2 surgeries where you may need to take the pancreas off the duodenum. The attachment between the pancreas and the duodenum are fairly loose except at the major and minor papilla. And at the major papilla, the attachment is primarily ductal rather than at the minor papilla, where there might be a degree of parenchymal fusion with the duodenal wall. Arterial supply. You can see that there are a fair amount of arteries. The gastroduodenal artery, which gives us the anterior and posterior superior pancreaticoduodenal arteries. The inferior pancreaticoduodenal, which comes from the superior mesenteric artery. This picture shows it very simply as a single trunk arising of the superior mesenteric artery. This area is the part that we were just discussing, that which we need to clear off clearly. So having a clear idea about the anatomy in this part is critical. The tail is mostly supplied by the splenic artery, the dorsal pancreatic artery, and multiple transverse branches from those two. This is a posterior picture that essentially shows the same thing. The key point to note is that there are a lot of arterial variations that can be there. Mesenteric celiac trunk can be, a single trunk can be seen in 2.8%. A replaced or accessory right hepatic artery or even a completely replaced hepatic artery from SMA can be there. This will run very close or even through the pancreatic parenchyma from the SMA upwards, and will hinder you in getting a clearance unless you work around it diligently. And IPDA, like we mentioned, it may be single, it may originate separately as an anterior and posterior trunk separately, and in a fair number, about 60%, it comes from the first genital branch. So ligating the first genital branch with a right angle through fatty tissue from the left side may not be the best thing to do. So, and then inferior pancreaticoduodenal artery can originate directly from the SMA posteriorly. So that also needs to be kept in mind when you are dissecting. Then comes venous drainage. Here we see the gastrocolic trunk forms a major drainage of the head of the pancreas, and then there is an inferior pancreaticoduodenal veins that drain directly to SMV. The tail and the other regions are mostly drained by the splenic and its branches, and the transverse pancreatic vein drains directly into inferior mesenteric vein in a good number of cases. The venous drainage of the head of the pancreas and duodenum is via the anterior and posterior arcade, and the posterior superior pancreaticoduodenal vein commonly drains directly into the portal vein, while the anterior superior pancreaticoduodenal vein drains into the gastrocolic trunk, which joins the SMV. And like we said again, this is eminently variable and can change dramatically. Then comes lymphatic drainage. The standard regional lymph nodes draining the head and neck of pancreas include those along the CBD, those along the common hepatic artery, those along the portal vein, those on the posterior and anterior pancreatic arcades, and along the superior mesenteric vein, and along the right lateral wall of the superior mesenteric artery. This is a simple description. Many of the anatomy textbooks describe it as superior lymph nodes on the upper border, inferior lymph nodes on the lower border, splenic lymph nodes on the splenic hilum, anterior lymph nodes on the anterior aspect of the pancreatic head, posterior lymph nodes on the posterior aspect of the pancreatic head. These are the simple descriptions. Then comes in the Japanese with their fine attention to detail. So the standard lymphadenectomy that is recommended, this is around 2014. It is probably bound to change in the next few years. Suprapyloric, infrapyloric, which are not marked out here. The anterior superior 8A here, you don't need to dissect the posterior lymph nodes in the hepatic artery. Along the bile duct, along the cystic duct, posterior aspect of the superior and inferior portion of the head of the pancreas, right lateral side of the SMA here. This numbering is a little wrong. It is 14A and B. Then anterior surface of the superior and inferior portion of the head of the pancreas, 17A and B. This encompasses the standard lymphadenectomy for a head resection. Extended lymphadenectomies were analyzed around this period, and it was suggested that, sorry, one S is missing there, skeletonization of hepatic artery, SMA, celiac trunk, and dissection along the anterolateral aspect of the aorta and vena cava, including aorta sphacia. During those analyses, significant survival benefit was not seen, or whatever was seen was attributed to stage migration rather than anything else, and it is not a standard recommended procedure. Standard lymphadenectomy for body and tail will include hilum of the spleen, along the splenic artery 11P and 11D, and inferiorly 18. Station 9 around the celiac needs to be dissected only if it is a body tumor bang in the middle of the body. Ductal anatomy, the main pancreatic duct and accessory ducts lie in an anterior plane to the major pancreatic vessels. And the main duct Versung arises in the tail and lies between the superior and inferior border, slightly closer to the superior border, and lies slightly more posterior rather than anterior. The diameter, obviously, we have all learned, multiple studies are there. 4, 3, and 2 is how I tend to remember it, head, neck, and body. And in the ampulla also, the variations persist. This is a classic ampulla overture. Then you have a partially resorbed channel with a common opening here, and then you may have 2 separate openings completely. Anomalous pancreatic biliary junction is seen when they join outside the duodenal wall, seen associated with 90% of patients with a colloidal cyst. There is a high incidence of CAGB and bile duct cancer in these patients, and head of pancreas usually has more tissue. This results from a delayed recanalization of bile duct due to the persistence of left ventral pancreas. Exposure of the pancreas, standard manuals, cattle brush and coccus. There are Japanese studies that suggest a no-touch technique where you don't touch the tumor before separating out from the superior mesenteric vessels by a reverse cockerization. You start at the end of the, divide the neck, go in, and then mobilize laterally. Then this is something that I picked up from a recent publication. Intestinal derotation and mesopancreatic dissection looked interesting. Basically, the whole transverse colon, again Japanese obviously, the whole ascending colon and the root of the mesentery is mobilized, and the colon and the small bore are rotated clockwise. So you can see that the superior mesenteric vein comes here, superior mesenteric artery has rotated to the right of it, and the proximal jejunum has come out from under to the right side. The jejunal branches, the IPDA, this whole area that needs to be dissected well for the mesopancreatic dissection is very accessible. I have never done this before. This is a recent discovery for me. Sir? I have not derotated it ever. Sorry. Then comes the artery first approaches to pancreatic duodenectomy. Identification of unresectability prior to the point of no return. Possible advantages are oncological superiority, which is not strongly proven, reduced blood loss, facilitation of venous resection by taking out the artery first, and early identification of aberrant right hepatic artery. Approaches are posterior, medial uncinate, inferior infracolic, left posterior, inferior supracolic, and superior approach. I have one slide on each. And posterior approach, basically, I actually thought that there would be a lot more of students here. Sir? Yeah. Posterior approach, basically exposing the origin of the superior mesenteric artery. You basically reflect the head and duodenum all the way up and then clear it over the superior mesenteric artery here. That is a posterior approach. Medial uncinate approach, the uncinate process, IPDA, everything is demonstrated after cauterization and mobilization of the DJ flexure completely. Inferior infracolic approach, you reflect the transverse colon upwards like you would do for exposing the superior mesenteric artery for an embolectomy or something like that. And then you identify the vessels there and dissect there between the superior mesenteric artery and vein to do the clearance. Left posterior approach exposes the first and second jejunal arteries at their origin and then applies traction on the superior mesenteric artery to expose it and IPDA identification, and IPDA gets divided in that plane. Inferior supracolic approach or anterior approach, demonstrating the superior mesenteric artery and the vein, splenic vein, celiac axis, everything after division of the neck, and then detailed dissection in between those two. And superior approach, retracting the pancreas downwards, celiac, SMA, and the branches and the areas that you need to dissect are exposed there. I think that would conclude the plain anatomy. I'll be open to questions and discussions now. I know I had 30 minutes, but...
Interesting. Starting from the variation in anatomy, I think as a beginner, one should expect variations in anatomy in all cases. But if you ligate a vessel which is not described in a particular position, like inferior pancreaticoduodenal artery, which is bigger than expected, I think we have to consider. What is your opinion about identification of vascular anomalies prior to your ligation, especially when you have large vessels or the middle colic artery arising from a pancreatic vessel, etc.? You have to suspect some associated anomalies elsewhere.
To dig up those old pictures, I actually went through an old article by Scandalakis, 1978. The article finishes by saying that we strongly recommend usage of DSA in all pancreatic cancer resections to precisely identify the vascular anatomy, which is critical to the results. And from there, we have moved on to CT angiograms, which are perfectly good. I would suggest that you ask for a triple phase, properly timed triple phase CT rather than a single shot venous CT before operating any pancreatic patient. Any pancreatic surgery, you need to have the vascular anatomy pat, because especially if you have an advanced tumor, in your mind you may think that okay, IPDA is there, you go, you loop the superior mesenteric vein and portal vein axis, retract it upwards and to the left, and you see everything. But if the tumor is advanced there, you have no view. You don't know whether there is a replace right coming out of the SMA, those kind of situations. So it is absolutely essential that you have a proper angio-timed CT scan, looked at the vessels. The planning should be beforehand. You should not have to think on table, what is this vessel?
Why I specifically ask this question, usually the students are taught before ligating gastroduodenal artery, you apply clamps. Incidentally, we had a few occasions when I ligated the right gastroepiploic artery, all the pulses in the hepatic hilum gone. So I think it's not the gastroduodenal artery. Anywhere during your arterial dissection, I think you have to suspect issues, especially in elderly individual and all. Second, regarding the venous, you forgot to mention the Belcher's vein.
So nice, before opening to the audience, a few points, nice exposition by Unni covering all the, and I agree with what Prathavan said that there can be more surprises, medicine is full of surprises, even with your pre-op excellent imaging, I think you should, it's good practice to always put bulldogs even before ligating, for a test trial clamping before going and ligating anything in HPB area. Only one thing, you were talking about the arterial anomalies, and as we know, the right hepatic artery replaced or accessory is one of the commonest. Apart from that, when you have a common hepatic artery from the SMA, it makes a lot of difference. Actually, I have sweated a lot in a couple of cases with the imaging showing a smaller tumor, and on opening, actually, the tumor was averting the CHA arising from the SMA. And CHA passes, when it arises from the SMA, it passes bang through the head of the tumor. So I think the NCCN guidelines, I think, mentions about neoadjuvant, routine neoadjuvant NACT for such anomalies, even if there is just near abutment for a CHA from the SMA.
Okay.
That is one thing which I wanted to say. And the other thing is about the types of unstayed process. The type 1, type 2, and type 3. Actually, one of our earlier trainees, Swastik, had done a study, retrospective study, comparing the margins between those who had type 1, type 2, and type 3. And actually, we found that the margins were same. There was no difference in the margin. Only thing, the operating time was more in the type 3, where it crossed the SMA. So I invite questions and comments from the audience. Should we start with the MC's trainees or Kale? Yes, Kale, you're.
I think you should just democratically.
To anybody, yeah.
Because the anatomy is most interesting actually in pancreas. Just responding to that question on IPDA, which is unusually big.
Large.
So that's something which we have to be critically looking, because just now, yesterday one of my old residents shared a CT image, had a prominent IPDA. So when the IPDA is prominent, it indicates there's a problem with the celiac.
Yes.
Right? So the options in that case is, in case if the tumor is early, it's a periampullary tumor, actually we can preserve that arcade between the IPDA and the GDA by ligating the branches. If we can carefully do that, we can still do the Whipples by preserving that communication between IPDA and the GDA. In that case, we may not even have to do any complex reconstruction at the celiac. Otherwise, you have to do a celiac reimplantation. So that's the importance of seeing that. One thing which, I mean, even I have a doubt, so probably. So we commonly use the term posterior pancreatic capsule.
Yes.
When we talk about this phrase and all this. So, according to you, so what is actually the posterior pancreatic capsule? Because if you see the anatomy of the posterior aspect of the pancreas, you have, starting from kidney, you have an anterenal fascia. Then there is actually a fusion fascia of treats. And then you also have the pancreatic capsule, which we normally see the anteriorly and the same. But what we see in all this pancreas, the capsule is thick. So, so what is your opinion on that term posterior pancreatic capsule?
I mean, I personally think that it is especially we use the term more with phrase rather than with Whipples. Basically, it is my feeling is that it is a composite, inflamed, thickened fusion of all these loose areolar tissues that are there rather than a named capsule. Yes.
A formed capsule you will see only in patients who are being operated for chronic pancreatitis. In other conditions where there is not much inflammation, I think the anterior and posterior part of pancreas looks almost very loosely attached, and no definite capsule will be seen. It's called as a pseudo capsule rather than a true capsule.
Yes. I mean, Subhash, the point that you are just discussing here, the levels of divestment, do you think it is worthwhile to go all around supramesenteric artery, since you brought it up?
I was just erasing that point just because not in every case, especially in borderline resectable malignancies, post-chemo, post-RT. In such cases, maybe that point is worth discussing. So there are further discussions on that point.
Yeah.
So
Why I am saying is, the standard lymphadenectomy definition clearly says that you are not to go to the left of the superior mesenteric artery. That is why I wanted it brought up here.
it is rather than taking up the lymph nodes, maybe it is the clearance to get a maximum R0 resection. That is the purpose of going beyond that point to the level 2 and level 3 as described by and all, where when you do the arterial divestment and those kind of things.
And that is actually for borderline resectable tumors. So probably you're justified in doing it, I think.
Depending on which vessel you are dealing with. Because if you have a body and tail lesions, your arterial divestment will invite more trouble than compared to the other lipo. Because if you have a celiac artery, pseudoaneurysm or other closely the hepatic artery and celiac aneurysm, post divestment, it will be very difficult to manage. It may be easy to manage other type of and so if you have a very large lesion, very much abutting the superior celiac axis, most of the time you may have to consider resection rather than divestment, arterial resection rather than divestment. What is
And one more doubt is, when you go like a level 2, isn't it almost similar to a mesopancreas excision? Because these two things, isn't it same or is it really different?
Dr. Kalai, you want to respond to that?
See, actually, the mesopancreas term is, it's not only between the uncinate and the SMA, it's actually the three components are there. Probably I think there's a session tomorrow on that. Maybe we can discuss during that also. So about the three components of the mesopancreas and how to remove during the surgery. I think sir.
Prakash wanted to say something. Yeah.
Just a comment about the axillary and aberrant right hepatic artery. I think it's my observation, I don't know, we haven't studied that. We tend to see very often, much more than what is mentioned in the literature. Maybe every second and third patient, we see either aberrant or axillary, which is not much mentioned in the resectability criteria of most of the guidelines. So is it the experience of others? I would like to know, because I think in Indians it's much more than common. That's one. And second is about the patients who have uncinate tumors, and the spread of the disease tend to be along the D3 and to the first part of jejunum, where all these, your SMA approach, all those may tend to fail the ability to do an R0 resection unless it is that area is really addressed in the initial part of the mobilization. Usually somebody who's starting may not appreciate that there is a large amount of tissue there. So what's your opinion in approaching such a patient? Where do you start the mobilization? How do you proceed in planning the resection to make it an R0 resection?
Sorry, can I?
For an uncinate
For
tumor.
a large uncinate tumor.
Yeah, large uncinate tumor where it spreads along behind the mesocolon, along the root of mesocolon towards the first part of jejunum. You may not see any tumor where we would make the tunnel, and maybe even the anterior aspect of SMA will be free, that area.
See, right now with imaging, you have a fair idea that you're dealing with a uncinate lesion before you get in there. So I would spend more time mobilizing the DJ flexor, turning it down, passing it under, and mobilizing that part first, rather than before I start taking the pancreas head off the vessels.
Yeah. Arun, yeah.
Just one more comment about replace right hepatic artery from SMA. Do you find branches to other areas like pancreas before it actually reaches the liver?
Yes. I have.
Many a times. So we need to be very careful about that.
Yes. If you have aberrant artery, some of the cases the posterior inferior superior pancreatic duodenal artery may be arising from that replaced vessels. It may be very difficult sometimes when the tumor is very close to that area.
Just wanted to say that the first slide which Dr. Unni showed, about all the historical characters, most of them were either shot, murdered, or hanged. So people who research in pancreatic disease have a very high mortality. I hope that's changing in the modern era. When you mentioned about bile duct outside or inside, it matters when you're doing a sphincterotomy.
Yes.
Because if you have a bile duct which is outside, you'll get only peritonitis or retroperitoneal abscess. But if you have it's inside the pancreas, you'll get a pancreatitis as well, and it is a bigger problem to manage. Everyone talks about this ampullary and this head cancer, and Kalei talks about it. But in patients who have involvement of the pancreas in ampullary carcinoma, it's pretty much the survival is the same. And it's not very obvious, even on the CT scan, it's not obvious even during exploration. So I'm really concerned about how surgeons really decide, oh, this needs only a hodgepodge uncinate resection, and this requires a real thorough resection. I'd like some experts in this all to comment on it in the course of the day if possible. The intestinal derotation, whether you do a limited intestinal derotation to enable the proximal jejunum to emerge on the right side so that you make everything straight like a right hemicolectomy, or whether you do it completely is a matter of choice, but some form of derotation would certainly make the anatomy much more clear.
I have never tried a complete derotation yet.
But it's definitely worthwhile any time when you have difficulties in the operation.
Yeah, just to add to that point on intestinal derotation. So when we do it, like normally the one which you mentioned, actually they do a complete derotation, which may not be required in
All cases.
All cases. So what we do is a kind of a limiter, as I was mentioning. So that's why probably you can use the term, at least some have used the term intestinal flattening instead of derotation. So that because to differentiate from the complete, so here you just flattening that between the mesopancreas and the proximal jejunal mesentery. So that's also one more term which you can hear.
So before we wind up, I think we have come to the end of the session. Before we wind up, can I have because all of this is talking about good radiology and imaging and pre-procedure planning. In practice, in actual practice, most of us come up with patients who have had at least 1 or 2 CTs outside. So in actual practice, how many of us, can we have a show of hands of how many of us would do a good pancreatic protocol CT before doing a pancreatic resection? 75%? Yes. Thank you, Uni.
Thank you, Speaker and Chairpersons, for the first lively session. Now I invite Dr. Tara Pratap and Dr. K. Prakash for the next session on a kaleidoscope of images in pancreatic disease with clinical correlation. To chair this session, I call upon Dr. Joseph George and Dr. Viju Baradan.
So, good morning. And after the crisp talk on surgical anatomy of pancreas, we will move on to imaging in pancreatic disease. I'm happy to share the platform with Dr. Prakash because he would be dealing with the clinical aspects of whatever cases I'm going to show here today. So in the next 30 minutes, we have 30 cases, and if time permits, would conclude with 2 rare cases. We would encourage participation from the audience, especially the residents over here. And off we go. So first case, straightforward case for the residents.
Done as spotters for residents, if somebody can show a hand. And anyone? Accused master is the last person to answer.
Yeah, perfect. It's annular pancreas where you see an aberrant duct encircling the duodenum, and this is CT image showing rind of pancreatic tissue all around the duodenum, and similar entities annular pancreas, circumportal annular pancreas, where you can see pancreatic tissue going all around the portal vein, and it has many subclassifications. And over to Dr. Prakash for the clinical and surgical relevance of this variant anatomy.
I think unless they are making any symptoms of duodenal obstruction, or we don't need to actively treat this condition. So unless causing duodenal obstruction only, we need to be worried about. And the importance comes if there is some pancreatic pathology along with that. Otherwise, this is a finding which is often seen on images.
So case 3 is again for the residents, your Mrs. Potter.
Yeah, Dr. Shashi.
Residents, please come forward.
Prashant. Pancreatic division.
Yeah, you can see the crossover of the ducts over here. And about the clinical part, like, sometimes it could be an incidental pickup, or it could be when the patient presents with symptoms. And there's an ERCP image, cannulation of the major duct showing ductal arborization of the minor duct, showing minor papilla, showing changes of recurrent pancreatitis as evidenced by dilated irregular pancreatic duct with pseudocyst. And again, like, it has got subtypes. It could be classic, it could be total, it could be incomplete. Anything to add, Dr. Prakash, from the audience?
I think the images are self-explanatory. Unless it's causing obstruction and symptoms, the active treatment is not required. But there are few patients who don't respond to endotherapy, minor papillar stenting. And in such patients, if there is features of dilated duct, only the surgical intervention is really required. In your opinion?
I remember one case where a patient had presented with single dilated duct, only dilated duct, no other symptoms. But in that case, the side viewing endoscopy showed actually a small nodule in the minor papilla. Biopsy came as neuroendocrine tumor. So probably it's a good idea to, even if you see a device with a dilated single duct, to just do a side viewing endoscopy to ensure that there is no obstructing cause like a tumor.
So this is a scenario which we confront with. What you see here is an enhancing lesion in the pancreatic tail, very close to the splenic hilum. And I would give you a clue, like accessory spleen. So a differential is always a neuroendocrine tumor. So what we need to do is we have to look into the enhancement pattern of the intrapancreatic spleen with the normal spleen. And if it follows the enhancement of spleen in all the phases, then you can categorize it as an intrapancreatic spleen. Of course, SPECT CT with sulfur colloid is diagnostic, and this is one of our recent cases with a proven neuroendocrine tumor showing homogeneous enhancement in the pancreatic tail region. So, what I'm showing you here is an enhancing nodule well away from the pancreas in the jejunum, ectopic pancreas, and sometimes like it could be in the greater curvature of the stomach.
In such enhancing lesions, we should also consider GIST or neuroendocrine tumors of the small bowel as well.
Yeah, in fact, that was a radiological diagnosis given because the most common submucosal enhancing lesion to us is either GIST or a carcinoid. And moving on from congenital conditions into inflammatory lesions. So this is one of our patients who presented with acute abdomen. So any takers, findings? So what you see here, this patient in fact presented with acute necrotizing pancreatitis, where you see non-enhancing pancreatic parenchyma in the distal body. And this is a normal pancreatic parenchyma for comparison. So do you see anything in addition to that? So there was a neoplasm. So this is an incidental pickup. Actually, the patient presented with acute necrotizing pancreatitis. Yeah, there is a calcification in the center. Yes, it is. And this is acute necrotizing pancreatitis with serous cystic neoplasm in the pancreatic tail region. So this is another case again with pancreatitis necrotizing pancreatitis with through and through involvement of pancreatic body. You can see vault of necrosis in the peripancreatic region as well as a dilated duct beyond. So comments, management. No history of trauma, just necrotizing pancreatitis, and after that the imaging showed upstream duct dilatation with a collection. Yeah, this is case of necrotizing pancreatitis with disconnected duct syndrome. Dr. Prakash, like.
Yeah, this is basically because of parenchymal necrosis and loss of pancreatic tissue, and the ducts get opened up into the necrotic collection. And you could have stricture on this side producing dilatation of the duct as well. So these will end up in, if you drain it externally, it will end up in a fistula, and it's a complex thing to manage. So initial interventions are usually with minimal invasive approaches, but however, you may end up in doing either a resection or a drainage of the strictured segment eventually.
And so these are from two different patients. Both show peripancreatic collections. First case, it looks a little heterogeneous. Second one, it looks fairly homogeneous. So yeah, the first one is of course a vault of necrosis. The second one, homogeneous, you can call it a pseudocyst. And MR like takes you a step ahead in characterizing those cystic lesions or collections, because this is a T2 weighted image showing debris. And I think it's very important for the endoscopist or the surgeon to decide upon necrosectomy versus drainage procedures, because it will tell you about the extent of debris within those collections. And it's difficult. Like it may appear as an area of variable density, but MR or even ultrasound is better to detect debris. So what is this? Moving on to the next case. No bowel connection. Yeah, this is a case of pancreatic abscess with air pockets and sequelae of pancreatitis with an abscess, and a contrast enema was given, and then it shows a communication with the abscess cavity. So how does that modify your diagnosis here?
So here,
yeah, I'm getting all the answers from this side, but the residents are not participating. The residents sitting behind you are not participating.
I think we have to call the residents here one by one. We'll put the questions. So it's better to call them here first. From back to front, and in the serial order, we'll post the questions. So first question comes to first person. Please come. It's not an exam. There is no marks, so it's a good opportunity for you to assess your level. Everybody is sitting.
Yeah, I think someone can start describing.
Yeah, we'll start with Dr. from Lisi. So you can describe the CT findings. Give him a mic.
I think we have a lot of cases to rush through, so I think got to make it fast.
Make a quick finding and.
Because it's 1 minute for one slide, so.
Yeah. So it is a contrast enhanced CT scan of abdomen showing abscess in the pancreas with air foci inside. In the lower image, there is a communication from the large colon to the same pancreas.
Yeah, you have given all the findings. So about the management part.
Such patients are often very sick, and they'll be having infections. So we'll have to anyway drain the collections or do the necrosectomy. But here, in view of the fistula already demonstrated the CT scan, probably a diversion along with the necrosectomy would be ideal. Otherwise, he'll end up in the fistula.
So case number 10 is a straightforward spotter.
replaced RHA, I think. Replaced RHA from the...
Rather than the arterial, I would say that this is a contrast enhanced scan. I have not provided the plain scan, and I think you can comment about the most staring lesion.
The aneurysm.
Yeah, that's an aneurysm which is involving the GDA, and this is a companion case where you can see an aneurysm from the splenic artery. So this is a second common site, can occur after pancreatitis or after surgery. And now we move on to chronic pancreatitis. So what I have shown here is CT from 2 different patients showing different patterns of calcification. So does this pattern of calcification give any clue to the underlying etiology?
Second one is tropical pancreatitis.
Yeah, and the first one?
First one is alcoholic.
Yeah, it's ACP. So in ACP you get fine regular calcifications, whereas you get more coarse calcifications in TCP. So case number 12, can you identify the complications in this post-contrast study? So what you see here is a curved reconstruction to the pancreas showing multiple ductal calculi with some ductal wall enhancement. This is a post-contrast scan.
Calcifications with cholangitic abscess.
Yeah, a hepatic abscess, coalescing hepatic abscess, and what you see here is the thrombosed portal vein as a result of portal pyemia. So case number 13, I think this entails a lot of discussion just beyond the scope of this discussion today here. So what you are seeing here is an enlarged lesion in the pancreatic head. This is a focal mass in the pancreatic head. You can see upstream dilatation, and this is always a problem for us whenever you see a focal lesion. We have to differentiate it, malignant mass from an inflammatory mass. So there are a lot of signs, but then you know what happens in clinical day-to-day practice. So if you see the duct penetrating sign, if you see visible remnants of normal pancreatic tissue, you can say it's an inflammatory mass, as what this case is. And this is a straightforward case of malignancy where you see that there's no parenchyma anywhere else in the pancreas. There is total fatty replacement, but then you see a soft tissue mass in the head region with double duct obstruction. And what is the sign which is shown here? The teardrop sign indicating infiltration of SMV. So another sign which you can look for is irregularity of the arterial vessel wall, and which is better seen when you do the 3D reconstructions. We look for that, and if you see vessel wall irregularity or this corkscrew appearance, like it indicates definite vascular infiltration. So there are a lot of differentiating findings, and I will not go into that. Moving on to cystic pancreatic neoplasm. So what we follow is this chart. So it is very easy for us radiologists to give a diagnosis. So whenever we come across cystic neoplasms in younger age group, we tend to give a diagnosis of SPEN. In middle age, we give a diagnosis of mucinous lesions. Elderly group, serocystic lesions, and elderly male, a diagnosis of IPMN. So I'll just show you one of the recent cases. This is a 31-year-old patient who came to us with 3.2 centimeter cyst in the pancreatic neck region. There was some dilatation of duct. And as all of us know, cystic lesions are better characterized by MR, and MR was also done. And what you see here is a cystic lesion with some lobulations, incomplete septa. MRCP was done. We could see the duct very close to the cystic lesion. It was looking as though it was communicating. Not so sure. It could be obstruction causing dilatation beyond. US was also done for this patient. FNA was done for this patient from outside. The reports were inconclusive. So we go by the chart. We can always give a diagnosis of mucinous neoplasm and hand it over to the surgeon. So I think the question is to Dr. Prakash, and then like.
Yeah, in mucinous cystic neoplasm, sometimes you can get classical multiseptate lesions, but if you see any peripheral calcifications or wall septations or mural nodules, you should suspect malignancy, mucinous cystic carcinoma, and we should be changing the management strategies accordingly. So another thing is that you may not see multiple septations in all cases. There is a variety called oligoseptate type of mucinous cystic neoplasm where you tend to see very less septations. So there are a few variants of mucinous cystic neoplasms. But ultimately, if you are suspicious, you can go ahead with aspirations fluid study and CA in the cyst fluid is diagnostic of mucinous cystic neoplasm.
For this patient, it was inconclusive. Finally, this patient was taken up for median pancreatectomy, and the report came as oligocystic serous cyst adenoma. And I'll just show you a few cases of typical mucinous lesions for the residents. So this is a unilocular type of cystic neoplasm where you see thickened wall plus coarse calcification in the wall. So sometimes it can have a multicystic appearance. And when you see thickened walls with soft tissue, you can consider the possibility of mucinous cyst adenocarcinoma. But remember, pseudocysts could have overlapping findings. So this is one of our patients. The lesion had thick wall, some organized contents, some in the wall, something inside it, and there was no documented history of pancreatitis, but it turned out to be pseudocyst. So remember, there could be overlaps with unilocular type of mucinous cystic tumors. So this is another patient, 60 years, who came to us with a solid cystic lesion in the head of the pancreas, and there was no dilatation of CBD, no PD dilatation, and we can always refer the chart, go by the age. So 60 years, solid cystic lesion, it's mucinous cyst adenocarcinoma, and that was the diagnosis we entertained. The patient underwent EUS FNA. Any from the US findings, like, you know, can anybody give the diagnosis? This is of course a solid cystic lesion, and I would say that in such a scenario MR would help, because MR would show the hemorrhagic contents and the blood fluid level, and this turned out to be solid papillary epithelial neoplasm. For the residents, Aunt mini lesion, what is it?
Next person can comment.
So we already...
What you see here is you can see the appearance and central calcification. So what the
Sunburst appearance.
in which condition?
SC and we have sunburst.
So it's typical, so sometimes it can be large, it can be multiple. And next person, so what is your diagnosis here? So our own resident, maybe he's seen the images. Quick, come up. Yeah, I think the clue lies here, absence of right kidney with a lot of cyst and multiloculated lesions in the tail region.
So
Yeah, this is VHL. So this is another patient, and here you can see the right kidney as well with cysts as well as with renal cell carcinoma. So what is the finding here, out of the box question, but then what do you find in the brain? Hemangioblastoma. So in pancreas, you could get cyst, microcystic adenomas and neuroendocrine tumors. So 60-year-old male patient, what you see here is dilated main pancreatic ducts. What's your diagnosis?
IPMN.
Yeah, because this image I think is explanatory. So I think you have to look for something very critical, like, you know, if you come across, we have to look for something very critical if you come across. So what do you see here within the dilated duct?
Neural nodule.
Yeah, yeah, and what does this image show? Yeah, this is EUS showing a papillary lesion, and Doppler's diagnostic if it shows vascularity, and in fact it would show more lesions than what we pick up on CT or MRI. So next case, 70-year-old male, again this is a cyst in the head region. I would just show the clinical, the final HPR. Any guesses? Yeah, this is branch duct with gastric type epithelium. So if you see a branch duct with solid components, you can make the diagnosis of an invasive tumor along with that. So another entity is combined IPMN with invasive carcinoma in the head region. So this is one of our recent cases, duodenum, ampulla. This is a main pancreatic duct, and this is an invasive tumor. So this is an interesting case, and this 40-year-old lady came to us, and this was an imaging finding. In this context, I think you're very correct. So this is actually the levels. I have shown you the CA99 levels, so that's a clue to the diagnosis. And then In fact, like
it's very difficult to differentiate preoperatively between CCP versus IPM, and here most of the diagnosis comes after surgery. And I think it's a report from Lakeshore, and we have also reported it's a rare entity where in our patients it's very difficult to identify preoperatively. Yeah, usually it's diagnosed during surgery or in the final HPR. Once you open up the duct, you will see papillary lesions in the duct and calcifications.
You can make a diagnosis during surgery. That
Yeah, correct.
you can plan other price or
Correct.
CCP patients are now immune to develop IPM and vice versa.
Yeah, correct. But in the context of radiological evaluation, it's very difficult to say upfront whether duct dilation is because of mucin or is it because of CCP. That's the clinical challenge.
So this is coexistence of both the conditions, and which came first, the hen or the chicken, we do not know. And again, an Aunt Minnie lesion for the postgraduates. So whenever you see such hyper-enhancing lesions, diagnosis should be neuroendocrine tumor. She was a staff with us, and this was a venous phase scan. The portal vein was displaced anteriorly, it was stretched, and you could see that the SMA was lying by the side of the tumor, and the tumor was adherent. This was a very difficult resection. The report is NET grade 2 head of the pancreas. So hyper-enhancing lesions, I think you should shout out with the diagnosis of neuroendocrine tumor, and they're long-standing. They cause atrophy of the distal pancreas, as you see here. And this is one of our patients. This is a proven neuroendocrine tumor. She presented with a large mass, and then whenever the lesion is large, but then you can appreciate the enhancing components as well as it becomes a little heterogeneous. There are a lot of liver lesions as well. Proven neuroendocrine tumor, non-functioning. And Dr. Prakash to add on to it with the management.
No, in neuroendocrine tumors, the management, even in metastatic setting, should be aggressive. We should plan out, we like to assess the liver lesions and metastasis by, of course, by a daughter PET scan, and then plan the treatment. This patient may require sequential surgeries to maybe first to tackle the primary, then to, if it is confined to right liver, maybe a portal vein embolization. We should plan even stage resection, and we should be managing it aggressively.
So in fact, this patient underwent portal vein embolization, and there was hypertrophy of the left lobe, and later underwent right hepatectomy and had a very long disease-free survival. So as has been pointed out, this is an investigation modality of choice to detect distant metastasis, and if the lesions are DOTA-AVID, then this lutetium therapy can be considered as a treatment option when all the other surgical options fail. And moving on to de novo pancreatic cancers. So this is again an incidental pickup where dilated duct was detected in the distal pancreas. There was a stricture. We could not we could not identify a mass over there. She underwent a distal pancreatectomy, and this is pan-in with focus of invasive malignancy. So this is a red flag which should be picked up and managed accordingly. And about the usual PDAC, pancreatic ductal adenocarcinoma, this appears very hypodense because of the predominant mucinous content. I think 5 more minutes and I'll rush through it. And then about the resectability, I think the anatomy has been dealt with, and this is the gastrocolic trunk which Dr. Unikrishnan has shown us. And this case presented with obstructive jaundice, and what you see here is the SMA, and you can see tumor all around. So we call it encasement when there is more than 180-degree contact with the vessel. And this is SMA with the initial genital branches. They were all encased by the tumor, so making it overtly unresectable. So, and this is another case of ours. I would call it as a borderline resectable lesion. So here the artery was fairly free from the lesion, but what you can see here is tumor extending to the retroperitoneum going into the transverse mesocolon. And though the arterial side was fairly all right, this is what the venous reconstruction images shows. This is the proximal SMV, which is narrowed. And making it borderline resectable rather unresectable. So this is the NCCN resectability criteria that is usually followed for resectability based on the degree of contact of tumor with the vessel. And this is another case where you see a lot of collaterals. This is Doppler showing the collaterals, and this is the obliterated segment of SMV. So collaterals would make the lesion inoperable. And this is the image showing the different patterns of involvement of tumor. And this is a portal vein. You can see that here there is a fat plane. So smooth narrowing with normal caliber, unilateral narrowing, bilateral narrowing. And this is what happens if there is severe narrowing with a lot of collaterals. And tumor mimics, so postgraduate, like, are you taking this up? Alcoholic with abdominal pain and vomiting, and
Clue has come into tumor mimics.
So this is a typical groove pancreatitis where you see a lot of soft tissue. Actually, there is a lot more soft tissue over here. You can observe that the patient has got gastric outlet obstruction. In addition to that, there's some pancreatic duct dilatation, changes of obstructive pancreatitis. There are some changes in the groove as well. Often the radiologist is the first person who should make a diagnosis of groove pancreatitis, and then it should be confirmed by other tests. I would say that, like, if you're able to pick up some cystic lesions in the duodenum, either in CT or on US, then that makes a diagnosis a lot more easier. But sometimes you may not be able to find it out. So another mimic I would say is this condition. What is this condition? You see a focal lesion, you don't see the dilated duct. Autoimmune, where you see some halo around the pancreas. Again, a difficult diagnosis to make. And the ductal system may be attenuated. You can appreciate the halo, not always. The serum lab parameters may be contributory, but not always. And however, the response to steroids, confirms the diagnosis. So trauma, a bicycle handle injury in a 9-year-old boy. So typical site of transection and neck region with a pseudocyst, and this is type 4 AAST, and was managed with cystic gastrostomy, and this is follow-up CT showing total resolution, but the distal pancreas is totally atrophic. Extraosteal lesions are a mimicker. So any takers? Multiple low density areas, glue, low density tuberculosis. So, and then you should always remember that lesions from outside can involve the pancreas. This is adrenal cortical carcinoma. So now I'll just rush through 2 of our interesting cases. And this is a 30-year-old lady with abdominal distension. Rare, but still like something rarer than that. Yeah, I think someone has come up with a diagnosis. Who said that? So this is a case of lymphangioma where you see multicystic low density areas all around the pancreas, extending to the retroperitoneum as well as to the mesentery with vessels through the lesion. She underwent multiple resections, and this is a coronal and the sagittal image showing the lesion, and this is going to be our last case for today. A 9-year-old female with an abdominal mass. Let's see who gets it right. wanted to show a case of pancreaticoblastoma, but I couldn't get any image. It's not a very uncommon entity. Actually, this is common. So this is what the histopathology showed.
Yeah, the message is SPEN could be malignant also. We had a patient with bilobar liver mets and SPEN recently, which was managed, and she's disease-free now. Yeah, but metastatic when they presented.
So that finishes, and I think we have shown you a small portion through this, and I thank Ramesh sir for the opportunity given. So thank you, audience, for your participation.
That was really lovely, Dr. Tara. Thank you very much, and thank the Chair for participating actively and the audience as well. I just wanted to mention that I did request for the names to be left into the into all these scans, but you must realize that in all our presentations, we must hide the names of the images of. We can describe the age, we can describe the time, but not the names, and that's something that we all should take notice. I'm sure the radiologists do it all the time, but this is just a lesson for us. Thank you very much once again.
After that interesting session, let's move on to the next landmark article session where the residents are actively participating. And we have 10 trials to discuss, and each resident will present his portion in 5 minutes, and the discussant will discuss the same in 4 minutes. And I call the first pair to present the waterfall trial, Dr. Rajiv Joshi, and the discussant is Dr. Vipin. I'm sorry, to chair the session, I call upon Dr. Sudhindran, Dr. Sajeesh Sahadevan, and Dr. Subhash R.
Maybe we should have some really smart and sharp presentations by our residents so that further discussion can be equally, active.
Good afternoon. So I'm Dr. Rajiv Joshi. I'll be presenting on waterfall trial, aggressive or moderate fluid resuscitation in acute pancreatitis. So by design, it is a multi-centric open-label parallel group randomized controlled superiority trial, unblinded to both patients and investigators. Patients are enrolled from those presenting to ED less than 24 hours from pain onset and less than 8 hours from diagnosis of acute pancreatitis. Regular physical and biochemical assessments at 3, 12, 24, 48, and 72 hours were conducted. Clinicians were able to provide further fluid boluses, seize fluid, or change the rate based on certain goal-directed points at these times. It was a computer-based central randomization. Total 744 patients were required to detect a 10% point difference in development of moderately severe or severe acute pancreatitis from 35 to 25% incidence. Independent data and safety monitoring board consisting of clinical pharmacist, cardiologist, and gastroenterologist were appointed. 3A priorized stopping rules were the p-value showing no difference at first and second interim analysis. Second is a clear harm demonstrated in one group, and third is a slow recruitment rate. This was set in 18 centers in 4 countries across Spain, India, Italy, and Mexico. The study happened between May 2020 and September 2021. The inclusion criteria were more than 18 years of age and patients having acute pancreatitis as defined by revised Atlanta criteria with 2 or more of typical abdominal pain, lipase or amylase more than 3 times upper normal limits, or evidence-based acute pancreatitis, imaging-based. And the exclusions were those with moderately severe or severe acute pancreatitis at baseline, having shock, respiratory failure or renal failure, with cardiac failure, NYHA grade 2 to 4, electrolyte abnormalities, chronic pancreatitis, chronic renal failure, DCLD, and severe comorbidity with life expectancy of less than 1 year. Total 676 patients were assessed and 249 were randomized, 122 to the aggressive group and 127 to the moderate fluid group. The baseline characteristics of aggressive and moderate fluid resuscitation group are relatively balanced over age, sex, gallstone, acute pancreatitis, SIRS, hypovolemia, median BMI, median urea, creat, hematocrit, bicep score, pan-promise score, and Charlson comorbidity score. The aggressive fluid regime consisted of 20 ml per kg bolus followed by 3 ml per kg infusion for 48 hours if oral feeding tolerated for more than 8 hours. Then further 20 ml per kg bolus was allowed if the urine output was less than 0.5 ml per kg per hour or the systolic BP was less than 90 mm of mercury during the assessments at 12, 24, 48 and 72 hours. The moderate fluid resuscitation started at 10 ml per kg bolus only if hypovolemic and followed by infusions at 1.5 ml per kg per hour for 20 hours if oral intake tolerated for more than 8 hours. Further 10 ml per kg bolus is allowed as per the intervention group above. And management comment to the both groups are that the lactated ringers were used and the fluid rate was able to be reduced or stopped if evidence of overload was seen. And oral feeding at 12 hours started if pan-promise score was less than 5. Outcomes which are decided were primary outcome being occurrence of moderately severe or severe acute pancreatitis defined as meeting at least one of the following criteria on the revised Atlanta classification. That is local complications, exacerbation of the pre-existing or the coexisting condition, creatinine of at least 1.9 mg per dl, systolic BP of less than 90 mm mercury despite fluid resuscitation, and a ratio of PaO2 by FiO2 of less than 300. So comparing these, in the primary outcome, in aggressive category, 22.1% patients had moderately severe or severe acute pancreatitis, whereas moderate fluid resuscitation had 17.3. The selected secondary outcomes are severe pancreatitis, local complications, persisting SIRS, ICU admission, respiratory failure, persisting organ failure, or death, and the trend was more towards moderate fluid. The safety outcome was fluid overload, in which 20% aggressive fluid resuscitation group had fluid overload and only 6.3% in moderate group. So this study was stopped by the Data and Safety Monitoring Board as significantly worse results with respect to safety outcomes in the aggressive resuscitation group, which were not balanced by any trend towards improved outcomes. So in author's conclusion, in acute pancreatitis, aggressive fluid resuscitation as compared with moderate fluid resuscitation for the treatment of acute pancreatitis led to a higher risk of volume overload and did not show benefit in the disease-specific outcomes. The pros of this trial are it is randomized, multicentric, there was no loss to follow-up and intention to treat analysis, relatively balanced baseline characteristics and clear protocol for fluid administration and pre-specified definitions, standardizes outcome assessment and improves internal validity. Excellent focus on safety outcomes given potential harm shown by high volume fluid administration. And cons were 86% of the patients were from Spain, it was unblinded, and given trend towards benefit of moderate fluid resuscitation with respect to the primary outcome, early cessation may have prevented study reaching a significant threshold. And fairly significant exclusion criteria was there. The patients randomized have mild pancreatitis without significant comorbidities, and it is uncertain if fluids prior to randomization were administered or not. Thank you.
It was a nice presentation and it's covered most of the points in this. But a couple of points I want to stress on is that even though most of the patients were from Spain,
yes,
there are multiple centers in Spain which recruited the patients, not just one single center.
Yes, sir.
So this is in fact a multi-center trial itself. And another point is that this was blinding of this would not have been practical. Blinding of investigators as well as the patient would not have been practical. As
yes.
They need to intervene at each step.
Each step they have to be interviewed and then management to be
Yeah,
changed.
otherwise those are a very well conducted, very well conducted study. But the only problem is the initial patient they wanted to enroll was around 744 patients. So
yes,
the endpoints the investigators chose, that was the presence of severe pancreatitis, or it was very clinically relevant, but differences in those could not be assessed because of the low recruitment rate.
Yes.
Was it not?
They had to stop it
Yeah,
in
they
between.
stopped previously.
I think the main issue is the inclusion criteria. We're talking about mild pancreatitis.
Yes.
You know, so where the mortality is like less than 2%. So normally, at that particular time. So the criteria would have been more, it would have been more useful had you been studying on severe pancreatitis or moderate severe
Yes, sir.
pancreatitis when they present like that. And that is the biggest problem. So here, the end point is how much of this mild pancreatitis end up having severe pancreatitis. I think that is a little bit of. So for the poor PGs, I mean, this is suppose a superiority trial. What are the other trials, other sort of trials? Non-inferior. What is non-inferiority? What does it mean? If it's already proven, you don't need to do another trial, right? Superiority, non-inferiority, what is the other one? Third one? Equivalence trial. So basically, equivalence trial you do when you're you're comparing a drug with a placebo or something like that. I mean, a drug with another generic drug. So obviously, they can only have equivalence, can't be. So superiority is particularly when you do compare with the placebo. It has to be superior, there's no point. So this was a superiority trial, which again itself is a little bit of it is a good thing, but then if you have a superior trial, the number of participants required is much higher. Much more. Non-inferiority means it can be same or better, which is what most of the trials are doing. So that's important to note.
Yeah, sir was mentioning about the acute severe pancreatitis, but there are a lot of logistic issues when you take severe pancreatitis also, because when this waterfall trial was prepared, they actually during their initial discussions they were trying to include all kind of pancreatitis and a comparison across the different type of pancreatitis. But the problem is always when there is a severe pancreatitis, actually the treatment regimens changes, because it is usually the multidisciplinary team which will be managing the pancreatitis part. So just looking at one particular point of fluid resuscitation alone may not be that much possible. So that might be the one reason why they haven't included that part. But whatever it is, as sir was saying, so it is the most important thing that the PGs should understand. It is mainly the goal-directed therapy that should be the aim in acute pancreatitis. So whether it is, you call it aggressive or moderate or whatever it is, it should be something like a goal-directed thing. And this thing has shown that there is not much advantage with the aggressive thing, rather than that it produces more of problems. So it should be a moderate goal-directed therapy that should be the treatment protocol for acute pancreatitis. Yes, sir.
Thank you for this presentation.
Thank
So
you,
there are two, three, important points in this paper. One is how many patients required boluses of 20 milligram when they could not achieve the hydration, adequate hydration. So is that mentioned in this study? How many patients required additional boluses of 50 ml per kg body weight per hour?
Yes, sir. Out of this 122 in the aggressive group, around 30 required boluses again. And in the moderate group, most of them were not hypovolemic, so they did not require.
No, we are looking at patients who actually went on to develop hypervolemia or overhydration, right? So that is our criteria when we are looking at. And here the additional boluses may be contributing to that. So when we look at the spectrum of the pancreatitis, the mild pancreatitis obviously will tolerate this hit much better, because to begin with, their physiology is not as disturbed as in moderately or severe. So those are the patients. But these are also the patients where you need aggressive hydration to minimize the organ dysfunction. So I'm not sure, whether we can actually conclude from this trial that, they have looked at 3 hours, 12 hours, 24 hours. So can we combine at that time when we have this initial fluid which has been given to take care of this hypovolemia, and these patients who are requiring more challenges of boluses, where we can actually add some kind of inotrope which can reduce the bolus but can maintain the hydration as well as the perfusion to the organs. Probably a combination could be a study which can look into this to reduce these issues.
Okay, sir.
I think what Subhash is saying, goal-directed therapy would be you have to look at certain goals and then go for the fluid management. So the main issue is the third space loss with acute pancreatitis. That is much more in a moderate or a severe pancreatitis. So that is where you need to go and give all the fluid. But in the mild, as soon as somebody comes with mild pancreatitis, it's probably not wise to go and give him huge amount of fluids. That is what this trial is showing. So which is where Subhash pointed out, you still have some things to look at rather than aim for this ml per kilogram, that sort of a thing, So, I mean, nowadays people talk about, IVC volumes and those sort of things. There's so many things. Simple CVP volume is good enough. So, thank you.
Thank you.
I call upon the next presenter, who will present the PROCAP trial, Prashant Venkatesh, and the discussant is Dr. Prasad.
Good morning. I am Prashant Venkateshan. I am going to present the PROCAP trial, a procalcitonin-based algorithm to guide antibiotic use in patients with acute pancreatitis. This was published by Professor Ajit in 2022 at the Lancet Journal of Gastroenterology and Hepatology. Acute pancreatitis is an inflammatory disorder of the pancreas, where a majority of the patients have a self-limiting systemic inflammatory response, where antibiotic therapy is of no use usually. However, a subset of the patients have severe acute pancreatitis, which is characterized by pancreatic necrosis, and when infected might need antibiotics. The aim of this study is to test the hypothesis that a procalcitonin-based algorithm to guide starting, continuing, and stopping antibiotics, which might lead to a reduced antibiotic use in patients with acute pancreatitis. This study was a pragmatic, single-centered, patient-blinded, randomized controlled trial conducted at the Manchester Royal Infirmary, UK. The inclusion criteria which were taken into account was age more than 18 years. The diagnosis of pancreatitis was made with the presence of 2 out of 3 of the following criteria: clinical criteria of abdominal pain, increased serum amylase lipase values, and characteristic imaging findings of pancreatitis found in CT, MRI, or ultrasound. And the pancreatitis was graded into mild, moderate, severe based on the modified Atlanta classification. And exclusion criteria were age less than 18 years, comorbidities which require prolonged antibiotic therapy like infective endocarditis, severely like immunocompromised patients, or patients under immunosuppressive therapy, and patients who have undergone previous thyroid surgery. 369 patients were assessed, of which 109 were excluded, 260 were taken into account, and randomly and randomized into 2 groups, 132 into the PROCAL guided care and 128 into the usual care. In the PROCAL guided care, PROCAL was tested on days 0, 4, 7, and weekly thereafter, or if there was any like untoward incident. And the PROCAL threshold level was taken as 1 nanogram per ml. However, there was one clinician override function where the clinician could give or stop antibiotics contrary to the PROCAL results. This is the flow chart. And the outcomes studied were, primary outcome was studied was antibiotic use. A variety of secondary outcomes were studied, like mortality, days of antibiotic use, clinical infections, and various other factors. And when we saw the results, the baseline demographics of both the groups were similar, and there was no significant differences in the distribution of the severity of pancreatitis. Here you can see the demography and the distribution of mild, moderate, severe is similar in both the groups. However, the usage of antibiotics and mean number of days of antibiotic use was significantly lower in the PROCAL guided care. Approximately 45% only had antibiotics in the PROCAL guided care, whereas 62% had antibiotics in the usual care. And there was no significant difference between the groups in respect to the other secondary outcomes, especially the rates of intervention. So, the use of the procalcitonin algorithm significantly decreased the probability of being prescribed an antibiotic without an increase in the infections or length of hospital stay. Usually, the decision to start antibiotic it is difficult and taken by the junior clinical staff sometimes. So, an easily accessible test that is clinically viable for decision making has a clear role, which can decrease the unnecessary and harmful overuse of antibiotics. Procal seems to tick all the boxes. The limitation of this study, however, is it's a single center study, it's a small sample size. Too many secondary outcomes were taken into consideration. The majority of the cases were mild pancreatitis, approximately 60 to 65%, and in 24 instances, the clinician override function was used, where they took the decision contrary to the Procal result. This can reduce the power of the study, and 10 to 15% of the patients had been treated elsewhere and then came here. So some of them were already on antibiotic treatment. So that could be a confounding factor. And usually the aim of any antibiotic regimen it is to reduce the hospital stay and decrease the infections. However, it was equal to the other group. And renal dysfunction, which can cause increased Procal, was not taken into consideration. So in conclusion, the PROCAP randomized trial found that a procalcitonin algorithm reduced antibiotic use without increasing infection or harm in patients with acute pancreatitis. Thank you.
Good morning. This is an interesting study considering like it's a randomized control trial, but there are limitations already as mentioned. It's a single center study because there are limited number of cases. But when we look at the sample of the cases, almost more than 50%, almost 60% in the procalcitonin group were mild acute pancreatitis, and in another group only about 55% again are mild acute pancreatitis. So is antibiotic really needed in a mild acute pancreatitis? There is no evidence as such. It is only in a case of suspected infected necrosis there is a need for antibiotics. So here the sample almost more than 50% are mild acute pancreatitis where you really no need for an antibiotic treatment. That is the issue with this. And again, there are control groups, they are given antibiotics almost for 14 days, not in a procalcitonin group. And the other thing is the patient is alone blinded and the research team is not involved in this evaluation, but still they will come for when there are the cases for principal investigator were there, they will come and assess the case, or if there is any request to that team, they will also come and assess this case. And the other thing is the period of study. This is during the time of COVID time. There are some patients who are actually were given antibiotics because of the because of the COVID severity. So how much is it reliable? Again, is a question mark. Thank you.
One doubt regarding this study. You're telling that procalcitonin guided will reduce the use of antibiotics.
Yes, sir.
Could we rely the procalcitonin for infections? Because if it's a severe pancreatitis, procalcitonin will be increased with the cells associated with it. So there will be again an over usage of antibiotics.
Procalcitonin,
so it is cleared in that study.
Procalcitonin usually it is used to differentiate between inflammatory etiology and infective etiology. CRP is raised in both, but Procal is usually raised only in infective, especially bacterial etiology. So that is why.
In majority of pancreatitis severe, we find that this procalcitonin will be increased. I'm not sure.
There is a threshold.
But the advantage of procalcitonin, as what they say, is so you just imagine a clinical situation of pancreatitis where the patient presents with abdominal pain. So because of the inflammation itself, the patient will have some amount of fever. So there will be leukocytosis. If you look at CRP, it will be elevated. So in this situation, whether the fever, the CRP, elevated total counts, whether it is really due to the inflammation of the pancreatitis or there is an underlying infection, so that is in question. So that is when especially at least the junior people will be in doubt whether to start with an antibiotic or not. So they are saying that maybe in that specific situation where you look at Procal, it will be elevated only if there is an underlying bacterial infection. So if it is only the features of fever, leukocytosis, CRP elevation and everything is due to the pancreatitis inflammation itself, then there won't be a Procal elevation. So if there is an underlying infection as well, there will be a Procal elevation. So you can start on antibiotics in situation where these features are there along with a very high Procal. So if the Procal is normal, then there is no need for antibiotics. That is what they are aiming at.
Yeah, but again, I think as Sajesh was saying, 1 is actually a pretty low number. We find it very, very commonly raised. So usually people say 5. If it's less than 5, it's less likely bacterial infection. More than 5, it's bacterial infection. That is a probably better cutoff. So does the thyroidectomy actually decrease the procalcitonin level?
It might be a confounding factor. That is why they have eliminated that, because it might come, because even thyroid can produce a procalcitonin.
It's interesting. I think most of the studies, what it has now shown, is not for starting antibiotics. It's actually for stopping antibiotics. That's actually much more useful. That's the other thing I wanted to ask you. So if they were already on antibiotics, how did procalcitonin guide it?
In day 0 of admission, they will take the procal.
Yeah.
If it is less than 1,
they'll stop it.
They won't continue the antibiotics. But in 24 instances, they have that clinician override rule which was used. So that might be a.
So what is the pragmatic trial? It's a pragmatic randomized control. What is that? So pragmatic means practical. Essentially, exactly what you were saying. That is, the clinician has got a significant control over the thing. So if he feels that, he needs antibiotics, but the procalcitonin is still low, he can still antibiotic, and vice versa. If it's high and he doesn't feel antibiotic is not required, he can actually stop it. So it's a clinician override. So it's a practical trial, which is actually very, very important these days.
Dr. Sudhi, in that case, in a pragmatic trial, if majority of the patients, more than 50%, have a clinical override, then how do you infer?
It's only 24 where, how many
not in this.
Out of 128?
Not in this. I'm saying suppose it is 50-50, how do you get the inference?
Yeah, that makes it difficult, because then finally again it will be the intention to treat trial. That's what you look at. So, yes.
They had started looking at 0, 4, 7 and then subsequently weekly. So it will be interesting to find how many patients within 7 days were started on antibiotic based on procal value, because you don't expect these patients to have infection in the first week of the pancreatitis.
Actually, the data of how many started, that is not, data of how many were started at what time, that was not available.
So that is why, you have those 24 overrides.
Yes,
because even if the procal was, rising in the first 7 days, the clinician did not think it was because of infection. Probably that is.
Yeah, because still the antibiotic use was less. So despite that override, the antibiotic use was less.
But actually, the override happened on either ways. So sometimes when the patient condition deteriorated, even when the procal was normal, the clinician started on antibiotics, and there are some situations where the clinician feel that the patient is okay, and even if the procal is high, they haven't started. So
I think procal
it is on a
clinical condition.
Yeah. In 19 patients, procal was low and they started antibiotics. In 5 patients, procal was high, then they stopped antibiotics.
So it is the override is on either ways.
And they have done an FNAC assisted E. coli, the bacteria was in 54 patient procalcitonin group and 39 non-procalcitonin group. That was their finding, clinical situation in FNA.
Okay, thank you.
Thank you, sir.
The next presenter is the Propatria trial presented by Sri Kumar, and the discussant is Dr. Jazeel.
Good afternoon, one and all. I'm Dr. Sri Kumar, here to present on Propatria trial, trial done by Mark Besselink and Dash group of pancreatic study group in 2008 Lancet. Infectious complications are a major concern in acute severe pancreatitis, with almost 30% of mortality with necrotizing pancreatitis. Infection commonly is due to translocation of bacteria and as well as mucosal barrier failure. There have been studies that is done to prove that antibiotic prophylaxis has no benefit in severe pancreatitis. However, probiotics have shown some benefit, especially in elective abdominal surgeries as well as mild pancreatitis, but the evidences are few. So this trial was a randomized double-blinded placebo-controlled trial with all first episode of acute pancreatitis was included, and patients after pancreatitis after ERCP, suspected malignancy or sepsis or infection due to a non-pancreatic cause, immune deficiencies were excluded from the study. Severe pancreatitis was predicted based on Apache 2 score, modified Glasgow score, or a CRP of more than 150. The randomization was done within 72 hours, and it was a computer-generated permitted block. And a separate team was there to monitor the adverse events once the treatment was started. The study product contains of 6 different strains of probiotic along with the cornstarch and maltodextrins. Each individual strains were selected based on their ability to inhibit the growth of pathogen, which were cultured from an infected necrotizing pancreatitis in vitro. And the placebo had cornstarch with maltodextrins. The drug was given through an NJ tube delivery twice daily for a maximum of 28 days, and if there was any delay in the NJ tube, it was given orally, and it was stopped only when there was an evidence of infected pancreatic necrosis, and there was no antibiotic prophylaxis given unless when ERCP was indicated for biliary pancreatitis. CECT was done after 7 days, and based on the culture, infected pancreatic culture, none of the probiotic organisms were found in that, and the endpoint was assessed at the admission as well as on 90-day follow-up. The primary endpoints included infected pancreatic necrosis, and a positive culture was mandatory, either surgically or while drainage. Bacteremia, in case of a non-pathogen, 2 cultures were required: pneumonia, urosepsis, and infected ascites. Secondary endpoint included mortality, need for surgical intervention, intensive care stay, use of antibiotic, multi-organ failure, and abdominal complaints. It was an intent to treat analysis with 732 patients were initially assessed with 434 excluded, and the final analysis was done for 152 in the probiotic group and 144 in the placebo group. The baseline characteristics matched. However, there was a non-significant increase in the organ failure before randomization in the probiotic group with 9 versus 5, and also multi-organ failure of 5 versus 1. And even the 30% pancreatitis necrosis was more in the probiotic group. All but 5 patients were treated within 72 hours. Or during the course of treatment, 2 patients had complications with one had a ruptured cecum with ischemia, and other had a small bowel ischemia. And based on review of studies, there was no relation between this, hence the study continued. On assessing the primary endpoints, it was comparable with the relative risk of 1.06. However, in the secondary endpoint, the mortality was almost 24 in the probiotic group versus 9 in the placebo group. And even the organ failure during admission was high in the probiotic group. Bowel ischemia in assessing showed that 9 in probiotic had bowel ischemia either in autopsy or surgery, and all of them had early onset of multi-organ failure and requiring vasopressor support. And all of them had a CT prior which showed no evidence of any mesenteric ischemia, and also in 5 out of the 6 autopsy, there was no evidence of any occlusive ischemic disease. So this is a chart with only 1% survived among that 9 with who had no vasopressor support, and it's a 22-year young male. On discussion, this study, the rate of infection matched another German study which was done for antibiotic prophylaxis in severe pancreatitis. And there have been studies which has proven probiotic is having no adverse events in a healthy volunteer. However, when done in 90 critically ill as well as PICU children, there have been non-significant increase in septic complication in the probiotic group. And some previous randomized trial in pancreatitis showed in 45 patients between mild and severe, there was mild decrease in the infectious complication. However, in 62 patients by the same study group when tried to do, they could not reproduce the result. Discussion is probably that there is more chance of non-occlusive mesenteric ischemia in the critically ill patient because of the decreased mucosal blood flow and because of the protease action. And on top of that, there's increased oxygen demand with local inflammation because of the enteral feed and the probiotic. Conclusion is there's no much benefit of probiotic, and there is actually increased mortality in the probiotic group. It's no longer considered safe, especially in critically ill patients. These were some of the trials that was, this was done recently in 2021, which showed that there is decreased length of stay only was the benefit in a mild pancreatitis group. And this was a meta-analysis that showed there was no harm or no benefit. The pros are the methodology of the study, which was conducted in a good manner with blinding and randomization. The cons are mainly the organ failure and the necrosis were more in the probiotic group. And probably it should have been a symbiotic versus prebiotic, as there were the cornstarch and maltodextrin also had a prebiotic component to it. And probably the dosage of probiotic could be more. It was 10 billion bacilli that was given, but previous studies have shown 10 power 12 to 10 power 14 had a better effect with the decreased probably starch, enteral starch. Thank you.
So basically, this is like a surprising finding because nobody thought a probiotic would create a lot of mortality than the actual benefits. Because none of the studies which has been conducted before or after has shown either benefit or increased risk of mortality in any of the studies. All the meta-analysis, whichever meta-analysis you take, there is no mortality, there is no increase. So why it has happened? So the issue is based upon the study design. So their heading is like it is a placebo-controlled RCT, but in terms, it is not a placebo-controlled RCT because it is not only the probiotics, they have given prebiotics to all the patients. So along with the 4 strains, they have given maltose, and also through the NJ feed, there will be some nutrient mixture which is considered as a prebiotic. So randomized patients received prebiotic plus probiotic. The other patient received only prebiotic. So whether it is a probiotic which has actually caused the mortality or it is a mixture of prebiotic plus probiotic was the actual reason has to be identified. The number 2, they have included for a predicted severe pancreatitis. What is this predicted severe pancreatitis? What is the definition? What is the sensitivity by using Apache score more than 8, CRP more than 150? What is the sensitivity of those risk factors or those risk scores which will result in, we can say that it will go on to have a predicted severe pancreatitis. And another thing is the randomization has been done in less than 72 hours. 72 hours is a huge time from the initial onset, so that a huge amount of water must have flown under the bridge. So the proven effects of probiotics should be happened before this period. And you can see the baseline characters as Srikumar already told, the multi-organ failures before randomization, organ failure before randomization were much more higher even though they are statistically insignificant in the probiotic group. And another thing, even though the organ failure during admission at any onset is statistically significant, but I am worried about this thing, organ failure and multi-organ failure after randomization. It is actually not statistically significant. So you cannot say that the probiotics are going to create a lot of organ failures. And in any cases of severe acute pancreatitis, the expected mortality is 10%, but here we have got 11%. You see the probiotic group, there is 16%. It has actually 9 deaths more than the expected, but in the placebo groups, it is only 6%. There is 6 deaths less than expected. So there is disparity. It is not a right study, it is not the right results which we have to get. And another thing, why there is such a massive incidence of bowel ischemia, it can be explained because we have added prebiotics, probiotics, and on top of that, there are a lot of starch. So if there is a high amount of fermentable sugars, what happens is this probiotics will create a lot of acids, lactic acids and acetic acid, and that is why you will get a lot of bowel ischemia. There is an acidic environment which will result in the mucosal barrier will be gone, and because of that there will be the cytoskeleton of the bowel will disrupt, and that will result in the ischemia. And I have to conclude by saying there are 2 ethical issues also which has been pointed out later after publication of the study. The first thing is that the probiotic formula in Netherlands, it has considered as a dietary food. It is not a drug. So this has not been validated. It has not been tested in animals or human beings before starting of the study. So a quality controls were not done. And number 2, as Srikumar correctly mentioned, in interim analysis showed there are hazardous effects, there is cecal perforation, there is bowel injury, but still they have allowed to continue so that there will be the more deaths than the normal deaths happen. So it is because this proprietary trial shows the probiotics will create more mortality. It's only because of the combination of probiotic with the prebiotic. It is not just the probiotic alone. Probiotics are actually useless or they are not that useful. Thank you.
We are running late, so in view of that, 1 or 2 quick questions or comments, and then we can proceed to the next.
Yeah, later, I think later on after the proprietary trial, the probiotics have been put under a drug, this thing, when it is not a drug if it is used on a normal individual. But if it is given to a patient, it becomes a drug. So it needs to have quality control.
Yeah, just a comment, because we're short of time. Actually, the Dutch group, so not the same people, they have reassessed. There is an article that you can read, reassessment of the issues of proprietary trial. So that they have done around 4 to 5 years after that. So as Jalil was discussing, so many issues during the trial period was discussed in that thing, and probably that might be the reason for this much of adverse events with this trial. But for the postgraduates right now, with whatever trial that is available, probiotics, they have not much role in probably acute pancreatitis as of right now. Maybe there are a lot of other mechanisms which are involved. They attribute it to the right dosage and timing of probiotic which might have caused this much of issues. So you can read on to that article also, reassessment of Propria trial, Propan trial for probable issues. Thank you.
Next presenter, Mrunal, and the discussant is Karthik, and they'll be discussing the extension trial.
Good afternoon all. I'm Mrunal. I'm going to be presenting the extension trial which compared an endoscopic versus a surgical step-up approach for infected pancreatic necrotizing pancreatitis. So background, first tension trial was conducted, which was a short-term trial which compared an endoscopic and a minimally invasive surgical step-up approach in patients with infected pancreatic necrosis. It was the first multi-center RCT to do so. So endoscopic step-up approach contains endoscopic transluminal drainage, single or multiple as necessary, and if there is a clinical deterioration, then endoscopic transluminal necrosectomy. And surgical step-up approach, firstly we went for a percutaneous drainage, single or multiple, and if there was no clinical improvement, then they employed a video-assisted retroperitoneal debridement or VAD. So it was a short-term study, and outcomes at 6 months of follow-up, it was mainly clinical outcomes that were checked, death or major complications, which showed no major difference in either arm, and minor complications like pancreatic fistulas or hospital stays, which was shorter and better in endoscopic approach compared to a surgical step-up approach. So based on these results for the tension trial, the preferred treatment for infected pancreatic necrosis had changed from an open necrosectomy, minimally invasive to endoscopic approach. But it was a short-term trial, so it was extended to make an extension trial, which was designed to compare long-term clinical outcomes over 5 years. As endoscopic approach is relatively new, and short-term was inadequate to give a proper outcome. So methods, there were two kinds of patients randomized to either endoscopic or surgical approach. Tension trial employed 98 patients. After 6 months, the surviving patients continued their study into an extension trial, which went on for 5 to 7 years. The inclusion criteria were patients with infected necrotizing pancreatitis who were candidates for either endoscopic or surgical drainage. So follow-up protocol, multiple factors were checked, but most notably, they checked for pancreatic endocrine function with HbA1c, exocrine functions with fecal elastase, and quality of life with multiple questionnaires employed. So endpoints, this is a clinical outcome. Primary were all death or major complications such as new onset organ failure, incisional hernia, bleeding require intervention, perforation or of a visceral organ requiring intervention, or an enterocutaneous fistula. Secondary were individual components of the primary endpoints, which were pancreatic cutaneous fistulas, biliary strictures, wound infections, recurrent or chronic pancreatitis, exo or endocrine functions, or both, reinterventions, hospital stays, ICU stays, and quality of life. So coming to clinical outcomes, coming to the primary endpoint, there were no differences observed in individual major complications. Death occurred in total 27 or 53% of patients, but none of these deaths were treatment or pancreatitis related. So overall cause-related mortality for infected pancreatic necrotizing necrosis was there was no significant difference between either an endoscopic or a surgical approach. Next, intervention and hospital stay. So the median number of interventions did not differ, but endoscopy group required fewer drainage procedures and had a shorter median treatment duration. Coming to pancreatitis-related complications, first is pancreaticocutaneous fistulas, hereby I'll be referring as PF. So persistent PFs occurred in 4 out of 16 patients in the surgical group. All of these 4 patients underwent additional percutaneous drainages, which led to new percutaneous fistulas. All 8 patients, irrespective of the group, were total 8, and all of them had signs of disrupted or a disconnected pancreatic duct. All of these fistulas were resolved after treating with various modalities. So endocrine and exocrine pancreatic functions, in short, endocrine, 1/3 of patients in all groups developed endocrine related indeficiencies, and 2/3 developed exocrine pancreatic insufficiencies. The difference in both groups were not significantly different. And these are in line with the meta-analysis that have concluded that both of these are in line with the natural progression of infected pancreatic necrosis. Quality of life, there was no much significant difference despite having multiple interventions in a surgical group, as patients have been proven to get very well accustomed to daily adaptations concerning their morbidity. So in conclusion, between endoscopic and surgical approach, there were no major differences in the primary endpoint of mortality and major complications. Endoscopic had fewer PFs and fewer interventions, and was of value in both prevention and treatment of PFs. On the contrary, surgical groups are more persistent PFs, longer treatment durations, and more interventions. Hence, if feasible, endoscopic approach should be preferred in the treatment. Thank you.
So this is another landmark trial, and I would like to give a few points which I could make out from the study before I hand over the mic to the chairpersons. So extension trial, basically an extension of the tension trial, and they followed the patients after 6 months up to 5 years, from 5 years up to 9 years. That was probably the first flaw of the study, where they don't have actually an endpoint. They were following the patients from 5 years to 9 years, the median of 7 years. So the longer you follow up the patient, probably the more complications you might be able to identify. Then secondly, in the surgical group, after step 1, if there was not a favorable outcome, the second step they tried was either surgical intervention, again in the form of percutaneous drainage, or endoscopic drainage. Whereas in the endoscopic group, they tried another endoscopy if there was the first step was not very successful. Another thing is the both groups were actually quite identical. Any patients could have gone to any arm, either endoscopic or surgical. So in that way, that's the advantage of the study. There was no bias. So either surgical or endoscopic, any patient could have gone to any of the arms. Then about the major criteria, the major complications that the study discussed was, one, that only the new onset organ failure was considered. If the patient had an already organ failure in the first 6 months, that was not considered when they followed him after the 6 months period. And one small thing which I noticed was that the incidence of incisional hernia was also same in both the groups. I mean, if the endoscopic group is not undergoing any surgical intervention, how the incisional hernia is comparable in both the groups? They should not have any incisional hernia actually. Then, as far as the deaths were concerned, there were 7 deaths. The study totally has shown that the deaths were not at all related to the pancreatitis per se, but then a noticeable fact is that much more deaths happened in the patients who had undergone a endoscopic drainage actually, 6:1. Then reintervention were much more higher in case of a surgical group, and most of them required endoscopic drainage because probably they had they needed stenting for the disconnected duct and persistent pancreatic fistula. So one of the cause of pancreatic fistula is the surgery itself. We are putting percutaneous drains, we are making a iatrogenic tract from where the fistula is happening. So, and this pancreatic fistula actually and then needed a endoscopic drainage only in the form of a stenting as well. So whether the stenting has the endoscopic approach has decreased the pancreatic fistula, or it's a chance association that the surgical group already had disconnected duct, so there were more pancreatic fistula caused by us iatrogenically. And other points were, so disconnected duct PD was also more in the surgical group. Again, chance association or the surgical intervention caused it, we don't know. Then, so obviously the study had concluded that endoscopic approach is more valuable both in prevention and treatment of pancreatic fistula, which is obvious because there's no outside fistula that we are creating. Another flaw of the study is that quality of life was not assessed at the baseline and at regular intervals. So we don't know whether that was a flaw in the study. So I think the major takeaway from this study was that the disconnected pancreatic duct is a major cause of morbidity in such patients, and if it can be avoided and if it can be treated early, then the morbidity will be much less in such patients.
No, I think the conclusion is more or less intuitive because over the years, even in Tamrita, when starting in 2003, at those times there was a more tendency to go for surgery. Patient is not improving well, let's go for surgery. So that has now been sort of gotten over with the fact that you avoid surgery as much as possible, or postpone it at least as long as you can. Somebody is sick, you try to do some interventions and radiological or endoscopic or whatever, and then get over that crisis, and then preserve surgery for the last bit. So I think that's been the sort of treatment change which I've observed, I think.
So one important point in this study that I noted is that in the conclusion itself, it's mentioned that endoscopy is superior to surgery if it is suitable. That is one point that I had looked into this study, especially some collections and necrotic materials. I don't think that still the endoscopy route may not be very much accessible. But surgically or by the ward methods, you will be able to access any type of collections. Anywhere you will be able to track it on. Endoscopically, they had to progress still, that is what I feel. So they themselves, I don't know how they had tackled the mesentery collections and all. I'm not very sure.
They use a gastroscope to insert. They increase the diameter of the hole that they have made in the cystogastrostomy. They introduced a gastroscope and used a scope to debride.
Yeah, that I agree. Yeah. But depending upon the extent of the necrosis, sometimes it will be extending along the superior mesenteric vessels, extending retrocolic. That is what I mentioned. So all these could be accessed by surgery always, but endoscopy still will be selected in these patients.
Actually, the patients who failed endoscopic intervention, all three of them underwent surgical intervention because of these reasons that you exactly mentioned. It was not
otherwise, we all know that it will be superior because there won't be a fistula appearing after a endoscopic necrosis.
Sajishi, actually, that point is taken care in the beginning itself. They have included only patients who can undergo both. When you have a very good access from the stomach only, they have included. Those patients who don't have an access from the stomach, they haven't included for randomization at all. So that point has to be always communicated. We should not attempt endoscopy thinking that this trial is showing an endoscopic approach better for a collection which is away from which don't have a good access. Once you enter from inside also, then you have to drain from outside. That actually what we have noticed is it complicates it more. So they have that started from beginning itself. The selection criteria is those who can undergo both. There is a collection which has an access from both sides. Only those patients are included.
So that's the most important point, that only where it is suitable.
So I think, so before I wrap up, I just got one more study. Actually, it's a recent study published in January this year. Upfront endoscopic necrosectomy or step-up endoscopic approach for infected necrotizing pancreas. It's a destined study. It's a single-blinded, multi-center randomized trial. So for the postgraduates. So it says that in an optimized patient, in a stable patient, if the collection is actually encysted collection, you can go upfront for a necrosectomy, endoscopic necrosectomy. It will help reduce the reintervention rates for such patients. Thank you.
I call upon Vandana now to present the ESCAPE trial, and Dr. Raj Kamal will be the discussant.
Good afternoon. I will be discussing the ESCAPE trial. Pain is the most serious clinical consequence of chronic pancreatitis, and so previous observational studies found that early surgery could mitigate the disease progression and prevent and can give better pain control. So the Dutch pancreatitis study group conducted an unblinded multi-center superiority randomized control trial to investigate early surgery could provide a better pain control in patients with chronic pancreatitis compared to endoscopic first approach during the period 2011 to 2016. They included all patients more than 18 years of age with a confirmed diagnosis of chronic pancreatitis and dilated pancreatic duct more than 5 mm with moderate pain. They randomized 88 patients into two groups, early surgery group and endoscopic first approach. The primary outcome they analyzed was pain as per the ISBK pain score at 2-weekly interval during the follow-up period of 18 months. And secondary outcomes they analyzed was pain relief, quality of life, disease progression, hospital admissions, number of interventions, and death. The endoscopic first approach, designed by Dutch chronic pancreatitis expert panel, was a stepwise approach. First step in this approach was medical management as per the WHO stepladder pain pattern, and then if it fails, then goes for the endoscopic approach. For stone size less than 7 millimeter, the patients underwent direct ERCP without stenting, and for stones more than 7 millimeter, patients underwent extracorporeal shockwave lithotripsy. If a stenting was performed, ERCP was performed 3 monthly. And if endoscopic approach fails, then the final step is surgery. For a head size less than 4 centimeter, they underwent lateral pancreaticojejunostomy, and for a head size more than 4 centimeter, Frey procedure was performed. So of the 44 patients randomized into 2 groups, only 33 patients underwent early surgery as per protocol, and 32 patients underwent endoscopic first approach as per protocol. The basic demographic data between the 2 groups were almost similar. So on analyzing the data, the primary outcome, the pain as per ISPICI pain score, was found to be lower in early surgery group compared to the endoscopy first approach. Of the secondary outcomes analyzed, the number of interventions was found to be statistically significant, with fewer interventions in early surgery group compared to the endoscopic first approach. The other secondary outcomes like pain relief, pseudocyst formation, chronic opioid use, pancreatitis flare-up, exocrine and endocrine insufficiency were found to be similar between both the groups. The mortality was 0 in both the groups. Here we can see the ISBK pain score plot. A difference of minus 12 points was found between the 2 groups. The pain relief at the end of follow-up was found to be 58% in early surgery group and 39% in endoscopic first approach, but that was not found to be statistically significant. So to conclude, early surgery provided lower pain score with fewer interventions, and there was no statistical significant difference between the proportion of patients with pain relief in both groups. The pancreatic function and quality of life were comparable in both groups. Surgery provided a better pain control that led to short-term opioid use and that avoided the long-term opioid dependency and central sensitization and hyperalgesia. So the strengths of this study are, they used a pain assessment tool that was specifically designed for chronic pancreatitis. An expert multidisciplinary team was participated in managing the patients, and only few patients were lost to follow-up. The limitations of this study was there was a high observer bias due to the frequent pain assessment at 2 weekly interval. The patient reported higher pain score, and the follow-up period was too short to comment on the pancreatic, exocrine, and endocrine insufficiency. The sample size was small, that of the 44 patients randomized into endoscopic first approach, the 13 patients had to undergo surgery finally. And the results of this trial cannot be generalized to a low expertise centers. Thank you.
Good afternoon all. First, I'd like to comment on this study. It's a superiority trial. Here, the aim is to prove that surgery is beneficial in the early stages, early part of the disease, rather than waiting till the pain progresses. But around 90% of the patients in medical management group, they failed. And 65% of patients in the endoscopy group, they failed. And around 20% of patients had to undergo surgery. And also the endocrine, the exocrine function was not maintained. At the end of the study, almost 90% of patients had exocrine deficiency. This is what I just felt. This was like the early disease, it was not suiting, all these findings are not correlating. And my question is like, the pain score was better in the surgery group during the study, like a 2-week follow-up. But at the end of the study, there is no difference in the complete or partial pain relief. Can you explain why?
The pain relief at the end of follow-up took only the last 5 mean scores, while the pain score as such took into account the whole pain scores that was collected during the 18 months period.
Okay. So only the last part of the study is done. But there is no difference. This is also finding which is contradictory.
Yeah, can I ask, did they randomize all patients like one endoscopy and one surgery? Because what we also see nowadays, any chronic pancreatitis with stones, no matter what is the stone load and what is the stone location, the endoscopists try to, or just finger the pancreas, put in a stent. The actual role of endoscopic therapy in a chronic pancreatitis is to clear the stones. All ductal stones have to be cleared, and that's ideal only for a head stones, maybe one or two. If you have stones distant in the tail, it's impossible to reach there and clear those ones. I don't know what the randomization was done. And as he mentioned, the pain relief in a surgical group is only 58%, which is very inferior. If Dr. H. Ramesh is here, he'll be very disappointed to see patients having persistent pain after an phrase operation. So any comments on these two findings, how they randomized, what was the topography of the stones in the pancreas, and why so low pain scores in the surgical, the pain relief in the surgical group? Thank you.
All patients included in the trial, they randomized according to the randomization criteria. And the randomization criteria was that all patients with chronic pain due to chronic pancreatitis needing an non-opioid analgesia, but that upgradation to opioid analgesia, and also recurrent episodes of acute pancreatitis with flare-up episodes and flare-up free periods that lasted for 7 days in a year, or affecting the quality of life. That was the randomization criteria they had.
Sriras was asking, it is only the large duct disease. It is mainly the criteria for endoscopic treatment was mainly the large duct disease, where they have large stones, which can be approached through the endoscopies. They have included only that much of cases.
So
not small duct disease or ducts with strictures. Those kind of cases were not included. Only the large duct disease were included, and the dilated duct diseases were included.
So same question I want to ask of the exclusion criteria, whether it's strictures or multiple stones, how effective ESWL will be there? Have they excluded such cases? That's what I want to ask you. If there are multiple stones, and if there are strictures, have they excluded such cases? What is the exclusion criteria? Have they mentioned about that?
No, they excluded only patients with prolonged opioid use, pancreatic cancer, history of pancreatic surgery, history of biliary obstruction, and all such cases were only excluded. Patients with multiple strictures were not excluded from
How
this.
effective it will be for a ESWL if there are multiple strictures?
They underwent repeated ERCP
I don't
procedures.
think so. If there is he mentioned if there is distal tailed stone, how it will come out? But
So, there are a
multiple
lot of
stones.
people who do that. Even Asian gastro also, they have a lot of experience with doing that. So the question about Shiraz thing, see, we never assess them objectively as they've done the pain relief. Here, as she mentioned, they keep on repeatedly asking, have you got pain? Have you got pain? What's your pain score? So obviously, they will say, we have a unusually high result because we don't see those patients back most of the time. And we never ask them objectively, how is your pain, etc. So so we can't blame them having a high failure rate. Just that they're following the patients well. We don't do that. That's a problem.
It's a nurse who fills the data, and there was definitely a far better pain score relief than what they have shown. And I think they have mentioned they did only LPJ based on the head size. They didn't do the phrase procedure probably in all patients. Only when the head size was high, they did the phrase procedure. That also may have undermined the pain scores in surgical group.
Again, the long-term pain relief of surgical thing, it's a typical thing. Initial pain relief and quality of life is much better with surgery. Most things, for example, coronary angioplasty was a CABG. But then over a period of time, it actually equates. Mainly because the disease actually progresses. We don't see stone is not the cause of the pain. What is removing the stones may not remove the whole thing completely. What exactly is the cause of pain? We don't even know now. So the disease actually progresses, and then they catch up.
We presented the data on this in IAP in 2010. The long-term data on a phrase procedure where
the long-term scores were not inferior because when the patients come with the pain after 6 months and 1 year down the line, when we investigate them, in 40% of the, I think 30% of the patients, 28% roughly, there was a definite cause, not the stone, but other definite reasons which when tackled were relieved. Like, one patient, an ovarian cyst, multiple patients have CBD strictures and stones. When you deal with them with endoscopy, their pain scores improved. Some patients have the afferent loop obstruction. So we keep on delaying and ignoring them. If you evaluate them, a significant number of patients, you'll find a reason. Apart from being leftover stones somewhere there, we have done multiple times rephrase procedures in those patients. So apart from pancreas, there are sometimes identified reasons which can be corrected if evaluated properly.
So, Ramesh, one last comment.
I think the point which Prasad was talking about, I think the European gastroenterology guidelines talk about endotherapy first. Yeah, that's the problem. So that may be the reason offering that for all.
So that is one limitation of this study. So this study applies only in centers where there is sufficient expertise for advanced endoscopic procedure is available. So only in that setting you can compare these two things. In other settings it is not that good.
Thank you, Vandana. Thank you very much.
Thank you, sir.
For the SPAC 5 trial, I call the presenter Dinesh and the discussion Dr. Shaji.
Good afternoon, one and all present here. Myself, Dr. Dinesh from KIMS Health Trivandrum. I am going to present on SPAC 5 trial. It is a immediate surgery compared with short course neoadjuvant gemcitabine plus capecitabine, FOLFIRINOX, or chemoradiotherapy in patients with borderline resectable pancreatic cancer. It was a 4-arm, multi-center, randomized phase 2 trial. It was published in Lancet Gastroenterology and Hepatology in December 2022. We all know that pancreatic cancer is a highly challenging cancer to treat. Despite use of adjuvant therapy, there was a low resection rate and poor survival. For upfront locally advanced resectable cancer, even after adding adjuvant therapy, the 5-year survival improves gradually from 8% to 20%. With the combination chemotherapy, the 3-year survival was around 63%. So use of preoperative neoadjuvant therapy to increase the resectability rate and overall survival rate. However, there have been no proof of concept. Aim and objective to explore whether the short course neoadjuvant therapy followed by resection and then adjuvant therapy might be superior to the immediate surgery and adjuvant therapy in case of borderline resectable pancreatic cancer. Methodology, I have already mentioned that it was a multi-center, randomized, open-label, phase 2 feasibility trial. It was conducted across 16 centers in UK and Germany. Here the participants are randomly assigned to 4 groups, 2:1:1 ratio. Immediate surgery within 2 weeks of randomization, GemCap, 28-day cycle of 2 cycles they are given, FOLFIRINOX, 4 cycles they are given, and chemo-RT around 50.4 gray they are given. So here the primary outcome was recruitment rate and resection rate. Here they included R1 also. Secondary outcome, R0 resection margin, toxicity and overall survival. Inclusion criteria, the tumor factors, it includes borderline resectable mass defined by the CCT, NCCN criteria, histological and cytological proven pancreatic ductal adenocarcinoma, those who underwent biliary drainage. Patient factors above 18 years of age, WHO good performance 0.1, platelet more than 1 lakh, WBC more than 3000, and bilirubin less than 1.5 times upper limit of normal and normal renal function. Exclusion criteria includes distant mets and previous and concurrent malignancy, serious medical and psychological problem, and pregnancy and ischemic heart disease. So among 478 patients are recruited, 90 patients are randomly assigned. Out of this, 86 patients were full analysis set includes. So those only 80% underwent surgery, 90% in the immediate surgery group and 72% in the pooled neoadjuvant therapy. Among that, 68% underwent resection. Only 14% achieved R0 resection in the upfront surgery. In pooled neoadjuvant therapy, only 55% underwent the resection. Among this, only 23% achieved R0 resection. So around 70% had a positive lymph node detection. 90% in the immediate surgery group, very less in the neoadjuvant chemo-RT. Only 25% had a less positive lymph node detection. Comparing the CA19-9 between the groups, there is a significant reduction in the CA19 between the surgery group and the neoadjuvant group. so around 70 to 80%. Peri and post-operative complication, around 40 to 50% had complications, more in the surgery and chemo-RT, but there was no significant difference. The 90 days mortality rate was around 7%. Tumor response, there was no complete response among the group. Only 13% had a partial response, more in the FOLFIRINOX group, and 72% had a stable disease, both in the GEMCAP and FOLFIRINOX. So overall survival by the post-hoc analysis, so around 40% in the immediate group, but double the amount the survival is increased in the combined neoadjuvant group. And disease-free survival also around 40% in the immediate and 60% in the neoadjuvant group. Among the neoadjuvant group, the FOLFIRINOX had a highest survival, around 84%, and GEMCAP and 80%, and chemo-RT group around 60%. So overall, the event-free survival better in the pooled neoadjuvant group, in that GEMCAP and FOLFIRINOX are higher. So conclude that after accepting the limitation of small sample size and short follow-up, the SPAC5 showed neoadjuvant short course combination chemotherapy was more effective. Among that, FOLFIRINOX was better, around 85%, even though the toxicity was higher, but it was manageable. So in spite of low resection rate, no significant difference between the resection rate, the significant survival advantage was there in neoadjuvant group. These are the limitations. There was only 28% achieved R0 resection, and multi-center, it was conducted in multi-centers, so there may be a difference between the surgeon's experience and less sample size, and also there is only 1 year follow-up also there. Thank you.
It was a nice presentation. When we are talking about the strength of the study, I think it was a multi-center trial conducted as an international one. Many centers participated, even though the number of the cases being recruited was very less from many centers. But they could find out some positive side towards the neoadjuvant treatment, which has now become more and more into fashion for the treatment of borderline pancreatic tumors. But the problem with this study is that it was started as a feasibility study. They were actually looking for the safety profile of the study, whether they were even looking for whether they could be able to get the ample number of samples in future and all. And it turned out to be to bring up new informations into it. This is exactly what happened. So the sample size they started with was, they wanted to start was around 100, and they could end up only with 90. And as time went by, actually being a feasibility study, we're not able to make out proper clinical response rates, everything from that study. It is not statistically powered enough to have such data. So the problem was that even though they could prove that it is statistically, it's feasible to do that study under proper safety profile, the rest of the things are not completely reliable with such a short, such a small sample size, and with a follow-up period of about 1 year only. And they proved that the neoadjuvant treatment arms were having more disease-free survival in 1 year and overall survival as well. But as time goes by, this may not be the real picture. Just by 1 year, we may not be able to say how many patients are going to have more recurrences. If you look at the data itself, from 76% patients, 76% of the patients having overall survival, when you look into the disease-free survival, it's only 59%. So that is by 1 year time. So as time goes by, the number of patients who are going to have more recurrences, even from the neoadjuvant treatment, may be high. So to prove that, to prove against it, we need more numbers. So sample size was a major concern, and also the follow-up period was also a major concern. And one more thing is that in chemo-RT group, they have better lymph nodal negativity, and the R0 resection was also found to be better for them. But still, it didn't come to a better survival rate for those patients. So there are a lot of things that are confusing us, and even though we think that this is giving us quite a lot of idea as far as the neoadjuvant treatment is concerned, we need to have more number of patients recruited into similar studies, and then only we'll be able to have a proper data. The study is actually getting concluded saying that it may not be worth suggesting to have a bigger study because of the results that they have obtained, which I don't think is totally acceptable. And even though we may not be able to randomize patients with immediate surgery and neoadjuvant, we may have to have other subgroups. When between the subgroups, we will have to have more studies to stick on to this completely. Thank you.
Thank you. So what about the number of patients who did not undergo surgery after the neoadjuvant therapy? In all three groups of neoadjuvant therapy.
Yes, sir.
How many did not undergo
Only
surgery?
the 84% of the neoadjuvant group, they are able to restage, sir. So around 16% are not able to restage.
So I think that's one of the important messages of the neoadjuvant therapy, because the R0 resection rate was same in both groups.
Yes,
So what neoadjuvant therapy tells us or guides us is to choose the bad biology tumors. The ones that we operate on upfront will include all the groups of tumors, but the ones that are responding neoadjuvant or are progressing on neoadjuvant, we know that they are actually, either good group or bad group. And then we seed out the bad group. And therefore, you tend to get a better survival for most neoadjuvant therapies in most malignancies. I think that is one of the things. So, but generally, even for resectable tumors, I think there is no evidence that neoadjuvant is probably better in whatever ways it is.
As Shaji was saying, whatever criticism about this trial is very true, because it is just a phase 2 trial. It is not a phase 3 PACA trial. This is just a feasibility trial, as you said. But the results that came out, that was worth discussing. That is why we are discussing about that kind of a trial. And when compared to, it is a 4-arm trial, but when you compare surgery with any form of neoadjuvant treatment, they showed a clear survival advantage in 1 year. Whether that can be extrapolated when you take 5-year or 4-year, that is a different matter. But there are different trials that are coming up comparing neoadjuvant treatment to surgery alone. And most of them are showing a positive trend towards the neoadjuvant treatment. Whether it is neoadjuvant chemoradiotherapy or neoadjuvant chemotherapy alone or whatever it is, there are several other trials where they have compared gemcitabine and capacitabine in combination with surgery. And there is another trial that is about to be presented next, that is the PRIOPAN trial. So where they have compared the chemoradiotherapy with surgery. So everywhere there is a trend towards advantage to some form of neoadjuvant treatment. And clearly, any form of neoadjuvant treatment, if you take, that has got a advantage either with the R0 resection rate or with, even though it is less, or with the survival with neoadjuvant treatment, some form of neoadjuvant treatment.
Yeah, I agree with that. But
in borderline resectable,
yeah,
clearly, in borderline resectable.
Exactly. In borderline resectable tumors, I agree neoadjuvant has a lot of role. There is no doubt about it. But the only question is, as the study gets concluded, that with this study, we may not be able to suggest larger studies. That's what actually worries me. I don't think we have that much sample size or sample strength to conclude saying that we don't need any more studies. That's exactly what I meant. I have no confusion that neoadjuvant treatment has definite advantages. I also agree with that. As Sudhindra sir was saying, it selects better biology patients also. There is no doubt about that. But whether we need to go ahead with more studies, whether we need to look into this thing and finish off saying that this is a landmark study, we don't need to do anything more, that's the only thing that is worrying me. Thank you.
Thank you.
The next presenter of the PRIOPAN trial, Dr. Santosh, and the discussant is Dr. George Matthew.
Good afternoon all. I am presenting the long-term results of the Dutch randomized PRIOPAN trial, the study that compared neoadjuvant chemoradiotherapy versus upfront surgery for both borderline resectable and resectable malignancies. With the perceived benefits of the neoadjuvant therapy, such as downstaging of the disease, increasing the number of patients who receives the systemic treatment, this phase 3 trial was conducted by the Dutch Pancreatic Control Group over 16 hospitals in Netherlands, and they recruited 246 patients over a period of 2013 to 2017. The 2-year follow-up results were published on 2020. So they included pathologically proven adenocarcinoma of the pancreas, which are primarily resectable or borderline resectable tumors as per their guidelines, Dutch Pancreatic Control Group 2012 guidelines, and patients who are fit to undergo surgery and chemoradiotherapy. They excluded T1 resectable tumors, locally advanced irresectable tumors, or tumors with distant metastasis. And patients with cytologically proven N2 lymph node mets were also being excluded. So the primary endpoint was overall survival by intention to treat analysis, and secondary endpoints were resection rate, RO resection rate, disease-free survival, loco-regional free failure interval, distant metastasis-free failure interval, and they also studied the chemotoxicity in both the arms and also post-operative complications. So after randomization in the upfront surgery arm, patient after surgery undergoes 6 cycles of gemcitabine therapy, whereas in the trial arm, after randomization, an initial staging lab is done to look for the mets, and if there is nothing obvious, patient will undergo neoadjuvant 3 cycles of gemcitabine. The second cycle of gemcitabine combined with RT, 36 Gary over 15 fractions. Again, re-evaluation within 4 weeks, followed by surgery within another 4 weeks. So after surgery, they will undergo another 4 cycles of gemcitabine. So of 120 patients assigned to the neoadjuvant arm, after undergoing laparoscopy 114, neoadjuvant treatment was started in 91 patients. Of these 91, including the crossovers who underwent surgery, is 82, and 72 had successful resection. Of these, 55 had received at least 1 cycle of the adjuvant chemotherapy, whereas in the upfront surgery of 128 assigned, 121 underwent surgery and 92 had resection, and 65 received 1 cycle of adjuvant therapy. So coming to the results, the Kaplan-Meier graph shows there is a survival advantage of increased median overall survival period of 1.4 months only in the neoadjuvant arm compared with the upfront surgery arm. On further subset analysis, it favors the neoadjuvant group by reduced hazard ratio of 0.79 in the resectable and 0.67 in the borderline resectable tumors. So clearly in the neoadjuvant arm, there is a downstaging of the tumor with more T1 tumors and reduced nodal status and reduced perineural invasion and vascular invasion. And there are more RO resections in the neoadjuvant arm. So the disease-free survival, loco-regional free failure interval, and distant metastasis-free interval were all statistically significant in the neoadjuvant compared to the upfront surgery arm. Coming to the safety profile, the serious adverse events are, there is no difference between the both groups. Both groups had around 16 patients with grade 5 serious adverse events, 18 each group. So the study emphasizes there is a need for the paradigm shift towards the neoadjuvant therapy, as there is a clinically important relevant improvement of 14%, and the disease-free survival, loco-regional failure-free interval, RO resection rate were all favorable, supporting the neoadjuvant chemoradiotherapy. And also, patients had better compliance to the neoadjuvant chemoradiotherapy in the neoadjuvant arm, as 89% patients had received at least a form of systemic therapy. So the main critiques were they used a different resectability criteria compared to the NCCN guidelines where everywhere it is used, because more of a subgroup of borderline resectable as per NCCN could not be included in this group, and cytologically proven N2 lymph node mets were being excluded, but the methodology for that is not, they have not explained in their study protocol. How many patients excluded because of lack of biopsy and how number of lymph node harvested they have not provided in their supplement. Even though there is a statistically significant improvement in the overall survival, there is it's only a 1.4 month, 6 weeks advantage. And how many patients could not undergo or they had a delayed surgery because of the chemotoxicity who are potentially resectable tumors, they have not explained. Thank you.
A nice overview, Dr. Santosh. I would like to add a few points. Actually, the pancreatic cancer has been a nightmare for all of us because of the low survival rates. Because this study proved that it's a blessing actually for the patients and also the doctors who are treating, actually the survival rate is increasing. So it's a neoadjuvant therapy is the new thing. Actually, borderline resectable cases, actually we know for the last 10 years, we are all in practicing for the borderline resectable, but for the resectable cancers, actually it increases the survival is a new thing. And also this study showed that the long-term follow-up is actually required for any malignancy, such aggressive malignancy like pancreatic cancer, to say the verdict. The PREOPANC 1, that is the first part, which was published in 2020, did not show this increased survival rate. But in the long-term survival rate, it showed that it is actually 14% overall survival rate is improving. That's the best thing I found from this paper, but some limitations are there. Of course, gemcitabine was used as a chemotherapy in this study. At that time, it was already the SPAC trial has shown that the FOLFIRINOX is better than gemcitabine, but they didn't change the regimen in between. That was one flaw. Another flaw was that they only used two arms. The radiation, we don't know how much the radiation has contributed over the chemotherapy. The recent PREOPANC 2 trial has shown that neoadjuvant FOLFIRINOX versus neoadjuvant gemcitabine RT, there is no much difference. But the survival rate is comparable, means 21.3 versus 21.7. So the RT, how much RT contributed to this improvement in the survival, we don't know. Actually, they should have done a 3-arm study versus the upfront surgery, neoadjuvant chemo, and neoadjuvant chemo RT. Maybe such future trials will come with such methodology. And that's all I want to add. Thank you.
I thought your last point was there, because 30% did not undergo surgery, right? Isn't it?
Sir?
30% did not undergo surgery, the neoadjuvant arm.
So neoadjuvant arm totally, they have mentioned 16 patients after randomization did not undergo surgery.
So obviously after chemoradiation, no?
Yes, sir.
Yeah, must have been.
Yes, sir.
That's again the same point, you know. So
because of chemotoxicity, they have not specifically mentioned. After randomization, 16 patients have not undergone surgery. They have mentioned it is because of the patient's medical choice.
After randomization?
Yes, sir. After randomization.
They might have withdrawn their consent, or those kind of things can happen.
But that's too many numbers, no?
Sir, medical decision and disease progression.
Probably usually the toxicity of thing. Just get that anyway. So, but the survival analysis, was it intention to treat? I mean,
yes, sir.
did
It was intention
include the
to treat
patients who did not
analysis.
undergo surgery as well?
Yes, sir.
They did?
Yes, sir. It was an intention to treat analysis.
The problem here is it included both the resectable and the borderline resectable. That is the problem. So when you take a mix of both borderline resectable and the resectable lesion, and when you compare it to get a better survival advantage, how much it will reflect the real situation, that is what we don't know. So from so much trial, whether it is SPAC 5 or this whatever trial that is coming up, we know that there is a clear advantage with the neoadjuvant treatment for the borderline resectable. That is almost sure right now. But how much result it will give for the resectable malignancy, that is still in doubt. So that is one problem with this study.
Thank you.
I know all of you are getting tired. There are 3 more, and this is this is about the technique, the periarterial divestment. Agostino is presenting, and the discussant is Premil.
Good evening all. I am presenting at the journal on the periarterial divestment in pancreatic cancer surgery, which was published in the Journal of Surgery from the University of Heidelberg. So with the new improvement in neoadjuvant therapy for pancreatic cancer, 30 to 50% of locally advanced pancreatic patients can be downstaged successfully. But even with this successful downstaging, still the peripancreatic visceral arteries may contain active tumor cells. And in most of these patients, the true arterial wall will be not involved by the tumor tissue. So in such patients, whether we have to go for an arterial divestment or arterial resection. Both have its own merits and demerits. Arterial resection from the previous studies shown that is associated with high mortality and morbidity rates amounting to 100%, and mortality of above 20% is shown in arterial resection. But it has slightly better R0 resection, while arterial divestment is having slightly better morbidity mortality profile. The R1 resection rate is slightly higher with arterial divestment. So in this study, in this paper, they have taken like all patients who had locally advanced pancreatic cancer or borderline resectable pancreatic cancer. The patients underwent pre-op FOLFIRINOX neoadjuvant therapy, following which all patients who didn't progress during the study were taken for surgical exploration. After excluding the metastatic disease, they proceeded with the artery first approach, and the suspicious tumor tissue around the artery was taken for frozen section. And if it comes negative, they proceed with the Whipple resection with triangle dissection. And if that comes positive in frozen section, they proceed with the feasibility of arterial divestment. And if the arterial divestment is not feasible because of multiple vessel involvement or multiple site involvement or true arterial wall involvement, then they decide whether to go for arterial resection and reconstruction or no resection. So the technique here, it was a 72-year-old male who had a pancreatic cancer with superior mesenteric artery was encased, underwent FOLFIRINOX 8 cycles, following which there was no disease progression. So they proceeded with surgery, and intra-op it was found that the proximal superior mesenteric vein was involved by the tumor. That was resected and reconstructed with a graft, following which there was the superior mesenteric artery was surrounded by, encased by a tumor tissue. The frozen came was positive. So they proceeded with divestment that was done with bipolar and cautery. There was a plane between the true arterial wall and the periarterial tissue where the tumor tissue is not there. So they proceeded with that, and they could able to save the artery and remove the tumor tissue in toto. So the key issues related to the periarterial divestment in pancreatic cancer surgeries are: currently available imaging techniques are insufficient for predicting the responses to neoadjuvant therapy, and arterial involvement and true arterial wall invasion, which can currently only be differentiated via intraoperative exploration, not by the preoperative imaging. And after neoadjuvant therapy, the visceral arteries can often to be dissected in a layer between arterial wall and remnant tumor tissue, and this divestment layer must be identified by meticulous operative dissection in several regions along the route of specific vessel. This novel operative technique can avoid arterial resection. So the further studies are needed for evaluating how often arterial divestment can be achieved in a specific population of patients with pancreatic cancer with arterial involvement. Detailed, comprehensive pathological studies are necessary to learn more about the patterns of tumor invasion and the presence of safe and effective divestment planes. And technical feasibility must be weighed against direct operation-associated morbidity and mortality related to arterial divestment. And clear oncological benefits must justify aggressive arterial divestment in a multidisciplinary setting. The improved safety and oncological equivalence of arterial divestment versus arterial resection for pancreatic cancer surgery must be evaluated by clinical trials. So this is a short video showing the arterial divestment technique. It is from Tata Memorial Hospital. So here, during intra-op, there is found to be some adhesion with the SMA in the medial aspect near the origin of IPDA. So with sharp dissection, first they clip and ligate the middle colic artery for better exposure. After that, there is a tumor infiltration in the medial wall of the superior mesenteric artery, which is dissected. And before going for divestment, they took the proximal arterial control and also the distal arterial control. Following which, the IPDA area where it was involved, where both vascular clamps are applied proximally and distally, and the area involved was dissected, and the origin of the IPDA was sutured with 6-0 proline. Thank you.
Just to supplement the presentation with few points. Now, patients with locally advanced pancreatic cancer with SMA encasement are now triaged with imaging. Patients displaying, I would like to talk about two signs. Patient displaying a halo sign where the encased SMA remains fully patent and free from arterial invasion are now candidates for SMA peri-adventitial dissection. And alternatively, the string sign, which involves involving the SMA, confers a more likely case of arterial invasion. A complete oncological resection cannot be achieved successfully in those cases. So this method of divestment, this method of patient selection abandons the traditional metrics of circumferential degrees of arterial encasement to guide the surgical decisions. That is the less than 180 degree, more than 180 degree and all. So the one on the right side is the halo sign, where we can see that the whole artery is full, it is patent, there is no irregularity or narrowing of the wall. Those are the candidates for SMA divestment, even though it is circumferential abutment. And the next picture is the string sign, where there is irregular narrowing of the artery, which shows a true arterial wall involvement. So this is a novel approach. This is done following neoadjuvant therapy. It was initially described by Miao et al. In 2016. And as he said, this procedure involves surgical stripping of the infiltrated neurolymphatic tissue of the SMA, leaving behind the bare skeletonized artery. Now, in many patients, only the fibrous tissue without any viable tumor after the neoadjuvant therapy, and consequently tumor removal without resection of artery is possible without compromising the radicality. Now, two techniques are also described for this arterial divestment. That means two planes of dissection. One is the periarterial plane of dissection between the tumor and adventitia, and the subadventitial dissection, where the plane of the dissection is between the tunic adventitia and the external elastic lamina. Now, the dissection is started from a virgin area, the area where there is no tumor involvement. Then it is proceeded towards the area where there is abutment, and it is usually done as a sharp manner using a sharp scissors and a bipolar forceps. And this seems to decrease the perioperative morbidity and mortality compared with arterial resection. Now, as this technique has only been introduced recently, there are few data on oncologic long-term outcome. However, the post-op histopathologic workup supports the concept in terms of R0 resection, and the potential oncologic benefit of divestment versus no operative resection, and the equality of arterial divestment versus arterial resection must be investigated. And also, we have to look into the potential side effects like pseudoaneurysm and arterial bleeding. Thank you.
One important point I had noted in this study is that you could decide on the arterial involvement only during surgery. That is the one important thing that has come up from this paper. Because radiologically, whatever you say, there is a halo sign or string sign, you can't decide upon that. You have to decide on the arterial resection is required or do an arterial divestment at the time of surgery. But the practical application of this approach, the problem is that the authors themselves have suggested multiple frozen sections. So even if you get a frozen section positive, you could go a bit more. But still, if it is negative, we don't know whether the true R0 resection is achieved or not. That is a problem with arterial divestment. So if there is some doubt that even that neural tissue or lymphatic tissue is stiff enough, or it's difficult after post-chemotherapy, arterial resection still may have a role.
Yeah, Satiji, I agree with you that the problem with this is that going in a plane where you send a frozen and then you try to go one more layer ahead. Generally, what we have been taught or what we follow is we go in the same adventitial plane. And I would disagree slightly with you that a pancreatic surgeon should get a surprise on table in a Whipple operation that he is going with a plan that he may require an arterial dissection or a venous reconstruction. We should be exactly having a mind that probably have a difficulty in an SMA area or a common hepatic area. There should be no surprises or new checks and balances on table. We should have a good CT protocol. Yes, there is a limitation of CT to tell you exactly how much extent is involved, but definitely there should be in the back of mind. We should be prepared that we need an additional extra hand, probably a bit more instruments, bulldogs, microvascular instruments. So it should not be a surprise on table.
It should not be a surprise, but you should be ready for arterial section also. That is what I was highlighting.
Yeah, that will come by imaging, right? We need a high quality CT scan nowadays. It shouldn't be like we ignore a CT scan and then see, oh, artery is involved.
No, but that's the point, Shira. So where the radiology probably shows arterial resection if required, you can still go ahead with the adventitial, peri-adventitial thinking, and then you may get away without it, and that's the point. So
the imaging is important. The imaging is important. We can't rely completely on
Based
table
on the
because,
imaging-
because it is difficult to find out tumor invasion or infiltration by pancreatitis and all. On table, it's very difficult to differentiate whether the fibrosis is because of post-radiotherapy or it is actual tumor invasion. So high quality imaging is a must.
So imaging will tell you there is an arterial involvement. So on table, you try, instead of going for a resection straight away, you try peri-adventitial dissection. And if that doesn't work, then you go for resection.
Yeah, I agree.
That is the thing.
That's why I agree. No, but the paper writes that the imaging is not, they should be on-table assessment of the artery, but we should have a back of mind that this probably has a potential of having a vascularization.
Sir?
No, I just wanted to say that any kind of radiology after chemoradiotherapy probably will not tell us correctly about the exact involvement of the artery. So we have to look at tumor markers as well. So the biology of the tumor is also important. If CA99 has come down, then probably there is a point going in and trying to dissect even those vessels which look involved on radiology after chemoradiotherapy.
Boss.
Yeah, I was just going to say that I agree with Rajesh that everyone was saying the radiology will tell you everything, radiology will tell you nothing, especially after neoadjuvant therapy. The same vessels will seem encased. The CA99 may have fallen, but many patients have normal CA99 to start with. And then you have, even that has been lost. That avenue of follow-up has been lost. So patient is doing well, clinically well. There's no obvious evidence of collateralization or major vessel block. The vessel may be encased, but not blocked. In such a situation, exploration is the only way to deal with it. And I'm not sure any radiologist will be able to tell you one from the other.
Thank you.
Moving to the triangle operation, Jason will present, and the discussant is Dr. Deepak George.
Good afternoon, everyone. Now we have the discussion on triangle operation. So I discussed the article titled Triangle Operation for Pancreatic Head and Body Cancers, Early Postoperative Outcomes. So this was published in Journal of HPB, and the study was conducted in the Department of Surgery in Heidelberg, Germany. So coming to the background, as we know, the disease progression after the resection in the pancreatic ductal adenocarcinoma is frequent. It's approximately 70% relapse within 2 years. In that, the local recurrence and the distant metastasis is associated with poor prognosis. So in a recent meta-analysis by Tanaka, the recurrence pattern was, in the recurrence pattern, the local recurrence was a solved recurrence in 20.8% of the patients. So in that, the negative resection margin status along the posterior as well as the medial soft tissue margin reduced the local recurrence and the increased disease-free surveillance. So the negative impact of the local recurrence on the outcome warrants an effort to decrease it. So that's where we introduced a surgical technique of triangle region dissection, which is bounded by celiac artery, superior mesenteric artery, as well as the mesenteric portal axis. So, however, then the anticipated oncological advantage of the triangle operation with a better margin clearance, the expected reduced local recurrence, and a better survival has to be weighed against the risk of more radical approach. So, this particular procedure was piloted in 15 patients with an acceptable mortality back in 2017. So, that was also published in Journal of HPB. So, in our study, the aim is to evaluate the safety and the postoperative outcome of the triangle procedure. So this is an observational study in which all consecutive patients undergoing the PD triangle and the TP triangle between 2016 to 2019 was matched to a cohort of PD standard and TP standard. That was matched to a historical cohort between 2013 to 2016. So what is triangle intervention? It's a combination of two surgical steps in which the dissection, the mesopancreatic dissection, is according to the level 3 by Eno et al. And here the dissection of the nerve plexus is done around the SMA from 5 to 11 o'clock. And next is the complete dissection of the soft tissue, which includes the nerve plexus, the lymph nodes in the triangle region, which is bounded by celiac artery, SMA, as well as the mesenteric portal axis. So apart from these two, we do a lymphadenectomy, which was performed, recommended as per the ISGPS guidelines. So it's a pictorial representation of the level 3 dissection, where as the previous presenter has discussed, we do a dissection between the SMV and SMA, and we dissect the nerve plexus, and the periodontal dissection happens from the 5 o'clock to 11 o'clock of the SMA. And the next picture is the pictorial representation of the triangle area where we dissect. So here we could see the cut end of the pancreas, the portal vein, the celiac axis to CHA axis, as well as the mesenteric portal axis. So that's the triangle region where we dissect all the nerve plexus and soft tissues. So coming to the results, 330 patients were included in the study. In that, 165 underwent the PD triangle PD triangle as well as the TP triangle, and 89 patients received neoadjuvant chemotherapy. In that, 49 in the triangle as well as 40 in the standard group. In that, 266 was PDAC, 30 was periambulary, 19 was NET, 8 was IPMN, and 7 was other pancreatic pathology. So if we see the duration of the surgery and intra blood loss was significantly higher in triangle group. And if you see the 30-day, 90-day and the in-hospital mortality, it did not differ significantly. And there was no significant difference in overall surgical as well as the non-surgical morbidity between the triangle and the standard group. But the triangle group had to stay more than 2 days in the ICU. And if you see the number of patients suffered from diarrhea, it differed significantly between the standard as well as between the standard and the triangle group. So if you see the short-term oncological outcomes, the lymph nodes harvested was more in the triangle group, and this difference did not reach significance in the TP cohorts. And if you see the resection margins, the PD-R0 resection did not differ between the groups. However, the circumferential resection positivity was more than 10% more frequent in the triangle group. And if you see the margin of the resection, that is R1 direct, it was more frequent in standard PD group. In the TP cohort, the R0 was significantly more frequent in TP triangle group, but R1 was comparable. And if you see, coming to the discussion, the triangle procedure is safe and feasible with comparable post-op morbidity, but the duration of surgery is longer, intra-blood loss is higher, ICU stay is longer, and the number of lymph node harvested is higher in the triangle operation. So the complication rates, including all the surgical as well as non-surgical, it was almost similar. So it confirms the safety of the procedure in the experienced hands. But whether the extent of the resection influences survival and the health-related quality of life is questionable. The PDAC has a perineural growth pattern, as we know. So the R1 and the local recurrence are found in the triangle region. So clearing all the tissues in this triangle leads to clearance of all neural and lymphatics draining the head of the pancreas. So triangle operation is not another type of extended lymphadenectomy, but it focuses on the site of microscopic tumor spread and frequent tumor local recurrence. So coming to the limitations of study, it's a single center study, it's a retrospective study, the data on the adjuvant chemotherapy is lacking, and the study focuses on the post-op mortality and the morbidity only, and the effect of the triangle operation on the local recurrence as well as the health-related quality of the life has to be evaluated. To conclude, the PD and the TP, that is the pancreatic duodenectomy, partial pancreatic duodenectomy as well as the total pancreatic duodenectomy, according to the triangle protocol, can be performed without increased morbidity and mortality at high volume center, but it may have the potential to improve the local recurrence and the disease-free survival, which needs further evaluation. Thank you.
Thank you, Jason. It was a very good presentation. Clearly, a pancreatic surgery like this described by Anu et al. Is a morbid operation. It requires more technical skill. Clearing 180 degree of tissues around the SMA, it is done in high volume centers, but I'm not sure whether it can be replicated in all centers. So doing such a morbid operation, they say the morbidity and mortality is comparable. Definitely, the ICU stay is more, the bleeding is more, the diarrhea rates are more, even though the other parameters are comparable. Whether you require such a surgery for all these patients, because the study has included periambulary, neuroendocrine, pancreatic ductal carcinoma. So it is a heterogeneous type of, even the Inu et al., when he described the level 1, 2, 3 dissections, he described this for level 3 dissection for advanced tumors, advanced cancer. So applying this kind of a morbid resection to all the patients, is it actually necessary? And when you take the postoperative out, the specimen, the lymph node retrieval can be quantified, but clearance of the neurolymphatic tissue around the SMA, how can you compare with the two studies? That's not very clear. We can take photographs of surgeries, but whether that is a comparable, actual comparable thing, like a lymph node or something, that is also a question to ask. And after doing such a morbid surgery, whether that translates into long-term survival, have they addressed anything about that?
No, that RCT is underway, but just in this study they have just addressed the perioperative mortality and the morbidity. But from the data which was obtained, they just extrapolated the data to the short-term oncological outcome. Long-term was not studied.
So being a high-volume center, they are showing that they can do a morbid operation without much complication, but whether that translates into long-term outcome, it needs to be seen. Yeah. And after a neoadjuvant course of radiation or chemotherapy, the R0 rates may be slightly better, but have they done a different analysis of patients who have undergone neoadjuvant?
No. The subgroup analysis of that has not been done in this study, particular study.
Sorry, just a methodology question. So in these sort of retrospective studies, obviously a lot of heterogeneity. So how do you adjust for that to make it sort of nearly as good as a randomized trial? What do we do? Propensity score matching. I think that's the thing. I think they've done that. I don't know if they've done it here, but that's the thing to do. So where you match the factors that are known to influence your whatever your endpoint, and then you match them so that they both are occurring equally on both groups. And so that's a new methodology these days. You can have a large number of patients and do a propensity score match.
This study was presented just to show the technical feasibility of these kind of studies. Their long-term outcomes are actually, the results are on the way. There are a lot of RCTs and other trials are going on. Probably that will come up with better results, especially for this borderline resectable malignancy, post-neoadjuvant setting. So there is a substantial chunk of tissue resting in that area. That is between the celiac trunk, between the SMA and the portal vein. In that area, there will be a lot of tissue that will be left. So if you can remove that thing in a better way, so that will be helpful. That is the idea, whole idea behind these things. And for the triangle operation, as it was described, so it will not, it doesn't involve the periarterial divestment every time. That is actually the extended level 3 as described by et al. So even the level 3 is a triangle operation where you don't have to do a SMA periarterial divestment. You just need to remove the tissue in that region, and the R0 resection is supposed to be better in such cases when compared to those cases which are not undergoing a...
So the neck transection, where does that occur? Because in this picture, it's so much distally. I mean, can we transect as we do normally, or do you have to go further down to the SMA side to transect the neck of the pancreas?
Yeah, it has to go up to the level of SMA, if it is a pancreaticoduodenectomy. This triangle operation is not only for the pancreaticoduodenectomy. It is mainly for distal pancreatectomy and total pancreatectomy, where it is more and more applied.
Whipples, you have to go a lot more to the left.
Yeah, if it is a whipple, we have to go to the left border of the superior mesenteric artery. But mainly the triangle operation and its applicability comes in cases where there is infiltration to SMA. So in cases where we do Whipple's resection, the infiltration to SMA area, it's not that much. It is mainly in malignancies or the tumor involving body of the pancreas. Mainly in the area of body or tail of the pancreas, where we have to do a distal pancreatectomy or in sometimes a total pancreatectomy. So in mostly the triangle operation becomes a part of our surgery in distal pancreatectomy and total pancreatectomy, where the tumor in the body of the pancreas infiltrate onto the SMA.
So basically, even the particular study has been on DPs and TP, distal pancreatectomy.
Yeah, distal pancreatectomy.
The triangle comes into your view only when you do a, pardon sir?
It's Whipples and this one, no? Or distal?
It is Whipples.
Whipples and total, not distal.
But classically, what Subhash said, the triangle comes into your view when you do a distal or a total pancreatectomy, the hepatic artery, the SMA and the vein on one side. And the clearance of the
yeah, please carry on, sir.
No, I think even Whipples will have all these areas which will be clear, and it should be done. Idea is, it's a perineural invasion which is now causing inferior survival. So to achieve perineural invasion, you have to clear this area in all the patients in even head of pancreas. It's not for body or tail only.
Will you be doing it for all patients with a periampullary carcinoma? You do need to go up to, that's what sir was asking. Do you need to go up to the artery or the lateral side of the artery clearance of that area. In a body of the pancreas and tail of the pancreas, fine, but in a Whipple periampullary, you need to do that.
That's what they're saying, no? So they. അടുത്ത പ്രാവശ്യം ആകുമ്പോൾ സ്ക്വയർ ഓപ്പറേഷൻ ഒക്കെ ഇങ്ങനെ മാറിക്കൊണ്ടിരിക്കും.
With the current understanding, it has not been recommended for periambulary carcinoma and other cases only. Maybe in.
Thank you.
For the final study, the leopard trial, leopard 2, Shafiq Samsuddin is presenting and Sunil is the discussant.
Good afternoon all. I'll be presenting the leopard 2 trial. It's a laparoscopic versus open pancreatidectomy for pancreatic and periambulary tumors. Background, Whipple's is a complex surgical undertaking traditionally performed by open approach, and it's a demanding resection and reconstruction phase and has a strong volume outcome relationship. It was laparoscopic approach was described by Gagner and Pomp, and there are recent several large observational studies showing from high volume centers showing the advantage of laparoscopic approach such as less delayed gastric emptying and shorter hospital stay. Leopard 2 trial is a multicentric randomized trial with the primary aim to compare the time to functional recovery after laparoscopic versus open PD. The methods is a multicentric patient-blinded parallel group randomized control phase 2-3 trial performed in 4 centers in Netherlands that each do 20 or more PDs annually. The surgeons have to be completed a dedicated training program in laparoscopic PD and had 20 or more laparoscopic pancreatic radiography before trial participation. The primary endpoints of the phase 3 was time to functional recovery, and it was defined by all of the following, with again pain control by oral analgesics, no IV or epidural analgesics, independent mobility, ability to maintain more than 50% of the daily calorie requirement, and no need for IV administration or no signs of infection. And the secondary endpoints were clavin door 3 or higher complications, the pancreatic fistula, biliary leak, GJ leak, postoperative bleeding, ICU admission, length of hospital stay, readmissions, the course, and the quality of life. The inclusion criteria include all aged 18 and above with benign premalignant or malignant indication for elective PD and were fit for undergo the procedure. And exclusion criteria, the suspicion of tumor involvement of the major vessels based on CT, and the BMI more than 35, and recipients of neoadjuvant radiotherapy were excluded. The randomization was on the 1:1 ratio, with stratified with the center volume with the lower less than 50 and high more than 50, and preoperative estimated risk of pancreatic fistula. It's a concealed permuted block randomization, and patient, investigator, and the outcome assessors were blinded. So out of the 251 patients assessed for eligibility, 105 was eligible, and they were randomized, and 54 allocated for laparoscopic and 51 allocated for open surgeries, and all were follow-up. But in in 2017, but the Data and Safety Monitoring Board recommended premature termination of the trial because there was five out of the 50 patients in the laparoscopic, that's 10%, died from complications within 90 days of laparoscopic surgery, versus only one of the 49, that's 2% from the open group died. So the complications were in the laparoscopic group, 2 were from bowel ischemia due to intraoperative vascular damage, 2 from post-operative pancreatic hemorrhage, and 1 from grade C pancreatic fistula. And in open group, it was post-pancreatectomy hemorrhage. The surgical quality control were stringently followed. All participating surgeons performed 50 or more advanced laparoscopic gastrointestinal procedures, 50 more pancreatectomies or either open on lap, and completed training in the laparoscopic distal pancreatectomy and training program in laparoscopic pancreatectomy, and had performed 20 or more laparoscopic pancreatectomy. All participating centers performed at least 20 PDs annually. At least 10 were laparoscopic, and 6 experienced international and pancreatic surgeons reviewed and graded the videos from the laparoscopic PDs. The baseline characteristics all were well balanced. Patient remained blinded up to functional recovery. The surgical findings, Soft pancreatic texture was more in laparoscopic procedures. Median pancreatic duct was comparable. The median operating time was more in the laparoscopy, 137 minutes longer. There was no difference in the R0 tumor resection. The median number of lymph node assessment were also comparable. Blood loss was lower after laparoscopic surgeries. And the time to the functional recovery, which is the primary endpoint, the median time to functional recovery was 10 days for laparoscopic and 8 for open. The median number of days to meet was comparable. Cumulative functional recovery over time was also comparable. And the subgroup analysis, the time to functional recovery was also comparable between the groups. The secondary endpoints, the Claventindo grade 3 and higher was 50% in laparoscopic and 39 in open. Laparoscopic group patients was admitted in ICU were unplanned compared with the 24% compared to 14%. And pancreatic specific complications like pancreatic fistula, biliary leak, and post-pancreatic hemorrhage were comparable. Median total length of the hospital stay were also comparable. The laparoscopic and the quality of life was also comparable, and the cost analysis between both procedures were also comparable. So conclusion, though it was prematurely terminated because of the safety concerns, analysis of the data from 99 patients underwent surgery showed that laparoscopic PD did not reduce time to functional recovery, but the postoperative complications, cost, and quality of life were comparable. The safety concerns were unexpected and worrisome, especially in the setting of trained surgeons. And the limitation was, one is the potential effect of the learning curve, and also the reduced number of laparoscopic procedures performed per center. Although the patients were blinded, caregivers and outcome assessors were not blinded. So this is one of the limitations. So suggestions would be to future trials should also focus on blinding of at least outcome assessors. Thank you.
Well presented. So before this trial, there was a leopard trial, which was regarding the distal pancreatectomy for pancreatic tumors of the distal pancreas, in which it was showed that the outcomes were better for laparoscopy than open. So after that, the same 4 centers, in the leopard trial, there were 14 centers. After that, 4 centers were selected for this leopard 2 trial. They did almost 114 patients, Whipple's procedures laparoscopically altogether, 20 plus. And in that, the mortality was around 2 to 3%. After that, they came into this trial. In that, the mortality was almost 20%. So unfortunate. But the type of complications, including major arterial and venous injuries leading to conversion and all, were supposed to be very high. So this is one of the trials with randomized trials, multi-centric trials, which is available. There are other trials, single-center trials by expert people, which had shown that laparoscopic Whipples could be done with less morbidity and mortality.
Baiju or Kalaiarasan, any comments on the? No, che. Yeah, Kalaya, please.
No, we have actually panel discussion tomorrow to this point.
Right, okay. No, I think one of the things about the mortality before versus after, there's a lot of selection, when you do the individual thing, because they can actually select patients, but sometimes when you go on the trial, because the patient on this trial, they go to forced to do that, and whether that has actually led to it, I don't know.
The Claventindo 3 is actually both the arms, 50% versus 39%. That is too high, is it not?
Mortality zero.
So the problem is whenever you compare this laparoscopic Whipples with other the open procedures, so this is one of the randomized control trials. So there are several single center studies. So the outcome of those single center studies where an experienced surgeon has been performing the laparoscopic surgery or laparoscopic Whipples resection, their results are consistently better from many centers, from China, from Japan, from India. So there are several centers where there are single center there is a team. There is a good team who are doing all kind of advanced laparoscopic procedure. They are into the laparoscopic Whipples and their results are better. So this is the RCT where they have compared after giving training to most of the laparoscopic surgeon, and their minimum training was supposed to be 20 cases. So even after this Leopold trial, why this kind of disparity occurred? Because many laparoscopic surgeons, they tried taking into consideration this particular aspect of learning curve. So how many cases are adequate for mastering a safe laparoscopic Whipple's resection? So there are several studies that has been going on, and in some studies even where Shailesh Srikandesh sir and everybody were involved, and they have identified the number to be somewhere around 39 for laparoscopic Whipple. And there are some Chinese studies where they have identified around 35. And there are people saying that it is up to 50. And after that 50, the mastering part comes, and then their morbidity and mortality comes down. So we are not exactly sure about the exact number where the surgeon or the team masters an ideal surgery with good morbidity and mortality compared to the open procedure. So whatever this RCT has given right now, the lap Whipple compared to open is the morbidity and mortality is high. And why the mortality high when even when the leak rates and everything is same? So if you analyze the data, the grade C leaks, actually the grade C leak is almost 10% when compared to 2% in open. So those are the big difference, 10% versus 2% that might have converted to mortality in laparoscopic Whipples. When you take grade B and C together, it is 28% versus 24%. But if you take grade C alone, it is almost 5 times. That is the problem.
I think John is worried about this highly extension session that has been going. Thank you very much indeed. Thank you.
A big thanks to all the chairpersons and the participants. I request to assemble after lunch at 2:30. We are running late by half an hour. washroom up there. Washroom. This is a slide change. If it supposedly will work here, if it doesn't work, then I'll change. And you can see next slide. It's supposed to be 40. It might extend or it might fall short of it. Depends on the discussion.
This one, yes, sir. Minimal.
Yeah, so it will,
Promoting polling.
IMA
Good afternoon. Now we shall begin our post-lunch session. We have two panel discussions in acute pancreatitis, and it is a case capsule-based discussion. So for the first panel discussion, I invite the panelists on stage, Dr. Rajesh Gupta, Dr. Joshi John, Dr. M.S. Pidambaran, Dr. Manu Pratap, Critical Care Consultant at Lakeshore Hospital, and Dr. Shahir Ali, Interventional Radiologist at Lakeshore Hospital. So in order to make the audience participation more lively, we are introducing a voting platform, online voting platform. So all of you can take your mobile phones and put on your mobile data, and if you can type slido.com, the voting questions will come to you on your phone. I shall wait for 2 minutes for you to log in. So once you type slido.com in the web browser, then you'll get the web page which says join as participant. And in the box here, you can enter the code which I showed you, 248410. So once you enter the code there, you have to press on the arrow icon. Yeah, I'll show you. 248410. This is just to make the post-lunch session a bit more lively. So if all of you are comfortable, I shall begin the case capsule presentation. So this patient came to us in 2015, almost more than 7-8 years ago. He was a 36-year-old male patient. He was a chronic alcoholic, and his initial treatment was outside, so we don't have a lot of details. He was admitted on 17 July 2015 with 1-day history of epigastric pain. Subsequently, we just have a brief sketch that he had deranged RFT, shortness of breath. He required dialysis for 3 days and mechanical ventilator for more than 2 weeks. And in between, a CT was done on 26 July 2015, which showed acute necrotizing pancreatitis. He subsequently recovered, and he got discharged from that hospital. And then he came to us on 27th August 2015, that is day 42, with fever and abdominal pain. Now we admitted him and did a CT, which showed a large necrosis, more than 50%, up to 90% of the pancreatic parenchyma, and large fluid collections. I want to show you the CT in detail, and so I am taking it on a separate PowerPoint so that I can scroll it. So as you can see, the pancreas is entirely replaced by necrosis. This is on day 42. And just a small bit of viable parenchyma is there. And surrounding collections are also there. In the right side, there is a huge collection. In the midline, there is a collection. In the left flank, you can see a collection. And this extends into the pelvis also. Yeah, so you have seen the CT now at day 42. And the blood test also I shall give you. The total counts was 10,700, differential count 56.3, CRP 111, serum amylase and lipase mildly elevated. The blood culture did not show any growth. Yeah, Procal was not done in 2015. Yeah. So what would be the next most appropriate action which we should take? Would it be surgical step-up approach with a PCD and NG feeding, or would it be a conservative management with antibiotics and NG feeding? So this question is what I would like to pose to you. On your mobile phones, if you have logged in, I suppose this question would have come. I'm afraid it's not coming. Has it come on your phone? Answered, yes. It's strange, it's not coming here. So then I guess we should have a show of hands because, oh, is it? You can see the result. Okay. Okay, that's strange, but yeah, then I need one of your help to tell me what the polling result is. 75% say that it is PCD. Yes. Yeah. So, what would be the role of antibiotics in this particular patient? And in general, in acute pancreatitis, where does the role of antibiotics stand? I would like to ask our panelist, Dr. Joshi John.
First, regarding in general, before I go to this patient, in general, the role of antibiotics in acute pancreatitis, this matter has been studied in detail with numerous studies since years together. Can I have the slide, please? Yeah. And surprisingly, many of the earlier studies before 2008 had shown reduction in mortality with prophylactic antibiotics. But after 2020, there have been several studies and more well-conducted studies, and none of them have shown any decrease in mortality with giving prophylactic antibiotics in acute pancreatitis. So, if you look into the guidelines in all associations world over, none of the guidelines recommend the role of prophylactic antibiotics in acute pancreatitis. But antibiotics, there is no difference in mortality, but overall infectious complications reduces and the length of hospitalization is reduced as is shown by many studies. And regarding the PROCAP trial, it was already discussed in the morning. So this is probably a useful indicator which may help us besides others. So in general, when to start antibiotics in a patient with acute pancreatitis? When the CT imaging shows gas in the necrotic collection on imaging, it indirectly means that it has gone in for infection. Or you've got a positive gram stain or culture based on a needle aspiration from the necrotic collection. Or if there is a strong clinical suspicion based on fever, but these are all not clear-cut. It also depends upon the clinical scenario based on which the clinician will take a decision. Serum inflammatory markers, especially the procalcitonin now is coming up as a more useful way. And when there is persistent organ failure, even after 7 to 10 days of initial hospitalization, or if there are extra pancreatic infections, these are the situations where you will start antibiotics in a patient with acute pancreatitis. So in this given patient, so now just before I finish, now this is the latest guidelines, American College of Gastroenterology guidelines, again which suggest no role for prophylactic antibiotics, and even they have gone one step further and suggested no need for doing a fine needle aspiration if in suspected infected pancreatic necrosis also. This was just published 2 months ago. You start antibiotics which would penetrate the pancreatic necrosis and is usually preferable to delay when it is used to delay surgical endoscopic or radiological drainage beyond 4 weeks. So given in this particular patient, I would have liked, as Ramesh had said, I would have liked to know the procalcitonin value also. The counts of this patient are normal. So if there is I would take the cultures, maybe I'll take a fluid aspiration and see, and blood cultures, or see whether the patient has got any extra pancreatic infection like chest infection or any catheter site related infection. If none of them are there, I would still wait, unless the patient goes in for further deterioration or system failures.
Yeah, in this, I agree with Dr. Joshi John that in this setting, when the patient has had multiple ICU catheters and has a long ICU stay, it's highly likely that one of his necrotic collections has got infected. And so FNAC. But then the problem with FNAC is that it's generally believed that we introduce infection into the collection. So that is controversial. So what we did in this particular patient, I'll just let you know. As all of you had just voted 75% for the PCD, we also did the same thing in 2015 an EC cyst drain placed in the right lower abdomen, an NJ tube was placed for feeding, and subsequently his fever and abdominal pain was not subsiding, so we placed multiple more PCDs, one on 3/9, and that drained 4.6 liters in 24 hours. And then 2 more drains in the paraumbilical region and the right hypochondrium. All the drain outputs decreased except the right hypochondrial drain, which was draining 250 cc daily. And the patient 3 weeks later was discharged on 16th September. This was his fever chart.
Sorry, John, can I just interrupt?
Sure.
What is the indication for placing the drain?
Yeah,
What is the indication for PCD?
Yes, exactly. I'm coming to that, sir. The day 42 is the time when we expect the pancreatic necrosis to become infected. And the patient has had multiple ICU admissions, and it's highly likely that when he has a fever, his cause could be an infection for the fever. Yes, he had fever and abdominal pain. So, which is why, and the evidence in the Panther trial and the surgical, it all favors a surgical step-up approach when there is the time when the pancreatic necrosis gets infected. It favors to put a PCD. That's what the trials say. So,
necrosis or sterile one.
Yes.
Which you generally won't do, but
yes.
If it is symptomatic, like pain is one of the indications for putting that.
Yes.
Fever probably would mean infection in a patient like this, but if there is no fever, but patient is otherwise symptomatic, then it becomes an indication to put PCD.
Yes.
Or to drain these collections.
So now let me come to the drain fluid cultures, which brings something more interesting. Out of the 3 cultures, 2 of them, and the initial one especially, did not show any growth. So this adds to the point that the fever that was there may have been, even at day 44, just systematic inflammatory response syndrome. However, one PCD did grow some enterococci resistant to cephalosporins and sensitive only to linezolid and teicoplanin. So now that brings to us to the Pointer trial, which I would like to ask Dr. Pidambaran to present. This is a trial which highlighted that even in that conservative management with antibiotics has a role when compared to PCD. So could we have waited on this patient? And what is the relevance of the Pointer trial? Over to you, Dr. Pidambaran.
This patient actually, based on the CT scan, I would have a slightly different opinion, because after 42 days, it is very unlikely that this has got it's not a loculated collection. Probably it would have been a second attack of pancreatitis. That is what I presume. I'm not sure about this, because usually after 42 days, we will have a much more organized collection. So if the patient is not symptomatic, I would not like to intervene.
Dr. Pidambaran,
yeah.
The revised Atlanta drove us to have this obsession with 28 days, for example. The human body doesn't follow days. Localization is not a matter of days. Sometimes it happens very early, sometimes it happens very late. So I don't think we can judge the collections, characteristics as being only dependent on the duration, because it's very variable.
Yeah.
And that's why
no, I agree to it completely. But only thing is that, see, usually there will be some local, this look more like a pancreatic ascites rather than a, so at least some localization will be there at least after 42 days.
The most common cause of this is a ruptured collection into the peritoneal cavity, which is as good as a pancreatic collection. It's just ruptured into the peritoneal cavity, yeah. So there's one large sea of collection, and there are many other smaller collections. I think that's pretty reasonable to think. I had a question that, in response to Dr. Sudhindran said, that masterly inactivity and activism, both are the two, contrasting, approaches in pancreatic necrosis. It's now very well agreed that if you are able to wait several weeks, just like we have waited here, it's time to act. And sometimes you wait, and then the patient goes into septic shock, and then you end up losing the patient. That's happened in our experience and the experience of others. And sometimes we have, gone too early and found that it doesn't really produce that benefit. So does the panel have any critical suggestions of which ones really we must be draining. That's the question that I would have liked to ask.
So I'll just
No, please.
I'll just go to the trial and then I'll explain this. So this is the pointed trial which was published by the Dutch Pancreatitis Study Group, and it says it compared the immediate versus postponed intervention for infected necrotitis in pancreatitis. So it is a multi-center randomized superiority trial for patients with infected necrotitis in pancreatitis, and they have randomized these patients within 35 days of onset of pancreatitis and randomized into immediate drainage, that is within 24 hours after randomization, and the other group they have postponed till the Waldorf's necrosis was reached, and the primary endpoint was comprehensive complication index, and all the complication over 6 months of follow-up. So the current standard, as rightly said, is the minimally invasive step-up approach. So international guidelines advise to postpone catheter drainage till encapsulation, but most of the pancreatic surgeons agree to the fact that, and when infection is suspected, they suggest for immediate catheter drainage. So when infected necrosis was suspected, this Dutch Pancreatitis Study Group was consulted and to evaluate the eligibility of randomization. And they have defined the necrosis in the definition of infection was classified into two groups, because within first 14 days they have defined infected necrosis by positive gram stain or culture, and after 14 days signs of infection was considered as diagnostic. So within 24 hours group they had done immediate catheter drainage. The postponed catheter drainage patient, they were given antibiotics, and till the Waldorf necrosis stage was there. So they assessed the primary endpoint, that is comprehensive complication index. So this was the results. So there was no significant difference in comprehensive complication index score, mortality, new onset organ failure, bleeding, number of intervention, and pancreatic insufficiency at 6 months. So there was some unexpected benefits, that is required fewer intervention for infected necrosis, less hospital stay, and 35% no need of drainage. So in this wake of this, this is just the trial which says that delaying intervention is not harmful. It's not said that it's not that much beneficial, but some patients the need for intervention also may be less. But in this patient, it's a huge distension. If the patient is not able to eat, the patient is having an abdominal compartment syndrome, or the patient having a distress or need for ventilation or something like that, it's better to relieve that and drain in that patient.
Yes,
in this peculiar patient.
Yes, I fully agree with you. The abdominal compartment and as Dr. Rajesh Gupta also said, when the patient is very symptomatic, even if the fever is due to SIRS, there is indeed an indication for putting a PCD. So this pointer trial has made a great difference, and even in the latest HPB conference, in the electronic posters from Netherlands, we have a submission saying the post-pointer era. And do we need to evaluate what Dr. Joshi was saying, the role of fine needle aspiration in infected necrotizing pancreatitis? So they have managed several patients conservatively, and they've done FNA also to see what is there actually a growth? And 12% of the patients underwent FNA out of the 607. And in 81% the FNA was positive. And in 22% they found that the antibiotics they were giving at the time of doing the FNA was inadequate. The bugs were Enterococcus and Candida, and it was not being covered by empirical therapy. So is the role of FNA coming back in the post-point era is something which we need to see in future. So now I would like to put this question again. Considering this evidence, we had all voted for a 75% for PCD. Would you consider a change just for curiosity, or would you go with the PCD itself? I'm sad that the answers are not coming on my screen here, but I think you're able to get it on the phone. You can select the option and submit, click submit, and then, okay. Yeah. Okay.
So I think reasonable. If the patient is reasonably stable, I think if there is no fever for 48 to 72 hours, I would like to consider stopping the antibiotics, not immediate, checking the procalcitonin again. If it is persistently high, then we can think for continuing the antibiotics. Usually, these patients usually require an antibiotic course of around 10 to 14 days. That's the usual requirement, but it still may vary.
Okay.
I was told that the only exception in the abdomen to source control, everywhere else the treatment is source control, not antibiotics, not anything else. Supportive therapy and source control. Here is the only condition where source control is never achieved, and you are doing all kinds of peripheral treatments. And how happy are you to withdraw the antibiotic as early as you are suggesting?
So I think here the source control means taking care of the infected necrosis. If the necrosum becomes sterile, then there is no indication for giving antibiotic. So if we have achieved that, then the source is also controlled. It's not that we are looking after removing the necrosum if it is infected, because that is of no consequence. The body itself will take care of the necrosum which is sterile through macrophages and other digestive enzymes.
Yeah, the main purpose is to get rid of the infection. So now we all agreed that to put a PCD in abdominal compartment syndrome is a must. And so I would like to ask now Dr. Manu Pratap to comment, because critical care is one department where they come across abdominal compartment syndrome a lot, and its incidence in acute pancreatitis. Over to you, Dr. Manu.
So, good evening to all. So, a few words about intra-abdominal pressure and ACS. Intra-abdominal pressure is a steady state pressure present within the abdomen, which is normally 5 to 7 millimeters of mercury. It's, as you all know, it is measured by the trans-bladder or trans-vesical technique as a surrogate method. And another thing is abdominal perfusion pressure. That's the mean MAP minus intra-abdominal pressure. That should be more than 60 millimeters mercury for the perfusion of abdominal organs. Then this is how you measure the intra-abdominal pressure. I'm not going into the details of that. Everyone knows that. Then when the abdominal pressure intra-abdominal pressure is more than or equal to 12 millimeters mercury, you call it intra-abdominal hypertension. And suppose the intra-abdominal pressure is more than 20 millimeters of mercury and it is associated with new organ dysfunction, at least one organ dysfunction or failure, it is abdominal compartment syndrome. So, World Society of Abdominal Compartment Syndrome had put forward this grading for intra-abdominal hypertension. So, grade 1 IAH is IAP from 12 to 15, and like that it goes up. And when it is more than grade 3 and grade 4 comes under abdominal compartment syndrome. In the particular case of pancreatitis, in acute pancreatitis, the incidence of ACS, IAH is between 50 to 60%, and that of ACS is around 15 to 30%. And it is usually seen in the early stage, in the initial 2 weeks of pancreatitis itself. And if it comes, then the mortality rate of for ACS in severe acute pancreatitis almost reaching more than 75% if it is present. So, why ACS occurs in pancreatitis is the question. There are several mechanisms. Pancreatitis itself is an inflammatory condition, and that will cause the whole of the abdomen will be inflamed. So the bowel edema, fluid collection, ascites, and all those things will cause increase in abdominal volume, contributing to ACS. In another route, from our side, we are giving aggressive fluid management treatment in the initial hours of pancreatitis, and that also will result in bowel edema, abdominal compartment syndrome, fluid extravasation, and all. Also, the patient will be having severe pain, and that will lead to guarding and reduced abdominal wall complaints. So, all these things will contribute to abdominal compartment syndrome, and finally, patient will end up in multi-organ failure and adds to the mortality of pancreatitis. So, what are the effects of ACS in acute pancreatitis? We know that it affects multiple systems. Pancreatitis, already pancreatitis hits kidney and lung severely. So when this ACS is also present, that will exacerbate the already pre-existing or impending AKI, acute kidney injury. That's through pre-renal and renal mechanisms. Pre-renal mechanism is due to the reduction of cardiac output, and renal mechanism is due to the increased renal vascular resistance. And just like that, due to the vascular effect, it will cause bowel ischemia and liver dysfunction also. And when it comes to lungs, which we are more worried about in our aspect, the ACS will in turn increase the intrathoracic pressure. There will be a diaphragmatic splinting, and it will result in reduction of the lung compliance, and it will cause atelectasis, shunting, and all those things. And we know pancreatitis itself can cause ARDS because of the toxins, and this will also add to that ARDS and result in respiratory failure. So many of the times, treatment of ACS itself, relieving of the pressure itself, will help the lung also. Then other organs in brain, ACS will cause increase in ICP, and that will reduce cerebral perfusion and CNS function. And when come to cardiovascular system, it will reduce the preload, contractility, afterload, everything. It even there will be intercellular edema between the cardiac myocytes also. So there will be structural changes, and it will affect contractility, and there are increased chance of thrombosis, DVT, pulmonary embolism, and all. So in general, it can cause heart failure. Coming to the diagnosis and management of ACS in pancreatitis, diagnosis is not that, it's usually clinical only. From the definition itself, the diagnosis is made. Along with that, if you take abdominal imaging and all, that will add to the corroborative evidences only, like cause of ACS, in like fluid collections, and sometimes you can see bowel edema, bowel dysmotility and all, ileus and all associated with this. And lab test, it's not so significant, but some people use biomarkers for early detection and anticipation of ACS, like interleukin 8 and all. That's not much useful in the clinical setup. So coming to the management part, there will be medical and non-medical management. Medical part, you should give analgesia, good analgesia, sometimes sedation, and even neuromuscular blockade. That means you have to, if the ventilation is compromised because of the ACS, you have to control the ventilation. You have to take over the ventilation. You can intubate and sedate, paralyze the patient completely, giving complete rest to the muscles, and that will reduce the abdominal wall. That will help in compliance and all of the lung. And while fluid management also, you have to avoid too much extracellular fluid administration. You should be giving optimal fluid to the pancreatitis patient. Like you should aim for adequate urine output, adequate hemodynamics and all. You shouldn't overhydrate the patient. Sometimes even deresuscitation may be required. There are some studies that even CRRT helped in reduction of abdominal compartment syndrome. And then coming to body positioning, In ICU, we all say patient should be head up. In this case, don't go for much, erect posture. A 30-degree head up may be ideal. If you go for further head up, further angle of head up, then that can further increase the ACS. And if ACS develops, then you have to keep the patient NPO. In that case, you may have to even consider parenteral nutrition also, because nutrition is also important in a pancreatitis patient. And sometimes you have to do the luminal decompression, like putting a Ryle's tube or rectal tube for colonic decompression, or even endoscopic decompression for relieving the ileus. Then you may have to sometimes use pro-motility agents also, along with this neostigmine, metoclopramide, erythromycin and all. So that's the medical part. And coming to the surgical part, we already said if ACS develops, then you have to tackle that. That is an indication for percutaneous drainage. That is the ideal thing, minimally invasive, but if not relieving, you may have to go for decompressive laparotomy also. Actually, completely paralyzed supine patient, that will reduce their guarding. Otherwise, guarding will also contribute. So this is a summary of what I told. You have to check the bladder pressure, and if the IAP is more than or equal to 20 with no new organ dysfunction, you have to consider sedation and other methods, even paralysis and percutaneous drainage, or go for abdominal decompression. Or if it's less than 20, you should be watchfully wait, keep a close watch. So that's it. Thank you.
Thank you, Manu, for the detailed talk on abdominal compartment syndrome. So let me come back after the diversion to our present case scenario. So we discharged him after 3 weeks, and 3 weeks later he came back to us on 2nd October. Now it's day 77. Now the patient has again abdominal pain and fever. Now his counts show a slightly increased DLC, 78.1%. And now we've done a CT again, and which showed the previous collections had all subsided, but one collection, the left iliac fossa, was still remaining. Let me just show you the CT. Yeah, this is the CT on 510. As you can see, the pancreatic necrosis remains as such. And as we come down, you see the previous collections have subsided where the PCD has been put. And however, in the left iliac fossa, on the left flank, there's a huge collection which has been undrained by the previous left-sided PCD. And here you can see the tract of the right PCD. The collections have all drained, and around it there is quite a lot of bowel. And as we come down, the central drain, also you can see the tract, you can see here, near the umbilicus. That was also drained fully, and just the tract remains, and there's a lot of bowel around it. And as you come down, you can see that left-sided drain, which unfortunately didn't drain this flank collection. Around it also, there is no much collection. Everything has drained. So, let me come back to my PowerPoint. And here is the fever spike. Now we see a much more marked fever, several spikes above 38.5, which Dr. Joshi was saying, which was suggestive of infection. Several spikes about 38.5. And now I could put the question back to you. On what intervention would you choose now? I suppose it's coming on your mobile phones. Otherwise, I can ask for a raise of hands. Is it coming? You've answered. Yeah, so the results are not coming here for some technical glitch, but I would like to know from you what. 70%, okay. Okay. Yeah, so I would like to ask Dr. Rajesh Gupta now, in this particular situation, what would one do next? The options are to put a wider PCD, as the crowd said, as majority said. Or do we do a ward through the existing drain? That's supposed to be one of the, where the existing drain has already formed a tract. And do we go around it, use that tract and do a necrosectomy? Or do we do an endoscopic transluminal necrosectomy, because 90% of the necrosis in the central region of the pancreas remains untackled? So what would be your way of approaching? Sir.
Situation.
Yes.
You know, it is important that if the patient has responded on PCD and we have discharged the patient, that these patients are kept under follow-up, close follow-up. And what we do is we call them every 10 days or 14 days to look for the continuous progression in their clinical scenario, which means that their nutritional status is improving, they are eating better, and the serum albumin level is increasing, which means that they are now going into anabolic phase from the catabolism. So once they are achieving that, then gradually we probably will increase the interval of follow-up, and then probably at some point of time leave them alone. In other cases where we have this issue of simmering sepsis, which probably we had in this patient, I'm not very sure. Yeah. But if we have that scenario, I'm saying if we have, then we should keep them in close follow-up and not leave them on PCD and probably let them come when they have a problem, because this is the situation which will arise. Having said that, most of the patients don't come back on the prescribed date. They will come back when they have problem. When they have this, then no, there are two issues here. One, there is a collection, and second, no, he is getting infection. And no, he is also getting into sepsis. So the problem is, if we just put PCD, this is day 77, and don't take care of that necrosum, which has not yet liquefied and disappeared. By now, this necrosum should have liquefied and got drained by PCD if it had to be drained by PCD alone. So we have to look for necrosectomy in this patient, because longer we delay the necrosectomy or the, as sir was saying, the source control, the more we are pushing this patient to a boundary where we will not be able to retrieve him. So I would go ahead and consider necrosectomy.
So would you require a previous PCD tract to ideally go into that cavity?
We already have that, right?
Yeah, but this was a separate collection.
So that is all right. Here you can also do transgastric necrosectomy.
Okay, for the central necrosis.
Yeah, for the central necrosis, and can have a PCD for the paracolic collection, and subsequently we can assess that, how to go about it later on.
Okay.
But I think the focus here would be to get rid of this necrosum, because we are almost, third month of the disease.
That is slightly, what you said, sir, is slightly contradictory to what the Panther trial and the step-up approach says, that if the patient is afebrile on a PCD, we need not upstage.
So I agree what you're saying. In our experience, we published 2 papers. We published one in 13 in Annals and then in 16 in Pancreatology, where we found, and this was consistent over the years, those patients whom we operated, the PCD, interval between PCD and surgery was beyond 15 days, our mortality was much higher. And it was crossing 50% when this interval was increasing. When this interval was less than 40 days after PCD insertion, despite the fact they were improving and we were operating them with the necrosum which was persisting, the mortality improved.
Okay.
So I think we have to consider our scenarios and our set of patients also, where the nutritional challenge is also a big hit to the recovery of these patients.
Yes, sir. Thanks for your opinion. And so I will go on to what we did for this patient. We've put a 20 French wide-bore Portex ICD tube drain under local and sedation, and all the other previous drains we removed. And as you can see, the culture started growing a zoo, the Serratia marcescens gram-negative bacilli. And now I would like to ask Dr. Shahir Ali, interventional radiologist at Lakeshore, about his technique and strategy for putting PCDs, coaxial catheters, and what latest technology is there to drain the necrosis.
Hey, very good afternoon. Thank you for this opportunity. In this era of minimally invasive and step-up approach, percutaneous catheter drainage of pancreatic collection still has a role in the early stage, even at about 2 to 3 weeks in symptomatic acute necrotizing collections. And we can do a PCD even in a patient who is unstable or in sepsis. And this could be effective alone in about 50% of the cases. PCD also helps in as a gateway for further endoscopic necrosectomy or minimally invasive surgical necrosectomy. The argument is that early drainage will help reduce the inflammation and may also help to organize the collection in a necrosed pancreatic collection. And PCD needs imaging guidance, and ultrasound can be used if the collection is large and superficial. Ultrasound can be used in the ICU settings or in an emergency setting. CT is the preferred imaging guidance, and CT is preferred for the lesser sac collection and also to get a retroperitoneal drainage through the flanks. Retroperitoneal route is the most ideal route for a PCD, as it avoids intestinal damage and it avoids peritoneal spillage of the infection, and it also gives a good route for further minimally invasive procedures. If a retroperitoneal route is not available, then a transperitoneal approach may be needed, especially if the collection is adjacent to the head and the body of the pancreas. In certain cases, we may not be able to avoid a bowel, we have to go through the bowel, and in such cases it is better to go through a transgastric route, as the gastric acid is free of bacteria. In some cases we may have to transhepatic route also, but it is generally avoided. There are two techniques. First is the Seldinger technique, and which involves getting the access into the collection by using an 18 gauge needle. Then we pass a 0.35-inch stiff guide wire through to the collection, and the tract is serially dilated using multiple dilators, and then the catheter is placed over the guide wire. And Seldinger technique is most useful in deep collections, but it is time consuming, and it may need the help of an assistant to maintain the sterility of the procedure. Trocar technique is the other method where we advance a coaxial combination of a sharp stylet, a stiffening cannula, and a draining catheter directly into the collection. And Trocar technique is useful in large and superficial collections, but it can be more painful. The initial catheter size may have a role in the success of the percutaneous drainage. Generally speaking, a liquefied collection, say a small caliber catheter like 8 to 12 French may suffice, whereas in an organized solid looking collections, a large bore catheters that is more than 12 French may be needed. Large bore catheters may help reduce the ICU stay and also readmissions. The other methods to improve the success of percutaneous drainage is by using large volume isotonic fluid lavage, and we can install antibiotics through the catheters depending upon the microbial findings, and we can also install necrolytic agents like streptokinase or hydrogen peroxide. There are some novel technical innovations to improve the success of percutaneous drainage, like the kissing catheter technique and the double lumen catheters. The basic idea is those things allow us to do a flushing and aspiration together. In the kissing catheter technique, two catheters are placed to the same tract into the collection, and one catheter is used to flush and another to aspirate simultaneously. Whereas in a double lumen catheter, we have the catheter in which a large bore outer catheter used for aspiration, whereas a central small caliber 4 French catheter may be used for flushing. So with all these strategies, we can expect improvement in the success of percutaneous drainage, and it is an integral part of the management of necrotizing pancreatic collection. Thank you.
So this patient was discharged again once he became febrile, and subsequently he was readmitted on 9th November 2015. Now it's day 115. He doesn't have fever, but his drain output is still 300 to 400 ml per day. Now, this is the same scenario which we all face, that the patient now gets dissolution. They have several constraints of continuing treatment. It's already 100 plus days, and the tubes are still draining. And he wants the NG tube removed. And his counts are 13,000, neutrophils 77%. So this comes to we've already discussed this in the part of the discussion, that despite having no fever and the drain still draining pus at day 100, would you like to intervene at this stage? Which, as Dr. Rajesh Gupta had clearly told us what he would prefer to do. So you could give your opinion. And since the slide was not working so well, if Dr. Dantis could tell me what the... Yeah, so that's the verdict is clear that we would like to intervene. Yes, and that's clear. So I need not ask the same question to you, Dr. Rajesh Gupta, but what mode would you choose now, ward or endoscopic in this particular patient?
John, I would like to add something before I answer this question.
Sure.
Understand that longer this patient is sick and is not recovering, he will take as much time to recover. And this prolonged period can create a hit any time when we can lose him because of secondary organ failure, which can set in because of anything. And I would also request my radiologist, these days they are putting pigtails right and left. I would request them, to fix these drains very securely, because most of the time these drains are put and these patients come with, 1 or 2 holes which are outside because they have not been secured. In this patient, I didn't see the last CT scan. If you said the collection is only localized to the retrogastric area, then my approach would be to do transgastric necrosectomy, because, and another thing is here, I would also like to see what is the drain fluid amylase in this patient, which has been draining 300 to 400 ml. There is definitely a pancreatic fistula. So in a setting like this, it is better to do transgastric necrosectomy, because that's a one-time procedure which will also provide durable internal drainage for the pancreatic fistula. External pancreatic fistula does not occur, and also gives a good look through the transgastric approach. You can actually go into the paracolic area and do necrosectomy from there also. I'll be showing this in my video subsequently.
Sure. So I'll just tell you now that what happened to this patient. The NG tube we removed and we gave him trial oral feeds, and he was tolerating well. His calorie recall was adequate. And so we discharged him on 14th November. And that's where the problem started. And he was readmitted on 30/11 on day 136. And this time he had fever. His previously placed drain was blocked. And there was purulent discharge from the previous drain site, which was already removed. And marred with that, we had several constraints to continue aggressive treatment. And so all that we could manage to do was to dilate the tract and put a wide bore Foley's with irrigation into the cavity. And subsequently, we could do a CT. And it is for academic interest, I want to show the CT to you, how it has changed. So this is CT when the patient has crossed day 100 and with the PCD draining pus, and patient doesn't have fever. But see, you can see the entire pancreas replaced by necrosis with gas. And even on the left portex, where the portex, wide bore portex ICD, which was draining pus, is surrounded by infected necrosis. So So seeing the CT image and patient's clinical condition, it is understood that we should have intervened earlier, but considering at this present situation, what would you choose is one question I could like to ask. You could vote.
Open necrosectomy 76, endoscopic necrosectomy followed by ward 24, endoscopic necrosectomy plus ward 4% and weighted ward 0.
So all of you have agreed for a one-stop shop to do an open necrosectomy and to settle it all in one go. So Dr. Rajesh Gupta, would you opine for the same? Or?
So, we need to understand, because this patient is non-nutritionally challenged. He's on a borderline. Giving such a severe hit to this patient of open necrosectomy is going to push this patient to organ failure immediately post-operatively. In our experience, we published in 2006, when we were doing open necrosectomy for these patients, 75% of these patients were coming out of the OT with respiratory failure and cardiac failure. They were on inotropes and they would require ventilation. And these are the patients who would have high mortality with high incidence of hemorrhage also and fecal fistula. So what we have started doing is that instead of, we will do necrosectomy, there's no question about that, but we are doing no minimal incision necrosectomy. So we'll probably put 2 or 3 incisions at different sites rather than giving one big incision and do necrosectomy. It may be one site at a time. It can be transgastric to begin with and then tackle the right-sided 2 or 3 days later, so that we don't give the maximal hit in the first go in a patient who has been now sick for almost 4 months. He will not be able to withstand an open necrosectomy in this patient.
Yes, I fully agree with you, sir. And that is what happened to him also. We had to do an open necrosectomy on 11/12 after countering the constraints. And post-operatively, the patient behaved as expected. That echo showed stress cardiomyopathy. There was fecal drain and a diverting ileostomy had to be done. And intraoperatively, there were 2 large cavities and the drain fluid culture growed E. coli, the wildest animal in the zoo of multi-drug resistant E. coli. And I just want to show the CT of after post-open necrosectomy, which indeed showed that the lung changes are developing. ARDS's patient is developing. However, the necrosis has been totally cleared. And there's some collection adjacent to where the bowel injury happened and the ileostomy was done. So, the patient, the ARDS progressed and he sadly expired on 13/1. And so the purpose of this presentation was to drive home these 2 points, that probably in the post-Pointer era, if we don't have a very high-grade fever, we could wait and consider antibiotic management. But once we intervene, we should be on a more aggressive route, even though the Panther trial and PCD step-up approach says if the patient is not having fever on a PCD, you can wait. But in a few patients, we have had patients who with the PCD and not having fever have come out. But in some category of patients, they need aggressive necrosectomy, a more aggressive necrosectomy. Now the case capsule presentation is over, and if anybody wants to discuss, can. The audience wants to add something, they can add.
Hi, it was a nice presentation and nice discussion. Thank you, sir, for all the insights given. Basically, in that last CT where we decided for open necrosectomy, in our situation, we have got a collection which is passing along the pancreas up to the head region, and then we have got necrosis extending along the left paracolic gutter. So this one, if you want to go for that pancreatic part, either you can approach endoscopically, or otherwise it will be difficult to approach by a extraperitoneal approach. Definitely in this type of patient nowadays, maybe last 7-8 years, we never opened up. And we have opened up in a different situation where an earlier stage were and they didn't do well. So these patients, we have approached that lower collection very well. We can approach by an extraperitoneal approach, small incision. And that big one, we can ask our radiologist to put a longitudinal drain along the pancreas and upsize it in 1 or 2 days. And we can go for this thing,
transgastric.
transgastric drain tract necrosectomy for the longer collection, and then combined approach. You may need to do it in 2-3 days, but a combined approach will be better to clear both without an open approach.
So, you know, in
And
this
even if-
patient, sorry,
yeah.
please go.
And even if you develop a fistula, it will be easier to manage and they don't go into the sepsis like in a transperitoneal approach. So whenever possible, we never go for a transperitoneal approach nowadays. Or in a worse situations only we have gone for that. Otherwise, always try to contain the infection in the retroperitoneum.
I think another point here is, I'll just make a small comment, that, you know, once we are so far away from the day of the onset of pain, it's almost 120 or so days.
130.
The necrosome will actually become, you know, localized. So it comes out very easily as a whole cost. You don't have to do a lot of dissection. So all you need is an access to that area, and then you pull it out, it will easily come out. So you can achieve this with smaller incision, with lesser trauma to the patient, surgical trauma.
Thank you all for your patient listening. We are running late, so I thank all the panelists for contributing in such a big way, and thank you audience also for making this session very lively. So let's go on to the next panel discussion in haste. So I invite the panelists, Dr. Rajesh Gupta, Dr. Roy Mukada, Dr. Arun Kumar ML, Dr. Ismail Siad, and Dr. H. Ramesh. They can come on stage. This time I'm not boring you with the Slido, and it will be more of a didactic lecture. But I do have a case capsule. Dr. Ramesh. He'll be coming. So I shall, for want of time, I shall begin with the case capsule. This is a 45-year-old male patient who had abdominal pain after intake of alcohol in 2022, which subsided after conservative management. And the initial management is all outside, so I have a very brief sketch. However, the patient continued to take alcohol, he says, and he had 4 such episodes and admission in hospital. And on the 4th admission, he had a remarkable acute symptom for which a CT had to be done. And I have that CT for you. I would like the residents to just give a shot at the CT, just like Tara Madam asked, so whether you can actually spot the diagnosis. So this is the plain film. This is the coronal images. Now this is the arterial face image. I'll show you the coronal face images also, and then if the residents could just give a shot at it, what could be the pathology. Any guesses? So this was the symptom, a massive bout of hematemesis, and it was a pseudoaneurysm of the inferior pancreatic duodenal artery of the jejunal trunk. So a superselective angiographic embolization of the IPD was done, and the patient recovered and was discharged. Now we realized that he has to stop alcohol after this, and he was asymptomatic for the next 6 months after this. And then in February 2023, he again developed severe abdominal pain. And initially, though the CT did not show any collection, however, when he was re-imaged, when his pain and distension increased, he was found to have a huge ascites, which had to be therapeutically aspirated. This continued then from every month from then. And every month he had to be aspirated for the collection. And subsequently, we have the MRCP images. I shall just rush through it. So again, the residents can have a go at it, what you see. There's a lot of ascites that I can say. But what is the cause for the ascites? Can you identify the cause of the ascites? This is the haze pictures. This is the MRCP. That's the site where the pathology is. Yes, ductal disruption. You can see that there is the MRCP is showing the fluid extravasating from the pancreatic duct. And that is what is causing the collection elsewhere. Can you show that? Yeah. Yeah, that's that small dot at the center. Just there, yeah. So subsequently an ERCP was done, which showed a free leak of contrast from just beyond the ampulla, and the guide wire was entering into a cavity beyond the ampulla, and through the pancreatic, though the pancreatic duct was opacified, the guide wire could not go through it. So then he subsequently came to us, and a tapping of ascites was done, and ERCP was repeated, and this was on 14 July, and the first go, there was repeated coiling of guide wire into the cavity. The dye was not filling the distal duct. You can see the images here, how the contrast is extravasating outside, and the endoscope is not able to cannulate into the pancreatic duct. However, they tried again on 3 days later, and this time they could pass it into the distal duct, and they could demonstrate a normal filling up to the tail region, and they could place a 7 French 10 centimeter stent. You can see the pancreatic duct beautifully delineated now, and the stent has gone through the ductal disruption into the distal duct. So now I would like to ask our expert endoscopist, Dr. Roy, and as he unfolds through his presentation, we would like to know what is the limitations while stenting a ductal disconnection, what is its success rate, if it succeeds, what is the long-term result, does the stent have to be removed, will it recur, and what the evidence is. Over to you, Dr. Roy.
Thank you. Thank you, John, and everyone. Can you just show? Okay. Oh, thank you. So this picture shows exactly what is happening there. You can see that the necrosis more than 2 centimeters of pancreas, the presence of viable pancreas upstream, and on ERCP, the free extravasation of the contrast. Variable presentations can be there, refractory PFCs, external pancreatic fistulas, internal pancreatic fistulas like ascites effusion, and then recurrent pancreatitis. So the same is shown here also, the viable necrotic area more than 2 centimeters, viable pancreatic tissue upstream, enhancing the intravenous contrast. And the upstream MPD dilatation may or may not be there, but if you have the MRI with the MRCP and secretin, which is very unlikely we get, we can more clearly visualize that. So ERCP is considered the gold standard. However, the not recommended just for diagnostic purpose, only for therapeutic purpose it is recommended. And the pancreatic neck is a commonest site wherein the pathology is. The management is conservative first, then surgery, and then endotherapy. So only conservative management is unlikely to result in resolution. Antibiotics, nutritional therapy are important. Enteral feeding is always better than the parental. And the somatostatin analogs doesn't have much role. So surgery, the resection, and then the internal drainage is a preferred option, either cystogastroscopy, cystogegnostomy, or pancreatic gastrostomy or jejunectomy, and then fistula jejunectomy. So the management of DPD is either PFC management and fistula management. So management of PFC is quite easy. It's not that difficult. We can either do it endoscopically. We prefer to do that because percutaneous can have problems of high risk formation of fistula. Transpapillary drainage, complete bridging of the disconnected PD is rarely achieved. It's very, very difficult to achieve that. It's, the introduction of, then the other thing is the introduction of infection in the sterile pancreatic bed. Smaller diameter of stent can't drain the thick material, necrotic material also. So the iatrogenic internal fistula, keep indefinite, you have to keep the cystogastrostommy drains most likely indefinite. So in RCTs, recurrence of PFC was 38.5% in patients with early removal versus 0% in the indwelling plastic stents at 14 months. The risk of migration is less, 15% over 2 years with rare adverse events. Single 10 French stent is almost equal to double 7 French stent. Now, because of the lamps which has come, it is more rewarding because can remove, the only problem is the lamps have to be removed in 3 to 4 weeks time because of the risk of bleeding and the buried stent problems. Generally recommended to replace with plastic stent after the removal of lamps. The recurrence after lamps removal is around 9%. The success rate is, this meta-analysis both shows the endoscopic transmural drainage around 90% and transpapillary it is much less, 58.5. The other study also shows transpapillary less cells. Then there is a hybrid drainage wherein you can, the DPDs with large collections, extension of the collection, and those with solid debris, synergistic work. You can either place a transmural stent to prevent formation of EPF, and the PCD allows for irrigation and aspiration of the cavity. So PCD is removed upon PFC resolution, and the transmural plastic stents may remain. So the fistula management is complex, endoscopic intervention, so surgery. So this is just the diagram which shows that you can place endoscopically EUS guided. This is just the video to show how it is done. You can puncture the pancreatic duct from the stomach if the PD is dilated, and then you pass the wire across the into this patient had undergone surgery, so probably it's a pancreaticojejunostomy stricture. So you can see that it is filling the jejunum. So once the wire is passed across the stricture, you can place the stent. Technically challenging procedure, not that easy, but if the PD is dilated, you can definitely try attempting this. So after dilatation of the stricture, this is the hurricane, the balloon dilatation of the stricture at the stricture site, and then you can place the plastic stent into the stomach. So this is the combined endoscopic modality of pancreatic ductal disruption and when the associated symptomatic pancreatic fluid is it is a partial ductal disruption, transpapillary with transmural is quite effective. But once it becomes a complete obstruction, the stent placement may be difficult. So you can either place the stent up to the collection, and then you place along with the transmural drainage. So in summary, DPDS is a common but unrecognized or unsought entity. Understanding the pathophysiology is very important. Associated PFCs make management simpler. Endoscopic drainage is preferable for PFCs. DPDS associated EPF often needs complex endoscopic interventions or surgery. Thank you.
Thank you. So now we had a very good overview of the endoscopic management of DPDS. Thank you, Roy, sir. So now over to the role of surgery in disconnected duct syndrome. I would like to ask first,
Can I ask you a question?
Yeah, sure.
To Roy, you showed a result of 0% at 14 months. Then you still keep the stents there?
Yeah, it has to be indefinitely kept.
Indefinitely. Okay.
Over to you, Dr. Arun Kumar.
So much to learn from Sir's talk actually, but there are two things I would like to highlight. Something like that is the transpapillary drainage, the success is around 9%. And one more thing I would like to highlight, these stents are going to be permanent. So this is not something like a one-stop solution for all kind of DPDS syndromes. So let me outline the short talk on like why this topic, indications, options, drainage versus resection, and finally some take-home points. This is a CT video, but I'll tell you the diagnosis. This is actually an acute pancreatitis, second episode. There is a ductal disruption at the neck, and there is a right pleural effusion. That means it's a pancreaticopleural fistula on the right side. Now just see the video. The highlight is the pancreatic duct from the ampulla till the leak is a de novo duct. It is not at all dilated. So transpapillary to stent it across is definitely going to be difficult. And there is no proper peripancreatic fluid collection. This is a long tract, and ICD was placed to drain the pleural effusion. So the DPDS, in the absence of a coexisting fluid collection, there is a role for surgery. And those who fail or even not amenable for endotherapy, again, that's a subgroup we should consider surgery. And not all the centers will have Roysara and with all the gadgets and the team around to allow a endoscopic ultrasound guided transmural drainage. So definitely there is some role of surgery in such patients. And given that there is a long-term durability of results with surgery is around 90%. So these are the common presentations which require surgical treatment. The most common would be a recurrent pseudocyst, a pancreatic fistula sarcas enlightened, whether internal or external. It could be even a surgical or a percutaneous placed drain, or even a presentation is like recurrent acute pancreatitis or even necrosis. But this is something like a chronic patient. This is not an acute patient. And by the time surgeons see this patient, they will have most often, almost always, something like a splenic vein thrombosis, if not a portal or superior mesenteric vein thrombosis, venous collaterals, and very poor performance status, and nutrition, the patient is going to be very much debilitated. And by the time we place 2-3 drains and 2-3 tubes, they practically get drained in terms of emotional as well as financial. So the surgical options too, we have like the resection versus drainage. And resection, the description is distal pancreatectomy. Some papers even say splenic preservation. But most often we should, I think, highlight on the internal drainage, just like the EUS guided transmural drainage. And it is highly recommended for a tail which is more than, body and tail which is more than 6 centimeters viable. The point is, internal drainage will have less chance of blood loss, less chance of organ failure, less postoperative pancreatic fistula, and less postoperative fluid collections, and less need of readmission, and less chance of endocrine as well as exocrine insufficiency. So many drainages are as also pointed out. See, depending on the disease mapping, we need to carefully tailor our approachment for internal drainage. It is almost always Roux-en-Y. It could be a pancreaticojejunostomy, pancreaticogastrostomy, sometimes even a fistula tract jejunostomy, a cystojejunostomy, a cyst with a dilated body and tail duct. You may combine the cyst along with the body and tail duct as a cystopancreaticojejunostomy. This mortality is highlighted and very much, something like 46%. No, we don't, the surgeons will not attribute morbidity, a split of my word. Morbidity is 46%, we don't contribute that much because the disease itself has its own natural history. So at least only half is contributed by our surgical intervention, I would say. The infections, sir, this is a sick patient, the disease process is ongoing. Just because we have done a surgery, don't attribute all the postoperative events to us. So it could be infections, new onset organ failure, thromboembolism, bleeding, and recurrence of collection. So, the only caveat of any pure internal drainage will be something like a left-sided pancreatitis. So, one thing about resection, I've never done. That's my point. It's a potentially dangerous dissection along an inflamed abnormal tissue planes. We don't have that much high volume in our center. Maybe that's the reason. Higher risk of definitely diabetes as well as steatorrhea. Why we should compromise, insult this innocent spleen along with a good functioning body and tail parenchyma. But despite the surgery, whether it is a drainage or resection, some small collections can have radiological persistence. Unless it is clinically important, don't target or don't explain to the family. So to sum up regarding the surgical role, treatment definitely needs to be individualized for a given patient with a given disease mapping on imaging, especially CT and MRCP. No therapeutic algorithms so far described. Endoscopic transmural drainage is always best whenever feasible, doesn't lead to an extended pancreatic fistula. Drainage is always better than resection. And beware of our sinistral portal hypertension. And some cases can even have a spontaneous resolution unless they clinically press us to do some intervention. Definitely it's a teamwork. Thank you.
In spite of intervention.
Thank you, Dr. Arun, for this marvelous presentation. And
one second.
Yeah, sure.
Normally, the dilated ducts are required for stent placement, but probably the exception is ductal disruption. In ductal disruption, to the best of my knowledge, and Roy and Ismail have to bear me out, if they get the guide wire across and if they get the stent across, it's game, set, and match. So this is an exception. In chronic pancreatitis, because of there's so much pathology in the duct, it's maybe a different story. So I would not agree that an undilated duct is a contraindication for stent placement. It's only a technical issue, getting the guide wire satisfactorily across and to be able to dilate the tract. And the second is, what about atrophy? Many of these glands don't create any trouble. I think you should mention that atrophy is a possibility. And resection is sometimes possible. All the cases are not, there may be only a nub in a pancreatic tissue which is producing a recurrent pain in the left side and in the left chest. And it is possible to even do a splenic preserving pancreatectomy. There is data in the literature. And last but not the least, end-to-end anastomosis has also been reported and published, including from our state. So all of these options are available. The important thing, I guess, is pancreatic conservatism. And certainly to make sure that you don't remove everything, because removing it is equally difficult. But moreover, after the acute pancreatitis, already the pancreas has been destroyed. That's why you're getting all these problems. So you need to be conservative.
Thank you, Dr. Ramesh, for that. And now I would like to ask Dr. Rajesh Gupta about his experience with disconnected pancreatic duct syndrome.
Yeah, John, I must say that we don't have much experience because most of these patients are no managed by endoscopist, and we have a very aggressive endoscopist who does US guided, drainage of that duct. Patients where, are managed by them after endoscopy or by PCD.
Rajesh,
so
I'd just like to say that you should stop using the word aggressive because it's a political statement usually.
No,
in therapy, you can never be aggressive.
So I will say why aggressive, because we earlier used to get these patients, now we get none from their side. And we don't know what happens to these stents 5 years, 10 years down the line, whether they stay in position, whether they get fractured, whether they get displaced, or they, this is a gastropancreatic tract. So it's not within the pancreatic duct where, you can sleep over the rest of the life. So here we still need to see. So I would say that till we have more evidence, doing this for every patient is an aggressive approach. So that is, I would qualify. So, that's our experience. I would just share 2 or 3 cases, and then I'll sum up. This is a patient. What we are now getting is patients where we are doing ward, and they get external pancreatic fistula which does not heal. So this patient again had external pancreatic fistula which was not resolving for 6 months, and you see the evolution of the disease over the initial period, and then this patient underwent for video-assisted retroperitoneal drainage from the left flank. And after that, this ERCP showed, because of that persistent fistula, that there was disconnection. And this is going on auto mode. Okay. And this is the surgery which was done because we traced that tract up to the site. And okay. And here you see the dilated upstream duct and the disruption at the proximal body of the pancreas. And then in a patient, after 6 months, the disease is more quiescent, and here you can actually go to the origin of this site and trace this fistula by the placement of the external catheter, which is retroperitoneal.
and from there you look at the opening into the pancreas, and then you do the anastomosis. This is second case where this was a gallstone-induced pancreatitis, which underwent necrosectomy and a diversion loop ileostomy, underwent restoration after 6 weeks, and once the restoration was done, he developed a clonic distension because he had developed clonic stricture, which was not picked up by pre-operative clonography. So this patient required subtotal colectomy and again ileostomy with distal mucous fistula, and a drain was left at that time for drainage, which again was draining persistently around 50 ml. And this is the CT which shows again the non-visualization of the parenchyma in head and abrupt cutoff in the body with irregular duct in the tail. And this patient, again, we went traced to the opening into the pancreas by tracing the externally placed stent, and then after we reach the opening in the pancreas, we widen this for around 5 centimeters, do some kind of coring, and then achieve anastomosis. Why I'm saying we do some sort of coring is because these surgeries, these patients are likely to, seal off. The jejunum may become separate, and the pancreatic duct then continue to harbor that dilatation and present as chronic pancreatitis. So this patient underwent fistulojejunectomy, which was around 5 centimeter, and patient did well. So we need to wait when we perform such a procedure. If we do it early, then because of the inflammation, the risk of this stricture of this fistulojejunectomy is higher. As I think Arun said that fistulojejunectomy is better than distal pancreatectomy. I'm not going to go into detail. There's pancreaticogastroscopy, which is done as a procedure which is popularized by French reconnection. However, it is a messy procedure and it can cause complications like bleeding and subsequent problem, and that is why the morbidity is higher in these patients. Morbidity is acceptable is 14 to 20% with some mortality, and that is because we are operating, if we are operating in hostile abdomen. Resection, as Arun said, leads to more parenchymal loss. There will be more blood loss. However, if we are thinking of doing splenectomy, which most of the time would be required, we can do splenic artery embolization to reduce the blood loss in a situation like this. And these days also, because we are removing normal distal pancreas, islet cell facility is available. So I would conclude that it requires a DPDS, if it is persistent beyond 3 months, would require some form of management, because after that time, they do not resolve spontaneously. Transgastric necrosectomy is one procedure which can actually take care of subsequent appearance of this external pancreatic fistula. Endoscopic management is preferred initial management. I am surrounded by 2 gastroenterologists. However, surgical treatment provides good durable success rate in more than 90% of the patients. Resection management should be avoided as far as it is possible. However, we still need to have comparative prospective studies between endoscopic and surgical management. Thank you. I have a small video, if you permit, otherwise we can finish it. So one of the video I'm showing here, so they tried doing it, but then it was persistent. So it was a failure in both the cases. We always send them for endotherapy. That we don't, even for this also, there is step-up approach
now. I'll switch on the video, sir.
So this is the patient number 2, where I showed that fistulojejunectomy is not. So here I think the idea is once you have a fistulous tract, you just don't dismantle that, let the drain be there, and then when you trace this, separate this from rest of the viscera, reach to the pancreas, the surface of the pancreas, and then identify that opening. And then dilate that opening. And that's what I wanted to show. I mean, it's just 1 or 2 minutes, but it's okay if it. Yeah, it will open with VLC, yes.
I suppose there's some technical issue.
No problem.
Okay.
Yeah. No, if possible, transmural. Transpapillary we can try, but it's always difficult to achieve. That's the reason if you have an access transmural, then try that.
Roy, is there any study showing that if you keep the catheter just in front of this, but not across the disruption, just proximal to disruption, that will drain?
Yeah, that is one picture I've shown.
Yeah.
That's a study actually. You need not fully
cross
it, but you need to drain it transmurally also. Otherwise, it will not function.
So that will work?
Yeah, that will work.
Even there are studies which shows that even you place a sphincterotomy or even place a stent across the sphincter, if you can reduce the pressure, it will actually heal.
I think I have a case to discuss. The disconnect, a young girl, no other reason for developing pancreatitis. Maybe the first episode of chronic pancreatitis in that girl. Massive pancreatic necrosis, somebody did laparoscopic drainage of collection and stenting was done. So this patient was having 1.5 years fistula and she came to me and finally I decided to explore. What happened was the proximal part, the leak, the duct was completely healed. But the distal part, the duct was open and that was draining into the duct because the keeping of the tube so close to the pancreatic duct actually make it continue to drain. So I dissected and identified the pancreatic duct and did a pancreaticojejunostomy to that. But after that, this patient had pancreatitis, both the undrained and drained, both systems. She had evidence of pancreatitis. So it may be correct when you have gallstone pancreatitis or other type, but in chronic pancreatitis, the pathology may continue even if you do it. So that may be a situation in some cases. That is showing pancreatitis. Interestingly, the pancreatic stent I got from the duodenum. It was not in the third part or fourth part of duodenum. It was not in the in position in that area. That may be the reason for healing the proximal part.
That brings us to our case also. The patient did well for 6 months, but then he was readmitted again with abdominal pain and vomiting in March 2024. And we did a CT, and I can show you the CT again of 21-3. As you can see, this is the plane image, and again, this is a question for the residents. The plane image, if you see something lighting up, then what is it likely to be? Yeah, it is a pancreatic calculus. And so we see here that this patient has gone into, this patient has gone into chronic pancreatitis. And subsequently, we did ERCP again, and there was a cystically dilated pancreatic duct involving the head, the dye not passing into the distal duct. So our endoscopist did a spyglass pancreatoscopy, and a CRE balloon dilatation showed a large pancreatic stone. And using laser, the stone was pulverized, and the stent was placed. And you can see the procedure being done, a picture of the procedure. And subsequently, an ERCP was repeated, and the pancreaticogram showed that the distal duct is filling up, and the dye is not extravasiting outside. And the patient is probably well now. So now this issue of recurrent acute pancreatitis, the enigma, why does this pancreatitis come back again, and what are the causes? And I would like Dr. Ismail Siad to throw light on that.
This patient was an alcohol abuse has got alcohol abuse.
No, he had discontinued after for 6 months now.
Even when the patient comes with first episode of pancreatitis, most of these patients will have at least pathological changes of chronic pancreatitis.
Sequelae.
So it may be a patient evolving on to chronic pancreatitis. Now, when you say recurrent acute pancreatitis, it is defined as 2 or more distinct episodes of acute pancreatitis with complete interceding resolution separated by at least 3 months. 10 to 30% of patients with acute pancreatitis will develop recurrent acute pancreatitis, and of which 10 to 30% of recurrent acute pancreatitis, no identifiable cause is found from history, laboratory evaluation, genetic studies, or imaging studies. After endoscopic ultrasound, 50 to 70% of these patients with idiopathic recurrent acute pancreatitis will have an identified etiology, which may be microlithiasis, small tumors which is not detected on conventional imaging, or anatomical defects which are usually seen in these patients. Approximately 35% of patients with recurrent acute pancreatitis will progress to chronic pancreatitis. That means these patients are basically are in the evolution phase when they present with recurrent episodes. Now, the etiology, it is similar to that of acute pancreatitis or chronic pancreatitis, where you have toxic, which is actually alcohol, or metabolic causes. If you don't remove the metabolic causes like hypercalcemia, hypertriglyceridemia, they can have recurrent acute pancreatitis. It can be idiopathic, where you don't find any causes. Genetic, which is also again a continuing spectrum of acute to recurrent acute to chronic pancreatitis, autoimmune pancreatitis, and obstructive pancreatitis, where you have small tumors which is obstructing or some anatomical defects. Previously, one thought that most of this pancreatic divisum is a cause for recurrent acute pancreatitis, and after relieving initial evaluation, US is the preferred diagnostic test, because some of these cases of microlithiasis, small tumors can be picked up on endoscopic ultrasound, and even endoscopic ultrasounds can see earlier changes of chronic pancreatitis. The role of ERCP for reducing the frequency of acute pancreatic episodes in patients with pancreas divisum is controversial, because 7% of the normal population has got pancreas divisum. And minor papillary endotherapy may be considered in pancreas divisum, particularly those with objective signs of outflow obstruction, where we have a small minor papilla, which is evidenced by dilated dorsal pancreatic duct or Santorin seal. Previously, one used to do cholecystectomy after 2 episodes of acute pancreatitis, but now with the advent of US, only when the patient has a demonstrable microlithiasis, one would go, because especially in our part, we see more of chronic pancreatitis in evolution, and these patients, even after cholecystectomy, will present with recurrent episodes. There is no role for ERCP to treat pain alone in patients with pancreatic division. So if you have recurrent pancreatitis and if you can demonstrate pancreatic division, there is no role for ERCP, because these patients will again develop pancreatitis, even if you stent these patients. The role of ERCP for reducing the frequency of pancreatitis episodes in patients with unexplained recurrent acute pancreatitis and normal pancreatic duct anatomy is controversial. So you should not try to stent all patients with recurrent acute pancreatitis if the duct is not dilated, and should only be considered after a comprehensive discussion of uncertain benefits and potentially severe procedure-related adverse events. And when pursued, ERCP with biliary sphincterotomy alone may be preferable to duct sphincterotomy, because most of these cases may be because of microlithiasis that causes recurrent acute pancreatitis.
Thank you, sir. Now over to Dr. Ramesh for the question. Does
that
acute
large stone which was extracted after pulverization, do you need to apply a CRE before putting the stent?
No, not because this was quite a big stone. So the spyglass to enter the PD, sometimes you may require dilatation, CRE dilatation. Otherwise, the spyglass won't go in. So that's the reason.
It's not for pouring the stones out.
No. The spyglass itself, 10 French it is. So for that, you require a dilatation.
So it's always been argued as to whether acute pancreatitis does become chronic pancreatitis. There's a common etiology like alcohol. It's very easy to understand that you can get acute and you can get chronic too. But there are other types, especially biliary, where there is usually no propensity to develop chronic pancreatitis unless there is ductal damage and stricturing. And even when ductal damage and stricturing occurs, obstructive pancreatitis happens, and that we'll discuss in the chronic pancreatitis session. So I'm allowed by the patient to show his details, his name, for instance. And how do I? You can see that this is a 41-year-old male. In 2007, he underwent this CT, which is almost typical of autoimmune pancreatitis, I think. Most people would say there's a halo around the pancreas, and the next slide shows almost something like a sausage. So this is, the patient could very well be treated with steroids. Some of them will be treated by endotherapy, some of them by all kinds of treatments, microlithiasis. It's as Dr. Ismail said. And this is again in 2007. 5 years later, he has this picture. You can see the dilated duct, you can see the calculi, not just in the body and tail ducts, but also in the head ducts, and extensive calculi in the head ducts. He's become 44 years. He's only increased 3 years in the 5 calendar years, incidentally. So in our patients, we found 2 groups of patients, one who followed necrotizing pancreatitis, and the other which there was no history of necrotizing pancreatitis, the typical patients whom Dr. Ismail referred to. And the difference in terms of the significant differences were that patients with non-necrotizing, that is, which seem to be going on to become chronic pancreatitis without a super acute episode, were younger. There was much more alcohol consumption. They were older, they had much more alcohol consumption and tobacco consumption. And they also had continuing alcohol consumption. And when you looked at the images, you found that the non-necrotizing were the typical ones which produce chronic calcifying pancreatitis, 69% of them. Whereas in the necrotizing ones, 10 of them had obstructive pancreatitis. So that was obviously a different ball game as far as the evolution of disease. So this is typically, what you see in our patients who have recurrent acute pancreatitis, I think what we should do is simply manage them conservatively and wait for them to develop chronic pancreatitis, because we have no therapeutic algorithm at that time. So Comfort and Gamble and Bagenstoss published this paper in, I think before any one of these people present here were born, where they described the story of repeated attacks of acute pancreatitis resulting in chronic pancreatitis. There is some evidence that there is both clinical evidence and there is experimental evidence, but the problem is that we don't have any histology at any time. The lack of histology allows us to use whatever theories we like. We can talk about stellate. I've never seen the pancreatic stellate cell, but I believe it is there, like God, and eventually it produces fibrosis. If the patient doesn't die of acute pancreatitis, then the patient will develop chronic pancreatitis. So, as I said before, biliary pancreatitis can become chronic when there is ductal disruption or ductal disconnection and stricture or parenchymal blowout. But the full-blown picture of the non-necrotizing pancreatic calculi strictures and masses may not be seen. So, I have a final problem that if you have ductal hyperobstruction, partially and temporarily, you get acute pancreatitis. You pass a stent, or you have some insult, or when you do a sphincterotomy. If you have a partial, long-standing obstruction, you get chronic pancreatitis. If you have complete obstruction, as you can get by ligating the duct or neoprene injection, then actually you get atrophy. So maybe that's the actual way things are developing, and this is actually my own concept of how patients develop chronic pancreatitis. The sentinel acute pancreatitis event is a fashionable concept where many, many events have been allowed to converge to create chronic pancreatitis, all from the initial watershed of acute pancreatitis, but there's no real evidence to say that this is true. Thank you very much.
Can I ask one question?
Yeah, sure.
So what about the early, in this spectrum, is there any entity called as early CP? And if it exists, then how do we pick it up?
I think in the interest of time, we should discuss it at the next session. But I think early CP has not even been defined. Is it a precalculus early CP? Or is it a non-dilated duct? Or is it a US finding? If it's a US finding, the biggest problem is one study from the Mayo Clinic showed that 61% of people who underwent US for some reason with background symptoms of irritable bowel had changes of chronic pancreatitis. And many of them, they lost their corporate jobs because they were thought to have alcohol abuse. in the background, and when they were CEOs and all that, they just lost it. So US is far too sensitive. It picks up chronic pancreatitis everywhere. Whether it's there or not, we don't know. And we don't have any other test which tells you the condition in its early stage. And I don't know if Roy and Ismail and everyone else wants to add something to this.
So don't do US unnecessarily.
No, of course, there is a industry interest as well. Because I said I wanted to show that it's the same patient to you all, because otherwise you will say I'm showing two different patients. I know that our friends here are alert, even though the hour is in the afternoon. That's why I deliberately let the names be shown. So I asked Mr. Bashir for permission to show his images. He was, of course, most Malayalis love to have their images displayed for some reason.
Thank the panelists for their active contribution. And we wind up this session and we break for tea.
Yeah, no real break. Grab a cup of tea. I'm going to get my laptop for the chronic pancreatitis session. And I promise that I'll wake you up out of your slumber. And let's have everybody participating in this session as energetically as we can. കുറച്ചുകൂടി ചരിച്ച് വെച്ചാൽ കുറച്ചുകൂടി ഇരിക്കാൻ എളുപ്പമാവോ? കുഴപ്പമില്ല. അതിനാണ് ഇത് വെച്ചിരിക്കുന്നത്. വീണ അദ്ദേഹത്തിനെ ഒന്നും ആരും കുറ്റം പറയില്ല. So I hope you have your VBox stuff installed in your phones, numbers. There went. I set it to അല്ല ആക്ച്വലി ധൃതിയില്ല, പക്ഷേ ഇടയ്ക്ക് ഇത് ലോങ് പ്രോഗ്രാം ആയതുകൊണ്ട് ഇപ്പോൾ ചാർജ് ഫുള്ളാണ്. പേരാണ്. I hope you are getting your cups of coffee or tea. Chronic pancreatitis is infinitely more difficult to manage than acute pancreatitis, and that is being reflected in the fact that I have practically the entire group on the stage. I hope that laughter is in response to that statement. കുഴപ്പമില്ല. എന്താ പ്രോബ്ലം? Time correct, time. Could I have my panelists on stage, please? In alphabetical order, Dinesh Balakrishnan from Amrita in Kochi, Joseph George, Rajagiri, Rajiv Jayadevan, Sunrise, Raja Kalayarasan from Jipma in Puducherry, Roy Mukada, my colleague in Lakeshore, K. Prakash from Asta, B.K. Pratapan from MCH in Calicut, Ramesh Rajan, MCH Trivandrum, R.S. Sindhu, MCH Kottayam, Ismail Siad, Asta Cochin, and B. Venugopal, Lissi in Cochin. For some reason, everyone wants to be on the opposite side. Ladies and gentlemen, chronic pancreatitis has been described as an irreversible change in the ductal and parenchymal elements, except in chronic obstructive pancreatitis. And we have gone over that before. So we need not talk about it again, except to say that there are no stones, no fibrosis, there is upstream dilatation, and little or no functional loss. We would like to classify pancreatitis into pain-free, painful, and complicated. And then, I'm sorry? Oh, it's not come. The slides haven't come. I'm sorry. Has it come? Duplicate ചെയ്തു. ഓ ഇത് കണക്ട് ചെയ്തില്ല. ജമ്മത്തിൽ വരില്ല ഇനി 10 വർഷം കഴിഞ്ഞാലും വരില്ല. എക്സ്റ്റൻഡില്ല, ഡ്യൂപ്ലിക്കേറ്റാ. ഒന്നുകൂടെ ചെയ്യണോ? Function F5. Okay. Okay, that's the list of our panelists, and irreversible change except in chronic pancreatitis, obstructive pancreatitis, like you see in the picture, no stones, no fibrosis, upstream dilatation, and no functional loss. And you can have either pain-free pancreatitis, painful pancreatitis, complicated pancreatitis, and divide each one of these into the functional disabilities. And if you do imaging as well, it seems we have a picture of the disease we are trying to do. I want to start by asking our panel, Joseph first and then Roy, if he has any dissenting views, then he can talk. But I don't think we can have everybody talking about the same subject. If you have a patient who has no pain, do we need to intervene?
I don't think so. We need to intervene.
Is it a comprehensive yes, no, or is it selective?
So unless in a patient who has got a stricture at the head of the pancreas, which is probably the cause for
so
the pancreatitis.
if you have to know whether the stricture of the pancreas, you have to do a lot more tests.
Yeah.
So what you're saying is you will do more tests.
Yes.
What tests? Would you do a CT scan?
Yeah, I will definitely go ahead and do a CT scan.
All cases. Would everybody agree that all patients with chronic pancreatitis, they would do a CT scan?
Yes.
Non-symptomatic? Yes. Everybody is clear on that. What about functional tests? HbA1c in everyone?
Yeah, HbA1c, yes.
Fecal elastase in everyone?
Not really.
No, I agree with that. And I think it's a waste of energy because only in severe pancreatitis, fecal elastase will be abnormal. What about calcium and or parathormone levels?
Calcium, we do just to check out.
Routinely? Dr. Roy, maybe?
Yeah, I think we should do calcium if there's calcific and chronic calcific pancreatitis, we should do.
Fasting without a tourniquet or anything? Anyways.
I think fasting is better always.
And without a tourniquet, also
Yes.
do an albumin level at the same time. especially if they have diffuse chunky stones. So I want to push forward. Would you intervene? That's the question. And now I'm asking the question. Would you never intervene, or you would intervene if there are complications such as mass or biliary obstruction? So this is the question that I'm posing to you all. It must be there with in your Vivox app. If you look at it, even the panelists can answer if they wish.
Yeah, if there is any complication, yes.
So Dr. Ramesh Rajan has sort of preempted the poll by saying if there are complications, even an asymptomatic patient may require intervention. So I'm afraid we can't see the results slide yet because people haven't really, have some people managed to vote? It's right there on the top. So anyway, so if there are complications, you may need some intervention even in asymptomatic patients. So look for complications, so imaging is required. So Dr. Roy, what kind of intervention, imaging that you want to do?
I think we should do a CT scan. That's the first thing we have to know the calcification and to know the parenchyma. So that's the first one.
And MRI or MRI?
MRI should come the next because first CT. Then if there's some doubts, then only we should go for the next one. Or you want to analyze the ductal morphology also, you can do an MRCP or something like that.
In your slide, you said secretin MRCP. Secretin, what's the price of secretin in India?
No, secretin MRCP is not routinely done in our country. So that's just that's the best option if you have, but that's not possible in India.
Human secretin is available in India, by the way.
Yeah, it's available, but it's costly.
Very expensive.
Yeah.
So,
US, as we have already mentioned, that the only if there is any doubt in the diagnosis, then we should go for that, because otherwise the sensitivity is too high. Though the specificity is almost equivalent to all this, but sensitivity is too high.
So I think we've clear that we need some cross-sectional imaging, preferably CT scan. And would you like to mention a word about primary hyperparathyroidism?
Yeah, that's again the parathormone levels. If you're suspecting that the calcium is high, or any of these clinical conditions we are suspecting, then you should do.
So it's been surprising that in all our experience, about 28 of them had hyperparathyroidism, and 4/5 of them never got pancreatic surgery. They only got enucleation of their parathyroid adenoma, and they are under follow-up. It's a big lesson to us.
They had calcification in kidneys also at that same time?
They did. Yes, that's a valid point, that they may have other evidences of metastatic calcification as opposed to dystrophic calcification, which happens in...
I have a question.
You're supposed to answer questions, not ask questions.
Regarding that calcification, can coexist chronic pancreatitis with well-known stones?
I'm sure it can. So you're always right. So now the patient has his or her first episode of pain. So now I'm going to stay with Joseph, and I'm actually going to move to Dinesh and Prakash and VK Pratapan and ask them whether they have any consensus, whether if a patient comes to you saying 6 months ago they had one acute episode of pain and they were admitted in another hospital, they got better, you evaluate them by your method mentioned here. They do have chronic pancreatitis, they may have dilated duct, they may have mass, they may have anything. Do you let them earn the intervention by saying go on and on and on and then intervention, or are you a little more generous to intervene early? What is Dinesh's first preference? What is your philosophy in general?
Look at the etiology of
I think your mic needs to go.
Look at the etiology of the chronic pancreatitis. Is there something that you can modify?
Yes. So is there alcohol as an etiology? Is that what you mean? Or no alcohol? If there's alcohol, you give them a longer rope.
Yeah, you have to get them out of their problem. The alcohol itself is the problem then. So, you can modify the risk factor by...
I'm going to come to that in a minute. But if alcohol is there, are you going to give a long rope? Just one moment, Dr. Prakash.
Yes. And I would consider age as much more important criteria here, because if a very young patient, develops ductal changes and stones, when they start to develop pain, I would tend to offer interventions early on.
I think it's very, very important point that age is a. Would you make a difference between diabetics and non-diabetics? Patients who are non-diabetic? I'll give you a conundrum. 17-year-old or 19-year-old patient, no alcohol, not a diabetic. Only one episode has happened. The other patient is 36-year-old, alcoholic, diabetic.
Yeah, I think even if there is no diabetes, I would tend to intervene, because to prevent the future exocrine and endocrine deficiencies, it's probably better to intervene.
Dr. Prathapan had a point.
The issue is one must make the people understand that chronic pancreatitis is not a curable disease. The very next moment, if you do surgery, they will ask, even after surgery, this patient is having this problem. So when they develop stone, when they have only first episode...
No, most of the diseases are not curable in this world.
No, I do agree, but even if you say this will, actually this patient will develop cancer subsequently later on, will our surgery is going to halt the progress into cancer? No. We have no answer as long as current management is available. So whenever you treat a patient with chronic pancreatitis, when you have a young patient with the probable possibility of developing early exocrine or endocrine insufficiency, you can. But in other ways, only one episode of pain, I don't think that is not
You would
an
wait.
indication.
You is the dissenting voice that he would wait. So when would you decide that finally they require surgery? In a non-alcoholic, relatively younger patient. We'll get back to Dinesh in a minute.
One, the number of pain episodes.
How many would you like?
No, at
5,
least, no,
7?
No, the hospital admission requiring abdominal pain for at least thrice in a year. I will
2 would not do.
No.
No, I need clarification, because it's a serious problem, because all of us face this problem.
No,
it's not a laughing matter. You can see that I'm not amused by this, because my biggest problem is all these criteria, because criteria are never met sometimes. But patients are in front of you. You have to solve the problem.
Thrice a year, that is the criteria we use.
Dinesh was had to say.
Go back to the etiology thing, because there will be modifiable risk factors.
Such as?
When we are saying intervention...
Your mic is far away from your mouth.
When we are saying intervention, are we meaning surgical intervention? There may be other interventions. They may have a pathology like autoimmune pancreatitis. They may have other modifiable risk factors. Then it also depends on whether the duct is dilated.
So let me halt you for a moment. I have excluded autoimmune pancreatitis from the mix at the moment. I am talking about non-autoimmune chronic pancreatitis. You are talking about modifiable risk factors, and would you care to mention what are those modifiable risk factors other than alcohol?
Classification, various, even genetic analysis in a young patient, offering early intervention in a young patient.
Can you hold your mic close to your mouth first? Yes. And then second is, if you have done a genetic analysis and you have found genes, and Dr. Rajiv will comment on it later on, how would you change your approach based on those, if you say you have a slightly higher number of SPINK1 mutations in this patient, how will it change your approach to the patient?
Right now, we do not have...
No, your patient is right in front of you. We can't...
What I meant is, we cannot, just because the patient is young, offering early surgical intervention, especially when the duct is not dilated, may not be the option ahead. So you have to look at...
No, that's another conundrum now. You're bringing in a different pitch now. Ductal dilatation as a measure of indications for surgery is a big controversy, as we will discuss if you required, if you have time. But I feel I have to mention to Dr. Prathapan here that whenever you give counseling for any disease, whether it's pancreatic cancer or whether it is chronic pancreatitis or any disease for that matter, you're only saying, I'm going to fix it now for the moment. You're not saying that the pipe will never burst again. You are just a plumber who's fixing a pipe. So that's the sort of analogy I would advise you to give, because if you go and say that you're going to cure them forever, that's going to be a real problem. Dr. Ramesh.
Rather than the number of episodes, I will also take into account whether it is disturbing their studies or their work. If it is disturbing, I will consider early intervention.
So is this coming up? How do I... Only at 5 o'clock, huh? Oh dear. So then, let me put this openly to you. Dr. Ramesh Rajan's third option, which he mentioned, of intervene if there is lifestyle disturbance in the prime of life. Would the panel accept that as an option?
Yes.
Or would they like to go to Dr. Prakash and say that they do it as early as possible, or stay with Dinesh and say, earn the intervention? I mean, let's just keep it like that.
Intervention need not always be surgical.
And also, of course, that's why I said intervention. I never said surgery. I've been very careful. So, any dissenting or different voices in the audience? If there are any comments, any different thoughts, they must come forward with that, because the result slide doesn't show for some reason. So this is what I wanted to ask you. Dr. Dinesh is the best person to answer all these questions. Other factors, would you factor in the severity of pain? Sometimes, I had pain due to gallstones, and the pain was so excruciating, I thought I had a heart attack. So I needed a surgery pretty rapidly. So I believe the severity of pain could be an important factor. As somebody said, hospitalization, the magnitude of the episode. Ethanol abuse could be viewed in both senses. What about family history of cancer? Would you do more genetic studies if you had family history of cancer? Yes, and then would you consider then resectional surgery rather than drainage surgery? I mean, Dr. Sindhu, would you like to take that question? No, we have a problem on our hands. We have to solve the problem. The patient is in front. It's an elephant in the room.
No,
we can't ignore the...
We'll ask for genetic studies.
Yeah, you can, but once you get the genetic studies, what next? Yes, Joseph?
Yeah, I would rather keep them on close follow-up, probably get a CT or an MRI at frequent interval.
So counseling so that they will remain on your follow-up.
Yeah.
So you have to put the fear of the cancer into their minds and say that they have to get attached to you. Dr. Kalai?
Sir, actually, family history of cancer, we should get genetic studies, because there is evidence to show that some mutations have a higher risk. For example, PRSS, the specific types have more compared to some other SPINK types. So that will give us, we'll be able to counsel.
If it is negative, then what do you do? PRSS one is rather rare in Kerala, at least the ones we have done, all the studies we have done so far. SPINK one is commoner. That's actually an inhibitory gene which is getting mutated, which is a kind of saying that somebody is holding you back and that is removed. It's very difficult to measure its exact impact on the system. As a geneticist, Dr. Rajiv is watching carefully. Could you care to make a comment?
As you said, the the prevalence of both these mutations are, especially PRSS1 is rare in India, quite common in Caucasian populations.
So age of the patient, Dr. Prakash has already, preempted this slide. So I think younger patient, no comorbid, no associated, risk factors, and some family histories, certainly then genetic studies, perhaps intervention earlier, not necessarily surgery. Would Dinesh accept that? It's important to, Prakash put this slide, but does Prakash himself want to put this in perspective? Does it really make sense, or is it just the endoscopy versus surgery, machismo that is talking here? No, unfortunately, physicians and surgeons are fighting over a condition that cannot be treated adequately. That is the reality. And we don't need to do that. We have to join hands together.
Yeah, the slide is only about the trial we have discussed. So early intervention probably tend to, because now there are many theories of neuropathic pain and nerve-related inflammation. So it's not only about removing the stones and relieving the ductal obstruction. So early intervention probably tend to decrease sensitivity towards pain and probability of the patient to have recurrent pain in absence of obstetric pathology. That's what the latest...
Would the panel accept that as a possibility, that don't delay too long? How many of them have a different opinion on that? We don't still know what is too long. Nobody understands that that term too long. Would Dr. Prakash care to say what is too long?
Too long is very difficult to judge, but if it's something affecting their social life, if it is affecting their productivity, going to work and going to studies, then I would call test rather than hospital admissions. Requirement of medications for control of pain very often on almost a daily basis, then that's an indication for some form of intervention, be it endoscopic or surgical.
So Prakash has again preempted this slide to say that nerve sensitization can be an important factor. And I'd like to always highlight this study. Not a large number of patients, but it's a group of patients who underwent total pancreatectomy of chronic pancreatitis, salvage total pancreatectomy, yet the pain did not go. And their systems were so sensitized that they remained on drugs and they remained addicted to drugs. So the next question I have is very critical. And I put all their names because anybody can take this question, that is abstinence a prerequisite for intervention? Now, the Dinesh has judiciously passed it to Dr. Sindhu.
Sir, abstinence in alcoholic pancreatitis is a must. From smoking and alcohol, because these are the two important issues which results in pain even after surgery. Some of the patients who are not...
Let's get out. That's it. You've said your answer now. You have to let others give their opinion. You have to move on and probably catch up also. We can't afford to take all this time for this session.
No,
Prerequisite. This is not a donor pool from which you are taking a graft or anything like that. It's really unfair. The patient became partly addicted because of his addiction and because of his interest in alcohol. And then after the pain came on, and then he took the alcohol to dull the pain. Now you are saying you stop and bear the pain for a certain number of weeks or months, and then I will think of intervening on you. And that intervention may not succeed either endoscopy or surgery. No, that's a little harsh.
The intervention, you should not, abstinence should not be a prerequisite. Intervention is a must if the patient has symptoms.
So I can give you a little anecdote of a, sorry.
Not a direct question. You are saying, is abstinence a prerequisite for intervention? Whether the abstinence after or...
No, that we have no means of control. First of all, as doctors, I feel we should stop being, moral priests. If somebody wants to drink to themselves to oblivion, it's their birthright. Yeah.
It's not a straightforward question, sir. Like, somebody may be having an alcohol
addiction. I'm going to stitch that mic to your nose.
I'll tell you. There's some problem with the mic, actually. I can speak quite loud. It's not about...
Try the other one, try that.
If somebody is addicted to alcohol, the important thing, rather than the prerequisite, the focus is now on his addiction and the alcohol problem. So you have to give a lot of weightage to that. If he has a pain, there are multiple reasons for the pain. But alcoholism in itself is a very important thing which needs all your attention.
It has been shown that stopping alcohol and smoking decreases the incidence of pain. So if one has to advise first of abstaining from alcohol and smoking.
I am disappointed that our panel is not talking about the morphology of the gland as well. If the patient has a large pseudocyst, Dr. Dinesh, do I have your attention? If a patient has a large pseudocyst and the strictures proximal to the pseudocyst, and then we say you go off alcohol, it's fine, he'll go off alcohol, true, okay, but perhaps you should also the same day do either endotherapy or surgery for the pseudocyst, because it would be really difficult for him or her to maintain themselves on a pain-free process. I'll give you an anecdote. A surgeon in Gorakhpur had chronic pancreatitis. He was drinking like a fish. He was also a pethidine addict. And he came to us with acute on chronic pancreatitis. We put in an NJ tube, fed him, and he was contemplating going back because the NJ tube was irritating him because his CRP was like 160 or something. So he had, he was obviously dependent on drugs as well as on alcohol. So he went to our psychiatrist. We charted out a program for him for de-addiction. He said he was willing to go through the process. But he said, my pancreas is hurting me daily. What are you going to do for that? And that's when I came to become aware of this entity, that we need to work on both fronts. I had pretty much the same approach as the panel, but I plead now that we should have a slightly broader concept. Yes, it is true, Dr. Ismail said that just stopping smoking and stopping alcohol will definitely decrease the inflammation, especially in a patient who has no morphological abnormality, just an enlarged gland with inflammation. Yes, some calculi, absolutely. But if the patient has an obvious ductal obstruction, patient has an obvious disruption, then you have to do something. Because I feel we need to qualify our statement. Yes, Joseph, and then Ramesh.
So one way what I would also suggest is probably you should intervene and just tell the patient that unless you stop alcohol and smoking, you're going to get a recurrence, and then I may not be.
No, that suggests that if you stop it, then you won't get a recurrence. That also is not true. So, I mean, we should not fall into traps like that. We realize that we are offering a service. Chronic pancreatitis is the best way of learning how to counsel patients, because you realize that the essential fallibility of healthcare. So you have to tell them that the way to go here seems to be that you need an intervention. Normally, it would be logical to wait for the stopping the alcohol and stopping the smoking, seeing if you get better, and then doing the intervention. But it may not be fair to you. So we'll do both hand in hand and hope for the best.
So, but your consent should be black and white.
Yes, yes. You can use any color, but
in black and white.
So now.
Sir, is it justified in asking him to stop alcohol and you're starting morphine?
I wouldn't give morphine for my patient anyway.
You're sending to pain clinic, they are giving morphine.
That's only for palliative care. I don't think our patients with chronic pancreatitis get morphine in our... We don't send them to a pain clinic, by the way. Why would we want to send them to the pain clinic? Is that your policy?
Sir, regarding this...
No, let her answer the... Let's
No, sir, some patients, even if they are on regular doses of drugs, that is, they are on regular follow, they're constantly getting pain. And they are actually asking for surgery. At that point, it's justifiable to go for an early surgery, even if the patient is having a very early age. That is justifiable. That's how we actually manage such patients.
Yeah, I accept that, but the biggest problem is that the threshold for pain is variable in different patients. Some patients, because of social reasons, women withstand much more pain than men. This is a social demographic which has been established. So that's why somebody yesterday was telling me that there are fewer female wards in the public hospitals, even though there equally number of women fall ill. They just say there's a family, there's an examination, though they will just forget about their pain and just plow on with their normal work. Whereas the men are the wage earners. They say even one day if I don't earn my wage, I need to go and get my treatment. Sorry? Whatever. Maybe that is applicable to a certain given case. So that's something we'll have to remember in future. No, but what I'm saying is that suppose a patient has a very low threshold for pain, then they will come and push you for surgery. Another patient who actually is suffering with pain, not able to go to work, but is not talking to you about it because of fear of surgery, may not come to you. That's why this ISBICI score and the VAS and all are very, very fallible. It's better to use the Prakash dictum of you see the social circumstances, see they are able to be functional. If they are able to function well, you can wait longer, no harm done. If they are not, then I think you should intervene. But you should be also looking into that. Just saying the patient who comes and cries saying do surgery, agree that, you may be in trouble. So if there's a mass now, and the mass can be, this is a dilated duct with no mass, and this is a mass which has produced a double duct obstruction. And I want to ask, again, I want to ask Dinesh, so if you have a patient with a pancreatic mass in chronic pancreatitis, there are two types of masses basically, the ones with the stones and the ones without the stones. Do you have a common minimum program for looking at these? And just give me a little bit of your thoughts, then we'll take the opinions of the others.
So I've actually put two cases here. Both of
Would you like to show them now or later?
Yeah, now we can look through them. The first case is a 56-year-old.
Can you give him a, you want a, will this work on that?
Am I audible?
May not work, no?
Okay. So the first case is a 56-year-old male. He's a history of ethanol intake, but abstinent now, type 2 diabetes. He's a case of chronic pancreatitis on follow-up in our clinic, pancreas clinic. And then he presents with weight loss and icterus. So this is the first case that I've chosen. So in this case, there was a discussion on imaging, cross-section imaging. Usually we do a CT scan, but I've chosen an MRI because this patient had presented with icterus. So this is a T2 weighted image, which is showing a dilated pancreatic duct and bile duct. So there is a double duct sign. In the next image, again, this is a plain lava image, which is showing in the head of the pancreas, it is hypointense lesion is there. So all this points towards malignancy as a probable cause. So the routine test that we do is, we do a CA99 as a routine. It was elevated, it was 220. EUS is always done as a protocol in such clinical scenarios. So it showed a 27 in 29 millimeter hypoechoic lesion in the head of pancreas. Main pancreatic duct is dilated in the neck. Abrupt cutoff at the head region. Pancreatic parenchyma atrophic, few calcifications, all pointing to chronic calcific pancreatitis with the head mass. We always do a EUS FNA and do a on-site cytology, the row staining. So basically the endoscopist takes the specimen next to the pathologist is there with a microscope. I'll put up a slide there. So
I took the slide out for time.
Okay, sir. So basically the specimen is fixed with isopropyl alcohol, takes only 20 seconds. Then you dip it 3 to 4 times in toluidine blue, wash in tap water, dry it and look under the microscope. So you can say atypical cell clusters suggestive adenocarcinoma. It makes the diagnosis. So
I wanted to ask you immediately, therefore, no calculi, if there's a mass, is your biggest worry cancer?
Yes, sir, yes.
Would the rest of the panel, have they got a comment on this? There's a mass, no, but the suspicion initially was chronic pancreatitis because the patient presented with pain, but there was no stones, and now it's turned out to be adenocarcinoma.
So I put a similar clinical scenario.
Yeah, we'll come to that in a minute. So just a word with Dr. Roy or Dr. Ismail, maybe Dr. Ismail can take it. ROSE is rapid on-site examination. In our hospital, for example, it goes to the pathology department because they are more comfortable doing it there. We don't do it in the next room. We don't have that, we can't order the pathologist about. How does Ismail get it done? If you do ROSE?
We send it to the lab.
You send it to the lab, but I think Roy does not remove his scope till he says enough tissues there.
Yeah, that's why. We get the report immediately.
Yeah. So he kind of knows. He doesn't tell us. That's the whole problem.
Nowadays we do biopsies actually, which
also
give more better results.
And sometimes that processing takes a day, sometimes, isn't it? But they will tell you there's enough tissue. The most critical thing is that the pathologist has told the endoscopist that there is enough tissue, so you can take your scope out. So, am I right, Roy? Is that right?
Definitely the scope will be out. The patient will be waiting in the next room till the...
And then you put the patient back again. Okay. Yeah. So your next case, Dr. Dinesh. Oh, I hadn't removed the slide. I apologize. So this is Dinesh's slide on...
No, this is the paraphernalia that's required. All that is required. So it's in the next door and the senior resident actually comes and reports to a consultant.
Would they work with the biopsy now as...
Yes, sir.
Because you would need to process it more, isn't it? A biopsy?
Mainly the point is the adequacy of the tissue. The cell block, the further studies on it will be given only
later. Case 2.
So case 2 I have chosen, as Ramesh sir has said, is a case with no stones. So again, this is a lady whom we saw 2 months back, 70-year-old lady, type 2 diabetes for 21 years. She had an episode of pancreatitis in 2017, almost 6 years back, when she was extensively evaluated with all the tests, and it was labeled as idiopathic chronic pancreatitis. Now, this was largely based on the US findings, because the duct was not dilated at the time. Now, recent worsening, she is seeing a physician for diabetes, and there was a recent worsening of diabetes with an HbA1c of 8. And that prompted the physician to ask for a CT scan. And she had a suspicious lesion in the head of pancreas. So she underwent evaluation at an outside center, underwent an US-guided FNA, and that was suspicious for malignancy.
So I want to just ask you, given the history of a previous extensive evaluation in 2017 for idiopathic and the diagnosis of idiopathic chronic pancreatitis, if a recent worsening of diabetes had not been there, would you have done an EUS FNA or would you have just examined her and followed up in the clinic? What is your threshold for EUS FNA? That's the question I wanted to ask.
Only because the imaging was actually, there was a low threshold. I don't know why the physician asked for a CT in that situation, HbA1c of 8. But I think he had a low threshold. He had been seeing the patient for a long time. There was something in her that, why did her sugars worsen? Yes. That prompted the imaging probably.
So there was only a bulky head on the...
Only a bulky head and it was evaluated.
So perhaps we did do a little bit of overkill. Combined. I mean, whether it's a referring doctor or us, it's the same thing. I mean, we have to take responsibility. Dr. Ramesh?
Yeah, she developed basically symptoms of chronic pancreatitis for the first time in the 6th decade of her life. And that is, I think, a pointer towards malignancy.
Well,
there's not hardly little evidence.
If you talk to our colleagues in Delhi, they would dismember you.
You agree?
because they talk about idiopathic pancreatitis in the elderly. It's also there in the West. In the West.
Yes, sir. We had many patients first time presenting with pancreatitis and no
But
pancreatitis.
with no malignancy or?
Yeah, malignancy presenting first time as pancreatitis.
No, this is a different situation. What you are talking about is malignancy presenting as pancreatitis. But four years ago, pancreatitis diagnosed.
No, chronic pancreatitis, if they present for the first time in the 6th or 7th decade, it is highly likely to be malignant. That has been the experience.
Well, I think we need to publish that because I'm not sure I can. First of all, it's quite uncommon for the first time, and therefore naturally everything stands out in our brain because when we document it, it may not be so. Would the other side, the left front, say something more?
No, I just want to clarify. How was chronic pancreatitis diagnosed in that patient?
Exactly, that's the question.
In 2017.
No, I think Dinesh is the one who is presenting the case.
Presented as pain.
No. How
Presented
did
as
you
pain.
diagnose as chronic
jaundice.
pancreatitis?
No, calculi. They were presenting for the first time in the 6th decade of life.
No, I think what he's saying is that, simply saying that if you have an elderly patient who comes with
first presentation.
No, chronic pancreatitis, in inverted commas, it may not be chronic pancreatitis, it may actually be cancer.
Chronic pancreatitis turning malignant.
That is not the point. What he is telling, any patient who is presenting for the first time with features of chronic pancreatitis in 6th decade. Or
After
7th
calculi,
decade. Maybe there, but it was
no, this is not such a case. I think we are confusing the picture.
64.
No, Dr. Dinesh has not even told us that there are calculi.
There's no calculi.
Exactly. Nobody even asked him, clarified whether there are calculi.
I told it's
Idiopathic chronic pancreatitis is
finding of chronic pancreatitis. No duct dilatation, no calculi at that time.
I think the moral of the story for me is that don't jump to any conclusions as far as pancreatic masses are concerned. This is not even probably a mass. Dr. Kalai, would you like to comment on all the things that have been said so far? Because I think so much water has gone under the bridge and you've been very silent.
Yeah, when there is chronic pancreatitis with mass, so the first thing is we want to rule out malignancy. And we all agree that it is not based on single finding. It's basically we need to take into consideration
we'll come
right
to that.
from the
We'll come to all
history
that. We'll come
so
to all that.
That is, the first thing that comes to my mind, like when I see a chronic pancreatitis with mass. And regarding that point, I think the presentation, the first time with symptoms in 6-7 decades, probably it indicates that they were having asymptomatic chronic pancreatitis, and the symptom probably is because of the malignancy. So that's why.
I'd like to clarify with Dr. Dinesh Balakrishnan that I think the reason why he has brought these two cases to the table is that all patients do not fall into one category. There is a whole heterogeneous group. Some of them turn out to be cancer, some of them turn out to be nothing really. So I think more evaluation and more care is required before reaching a conclusion. Is that reasonable?
That's what I was trying to.
Yeah, thank you. So can you tell us what happened with these tests?
As you asked us, is there a common minimum plan? So the previous slide I had just put in, when you see a patient in the OPD with such a history, we always review the CT images with our radiologist. The surgeon and radiologist sits and looks at the previous images to look at whether the images are satisfactory. Do we need to repeat the image? Is it a pancreas protocol, CT, all that? So we did that, and all that we could understand was it was a bulky head of pancreas. The peripancreatic fat planes were preserved. We could not, from the images done at the outside center, presume it's inflammatory. The CA99 done both at their center and our center was lowish, sort of 42, just above normal. So the next thing we do is review the block and slides. So though it was reported as suspicious, our pathologist was very clear. We were told it's benign pancreatic SNA and ducts, and if you are suspicious, repeat the biopsy. So this was what was told to us. So we discussed this case with our medical colleagues, and they did send some tests. Actually, this case is not a complete case. IgG4 was sent, and then, as is often done, when there's a head mass which is suspicious, we do a PET CT. It's like we repeat the CT, but nowadays we do a PET CT with a pancreas protocol. So we have the advantage of a good CT scan as well as a PET at hand at about the same cost.
Tell you a little secret, they get it for free. That's why they do it.
No, not exactly. No. Not for free, but there is a free part to it which I will come to, sir. So we did the PET CT, and the plan was to do a repeat EUS and biopsy. So the PET CT did not show any FDG uptake in the mass. So that's the PET CT. There's no FDG uptake, non a bit bulky head of pancreas. So nowadays, because FAPI PET is being done, if you ask for a PET CT, the nuclear medicine department wants to have some data on chronic pancreatitis and cholangiocarcinoma. So they do the FAPI PET free of cost. So this was done for this lady, and it showed SUV max of 7 point. As you can see, intense avidity in the head of pancreas. Rest of the pancreas is not showing any activity. So there is a focal area of what could be inflammatory, likely inflammatory etiology. So we had two ways ahead of us, either to go with our medical colleagues' plan of EUS and biopsy, or
wait.
The biopsy is negative, first biopsy is negative. So what we did was we went back to a radiologist and they looked at the first image and our image and said there is a reduction in the mass. So we thought we'll wait out for 4 weeks.
But one clarification, what SUV max would be required for you to say is cancer for sure?
So
I
want to just add about this because people should not go with because FAPI PET is not useful in differentiating between chronic pancreatic mass and malignancy because
not at all.
Yeah, because actually the FAPI
overlap.
The principle is the chronic inflammation takes up FAPI, and so when the mass happens in the chronic pancreatitis, it will invariably shows uptake. So. But it is useful in differentiating from acute inflammation. Acute inflammation does not take FAPI, but when there's chronic inflammation, FAPI takes up. So it is not useful in the setting of chronic pancreatitis to differentiate between.
The only thing is, it's not a backdoor chronic pancreatitis. This could be anything. It could be autoimmune. It could be some other thing. So we thought how the uptake is going to be in the gland.
Yeah.
Again, it is a protocol that they are trying to look at usefulness.
Okay.
And it's not charged.
Yeah, it's a research kind of. Okay. Yeah.
No. Yes. Was there any question from the audience?
No, acute inflammation does not take FAPI. Chronic inflammation, because the physiology, it's basically the fibro activated, so it is by the macrophages, which are there in chronic inflammation. So it is useful in differentiating, for example, post-chemo acute inflammation, their normal PET will show uptake, which looks like there is no response. But if you do FAPI PET, it won't show uptake, which means there is a response to the therapy, because acute inflammation, FAPI does not take up. So there it is useful, but in the setting of chronic pancreatitis, FAPI PET is not very useful.
Plus, in general, an FDG PET itself has tremendous overlap between chronic and pancreatitis and pancreatic cancer, because pancreatic cancer also produces pancreatitis around it. And the only use of FDG PET, sometimes somebody may argue, is that if you see distant metastasis. If you see that, then there's no controversy. Then we know we are having a cancer. Otherwise, you can argue till the cows come home that it's one or the other, and you still need a cup. Sorry, yes?
Can I ask a question?
Yeah.
It's to the all panelists. What would be the sensitivity of FNAC in a chronic pancreatitis?
I think we are going to come to that, Shiraz.
Okay,
yeah. So we don't preempt the...
I thought we were discussing the FNAC and...
So Dr. Dinesh, would you want to just complete this? You've said all this, haven't you? Already.
Choose the second plan, so we are waiting it out.
The Vivascope is the one thing which has recently come to the FNAC, FNB and all may soon, be much more easier once the Vivascope comes to the place, because
instantly you will get
instantly you get the report. The pathologist can instantly report that this is malignancy or not malignancy. So it's already come to the market, and it's most of the places it will come.
So Dr. Sindhu, now this patient with a mass has got moderate severity of abdominal pain, weight loss of 7 kilos in 5 months, tantalizingly. That's 6% of her body weight, and her diabetes mellitus has worsened. She also has some steatory. When you ask her, she says, yes, I have some fat intolerance. Now, what are you going to do?
Sir, it's a totally symptomatic patient with evidence of exocrine and endocrine deficiency. So, first of all, I would like to confirm that patient is taking adequate doses of supplement, that is pancreatic enzyme supplements and other medicines. In presence of that history,
for the audience's sake, it's adequate. What is adequate? There's immediately the question that I ask myself is what is the meaning of adequate? I don't know. I don't have the answer to that. Do you?
Yeah, patients usually on follow-up, we have to titrate the dose of enzyme replacement therapy and other medicines according to their symptom relief. If patient is worsening on that medications, it is easy for you to take a decision. In such cases, with this history, I would like to re-image and do the investigations to rule out malignancy.
Okay. Are there any other opinions? You will do more tests, in short. The tests will be lab tests, it will be clinical assessment, lab tests, and re-imaging, and probably USFNA. These are the 4 things that have already been mentioned. And would this algorithm be kind of okay? This algorithm was provided by Roy, but I would like somebody else to, who has Joseph, who has probably been silent for a few minutes. I hate to see anybody silent. Sorry? Vensar is very silent, so Vensar must be the one to. He's quickly saying, I haven't even seen the slide, so how can I talk about it? It's a test of his, refractory error as well as. No, it's very simple. Imaging, endoscopic ultrasound, FNA, and then proceed. That's pretty much the 4-step approach, which I think everybody, all of us agree. Most centers in Kerala are blessed with having all these facilities. So it's easy for us to speak the same language. My concern is, if you have a patient, like Dinesh said, clinically there seems to be that this mass does not look malignant. Clinically, the patient does not have mass. Is an EUS FNA mandatory and negative FNA mandatory for you to manage conservatively, or you can use a clinical basis itself? Let's ask B. Venu. That is, on a clinical basis, you and your, say, gastroenterology colleague sit down and say, this doesn't look malignant, we can wait and give them medication, see how they improves.
Or if there is no definite mass.
If there is a mass.
If there is a mass.
There's a mass.
Oh, okay.
There's a mass, it looks inflammatory mass, in other words. There's no features of malignancy on the imaging. Yeah. The CA99 levels are equivocal.
If facilities are available, FNA is mandatory to take a decision, treatment decision making.
So the next question immediately, if EUS FNA is done and if it's negative, will you accept it, or are you going to still sit on your clinical?
It depends not alone on EUS FNA. Multiple factors are taken into consideration.
So of those multiple factors, which would be, in your mind, 2 important factors? Will they be clinical factors? Or?
Clinical as well as laboratory parameters. So clinically, weight loss, jaundice, then imaging.
CA99 would you give importance to? Not much.
Yeah, but not much.
Not much. Now, Dr. Sindhu has talked about corrected CA99 as well as CA99 trend. And both of these, I would like you to explain to us what you mean by that.
Sir, as all of us know, CA99 is not a dependable parameter. It can go up to 20,000 in benign cases and very normal in malignancy. So we would like to get a corrected value in high value reports, like you have to exclude or treat cholangitis.
Is there a correcting factor you apply, or how do you correct it?
If he has biliary obstruction and cholangitis evidence, you have to drain the system and then have a repeat value. Or associated pancreatitis, if it is there, you can correct that, then get a repeat value.
But clinically, the patient's decision has to be taken in the course of the week.
Yeah,
if you put a stent, it takes some weeks for the jaundice to subside.
We'll go ahead with our plan, but we'll not take that CA19 value into consideration at that point. You can have another value.
No, conversely, I wanted to ask whether trend also, can it not be affected by the other factors? Like if a cholangitis, post-stent cholangitis happens, CA99 goes up. Is that possible?
But cholangitis, you can get an idea from the labs.
So the next question is, if to the audience was that if a US FNA is negative in the mass, would you accept it and then manage the patient conservatively? The panel has already said they will use other parameters. They don't trust the US FNA, although they depend on it also. So how do I do that? I think there was no, the session limit has changed yeah, we have to do a show of hands. Is it coming? It said time was up, actually. So I want to show you this slide. This is very...
Sir, can I add one more point?
Yep, please. Any
Sir,
number of points.
Before doing an USFNA, it is better to discuss with your colleague, that is gastroenterology colleague, who is doing the USFNA, regarding the point where you suspect malignancy in the image. If you can actually share the image and discuss with that person, and that can help that
My
person.
endocrinologist will be very disappointed. He says he can pick up everything. He knows how to read the CT scan as well as I can, and he can read it better. In fact, he takes the opinion of the radiologist as well. So I don't know that I will ever do that. I've never done that so far, and I will never do it again. I will never.
Surgeon's concern also you have to translate into words.
I don't know if anybody has a comment, but I would certainly not take that liberty. Yeah, Dr.
In addition to that, for centers where the pathologists, especially the Rose thing, with the biopsy, you said now you're doing with biopsy. How often the pathologists want to do IHC also on that?
Yeah.
To comment on, to be definite about malignancy, to differentiate benign and malignant. How often they want IHC also?
No, IHC for adenocarcinoma is not required. They can diagnose it only. IHC only comes when you are when there is a NET or.
No, not for NET. For chronic pancreatitis.
No, they don't usually use IHC.
There's some markers like PAMC4 and things like that described, which helps in, because in the background of chronic pancreatitis to diagnosing malignancy is not all that easy.
No, I think when the cellular yield is less, they use stains to try and categorize it. That is when they have additional sections, additional stains are required. So also if they have a poorly differentiated kind of a picture, then they need further IHC. But in general, sorry, Dr. Roy.
A problem when there is well differentiated, not poorly differentiated. Poorly differentiated is quite easy, but well differentiated, they have the problem.
Yeah, that's what I was asking.
No, but poorly differentiated also, they can't tell that from an NET. There'll be a uniform CF cells, but you need for both, I guess, in that case. So let's.
I think
sorry.
Point in USFNA, if there are a lot of calcification, I think the role of USFNA should not be kept very high, because we'll have to rely upon other factors if there are too many calcifications.
Why is that?
Because the US cannot see the mass beyond chunky calcification, and may be difficult to locate that area.
Yeah, but if they get it, so I was going to bring this after this slide, because USFNA, when positive, is fantastic. When it's negative, how much satisfaction or how much support does it give us for making a decision? That's when I fear that the issue of what the background is, what the calcification is, what is the clinical features, etc., come into it. So I did this opinion poll ranking. I sent this, this Excel kind of picture to all our panelists, and their names are on the top. And they had to categorize from 1 to 13 what they thought was the most critical in differentiating benign from cancer. And as you notice, there is a substantial variation, a lot of outliers. It often reflects their own personal practice, which is perfectly acceptable. In general, if I then added them up, and then I divided them into 4 different categories, 3 different categories. The greens, FNA and repeat FNA. So many people feel that a repeat FNA in the clinical suspicion is there high. A repeat FNA should be done. Does a panel agree? So a repeat FNA, an FNA and a repeat FNA, bilirubin, high bilirubin levels, duct penetration versus duct block, were given the highest ranking. Does the audience have any problem with that? Have they any clarifications, questions, dissenting aspects?
Because even in the absence of a mass, in the malignant process, usually you will have jaundice, bilirubin more than 6.
Dr. Shiraz, would you like to speak now?
Mass. So bilirubin has to be given quite, I also have put 2, although 1 I have given for US FNA.
Yeah, Dr. Ramesh is clarifying. Just,
No, that has been my observation. That even if you don't have a mass, usually in malignant process, the bilirubin
and then the yellows are the clinical parameters. I'm wondering why the clinical did not become green. I thought the clinical should have become green. It got just pushed out of the green If it had been in the 40s, it would be green. Maybe I should do categorization differently. Clinical is very important, I think, because we have the option of doing it again and again and again, and also studying the patient at different times, have different people seeing the same patient. So all this is possible with clinical examination, and that must never be forgotten. So I think even though it's yellow, it should be made green. Would everyone agree with that recommendation? CA99 can be yellow, that's fine. Duct to parenchymal ratio, double duct sign, displaced stone sign, are all yellow. And everything else is really red. Because EUS without FNA, would our endoscopists agree that it's really a bigger problem than a solution? Yes? So EUS without FNA is not specific, it's sensitive, not specific, doesn't help in differentiating between benign and, I'm sorry? Would you please come to the mic and speak so that you can have more discussion? What was the question?
Everybody's sleeping.
Are there any other comments?
I just want to actually clarify this red.
Yeah, please.
Some red in some places.
No, actually it was my inefficiency, because all the ones I wanted to mark red, but I forgot because I actually don't want to let you down. That's why I received all those additions later on, and therefore I forgot to color them as as red, all the ones as red. The twos I colored blue so that they will stand out. Beyond the two, I did not mark, so I'm just confessing what I did. These also must be red, so that they'll stand out to the audience. So I propose that we should do this study with all our members, all our friends, physicians, surgeons, and it will really be a very illuminating story. So, when do we intervene? Next question. Dr. Prakash. Do you wait again, or do you have to be expert, you have to be expeditious in intervention?
If there are intractable symptoms or complications, we'll have to intervene.
And now, so there's a biliary obstruction as well, remember. Now, this mass has got biliary obstruction as well. So when do you decide that you want to do a one-stop shop? You have a mass and biliary obstruction, you want to do, say, surgery. When do you say you want to do, say, endotherapy for the biliary obstruction and then treat the mass if it is continuing? Eliminate the biliary obstruction component or try to eliminate it if possible. Do you have a concept of how you would approach it?
Generally, the biliary obstruction chronic pancreatitis is a long stricture, and if at all you are doing a surgical procedure.
No, I meant, patient has got a bilirubin of 4 milligrams or 3.5 milligrams, some episodes of cholangitis before, but nothing active now. A mass is present in the head, inflammatory mass. There is nothing suggestive of cancer. So it seems that now you're telling them that.
Biliary stenting.
Will you do, or will you do just a direct surgery, which is your preference? And when?
I will first do a biliary drainage and observe the patient. If the pain is better, then we can wait. Otherwise, we'll have to plan for surgery.
Does do all the others? Doctors?
Some of this patient, the jaundice will invariably improve once the inflammation sets in. Some of these patients.
Without stenting? You would not
even without stenting, I have seen patients improving their bilirubin from 5. Last week, one patient, it's
basically persistent jaundice becomes indication more than 4 weeks.
So Dr. Prakash, Dr. Prathapan is telling us that initially, if there is an infective element, treated by antibiotics, treat the pancreatitis, give pain relief by medication, and if the patient's jaundice is not increasing, it's actually decreasing, you can wait. Would you buy that?
Such a scenario is very rare. I would say I haven't seen much patients. They may remain like that. They don't become normal very often. That's not very common.
This entity was actually discussed in detail in one paper by Fraser, and they have put forward the clear guidelines for intervention in biliary. Persisting jaundice beyond 1 month, more than 3 times alkaline phosphatase persisting for 1 month. Evidence of biliary cirrhosis proven biliary cirrhosis on a background of chronic.
I would not wait.
No, these were the indication they put. This was a whole study. It was in 2000 for when we were studying MCH. It presented as a paper in that time. But still that is considered as the landmark paper on biliary obstruction in chronic pancreatitis.
Would you like to also comment on the mechanisms of stricture in chronic pancreatitis, biliary obstruction, Dr. Prakash?
No, most common is because the inflammatory process, fibrotic stricture of the head mass, or then rare causes are because of stones or could be pseudocyst as mentioned here, and very rarely malignancies. So these are the reasons, but the commonest cause is the long fibrotic stricture along the lower 1/3 or even half of the bile duct. That's why the stricture extends usually to the retroduodenal area also. So they are long strictures.
So I want to give you, I want to ask Dr. Prathapan and Sindhu these questions. That you have three scenarios. You have a mass and biliary obstruction. You have a mass without biliary obstruction. And a biliary obstruction without mass. You have to give only one word or two word answers. You can't give explanations. Mass with biliary obstruction, mass without biliary obstruction, and biliary obstruction without mass. All these things, three things do happen. How do you? Quick answers. If you want to compose your answer, then we can wait and come back to this after 3 minutes. No, the other two are different questions.
Mass with the biliary obstruction, I would first take it as malignancy and would like to rule out and go for resectional surgery.
You would evaluate for malignancy. You would be much more proactive in management. Is that what you're trying to say? So, if this malignancy is reasonably ruled out, would you choose a lesser procedure, or you're just having a blinkered approach? All patients are malignancy.
Not like that. I would like to streamline. Bring down
so, proactive evaluation, proactive intervention.
Yes.
Okay. Yeah. Mass without biliary obstruction.
That I would go for a free.
If again symptoms are persistent,
yes.
if there is
so
no...
many factors, but one word answer, that's what you...
Biliary obstruction without mass. Great. I mean, I really enjoyed that. Biliary obstruction without mass.
Endotherapy or biliary drainage procedure, any other. Like PTBD.
Have you seen a patient like that?
Yeah, I've seen.
And what was the further follow-up of those patients?
Biliary obstruction, we took
you placed a stent.
Yeah,
and then what happened after that to the patients?
Then patient was under very close follow-up because we consider malignancy, your jaundice as a very...
You tell us what happened to those patients. Do you remember offhand?
No, no other intervention was done after that. So 1 or 2 patients had stones, large size stones in the head. For those patients, we have done fray with the biliary drainage.
So you chose, even though they had no pain, you went in later on and did it?
Yeah,
or they get pain. I'm interested in knowing what was the...
Pain is not there in the list. So patient, if he has pain, we will go for ductal drainage plus biliary intervention.
No, in these 3 scenarios, my question is very simple. Biliary obstruction alone happened. So the question that you have said, answer you have given is that you will do a biliary intervention alone without touching the pancreas, which is acceptable. Having done that, in those patients, did those guys develop pancreatic symptoms soon, or did they embarrass us by having within the next 6 months, 1 year, they got pancreatic pain and then you had to do a second procedure, even though it is surgical? Did it happen, or did it happen that for years they had no problems?
No, that had happened. Those patients had biliary, pancreatic stones also. We did LPG procedure.
Yeah, the first case, I do further workup, depending upon whether it's a benign or malignant mass, we do either Whipple's or manage. Second case, head mass without biliary obstruction, symptomatic patient, we manage depending upon whether this patient has got features to more in favor of malignancy or not. And lastly, biliary obstruction without mass, in my experience, I have 3 patients done first biliary drainage, surgical biliary drainage done. After 7 years, I had to do a pancreatic procedure in one. The second patient developed malignancy head of pancreas after 5 years. So 2 situations I had. So they were all presented with biliary obstruction, so I was planning only biliary drainage. At that time, there was no actual pancreatic mass or nothing to suggest.
Would there be a comment from the other side as to there is a role for, obviously there's a small role for biliary drainage alone in patients who have no pancreatic symptoms. I think it's generally now everybody is agreeing that an endoscopic approach would probably be better than doing one surgical drainage for that.
If there's no pancreatic pain, yes.
Yes, and then, but you have to tell the patient again that you may soon get pancreatic symptoms. Will you do that, or will you convince them? As Dr. Sudhindran said, he can convince the patient of anything. Would you convince them that your pancreas is the root cause of the problem, so why don't you deal with the pancreas?
There's a difference there. I think I'm coming back to that next. So if you have biliary obstruction without a mass, endotherapy first choice. But if the stone load is very high, sometimes you find stones impinging on the ducts.
Okay.
In that case, I will go for a phrase first upfront.
So you are qualifying the statement. Any comments from the... So while they try to answer the question, I'm asking this same question in a different way, that if you have pancreatic pain or no pancreatic pain. So we have more or less answered that question. So the bottom half is, probably irrelevant.
One point regarding that biliary obstruction is that around 4 cases there was biliary dilatation. That is, all of them were actually choledochal cysts.
There is no IHPRD. The hallmark for biliary obstruction is not dilated bile duct, but IHPRD. If there's a dilated bile duct alone, if you can see the lower end, try to image it. If you can't see it, think of choledochal cyst also. So I want to ask Dr. Ramesh Rajan the spectrum of biliary obstruction, because this is a very important concept. Somebody said you wait till, Dr. Prathapan said you wait till biliary cirrhosis happens. That can be quite counterproductive, because we want to do interventions before biliary cirrhosis happens.
Yeah, so
Dr. Ramesh.
It can be a very wide spectrum, as the slide says. You can have normal LFT, in which case you will just follow up the patient with frequent LFTs and things. Again, just raise alkaline phosphatase, again follow up. There's no pancreatic pain.
No, I think we are going, this slide is probably...
So, there's no pancreatic pain, we would just observe. If the alkaline phosphatase is going up on follow-up, one may consider endotherapy. And if there is mild jaundice, it's not increasing, again follow up, see whether it is coming down. If it is climbing 5, 6, then we should suspect malignancy and work up on that. If there's mild jaundice, again, you should always rule out a mass and malignancy. And there is no pain, it will be just endotherapy. Endotherapy, what they advocate is plastic stents, at least 2 stents. That is what is reported. And you have to keep them for more than a year, I think. I think Dr. Roy and Ismail would agree. At least for a year, you need to keep the plastic stents.
If it is a benign
yeah,
structure.
they're talking about benign, yeah.
It is not 2, actually maximum number of stents, plastic. Nowadays they say even fully covered metallic stent.
Okay. And then, again, at this point, if the stone load is very high, and sometimes the pancreatic stones in tropical pancreatitis are very huge, you can directly erode, you can impinge on the bile ducts. In such cases, I would consider the option of phrase, although there is no pancreatic pain, instead of an endotherapy. And then, of course, for cancer, we will work up and go for a plan for a Whipple. Cholangitis and liver abscesses, we have to treat the sepsis, endotherapy, probably nasobiliary drain, cultures, and antibiotics, then come back and reassess. And once you should not go into picture of the last picture of secondary biliary cirrhosis. At this age, we should not go into secondary biliary cirrhosis.
I have a question. Pascal Hamel showed beautifully that the biliary cirrhosis can be reversed by biliary drainage. It's a landmark paper which is still relevant. So must you be so pessimistic and do
I agree.
an SEMS? You should still drain the bile duct, and maybe there will be postoperative ascites. Maybe the ascites may go on for a long time, but you must try before.
Even fibrosis occurs early. It doesn't require long time to develop cirrhosis. It can happen within a few weeks, actually.
Yeah. Actually, it depends on the type of obstruction, I think. The secondary biliary cirrhosis, the duration and the type of obstruction, whether it is a complete.
So, Dr. Prathapan, in our preparation for this panel discussion, sent me the Caroli and Nora classification, and I was struck. In fact, it didn't occur to me to use this picture, but he described it that type 1s and 3 are the most commonly seen in CCP, but I was trying to point out to him that every one of these is common. That in patients with pseudocyst, you may get this. So you may get in malignancy, you will get 6. So I think this is a wonderful way of classifying biliary obstructions in chronic pancreatitis, and I'm certainly going to read it in detail, and I hope you will So I'm going to now ask Dr. Kalayaresan, because he's been silent all through, that now we have an inflammatory mass, we have biliary obstruction. It seems that our panel has clearly found out that it is not malignancy. So it's an inflammatory mass, there is biliary obstruction, and there is also pain. So surgery has to be done. No, intervention has to be done. So do you think there's a role for endotherapy in mass lesions? So it's going to be surgical intervention. So what kind of procedure are you, can you talk us in a couple of minutes through the pros and cons and what would you recommend?
I think once we rule out malignancy, so in pancreatitis, we try to preserve the pancreatic tissue. I mean, we have to balance between the pain relief and also the long-term outcomes. So that's why Whipple will not be considered in this scenario. So the option is we have Fry and Becker. So whenever we do open, so the procedure of choice is Fry, the extended or the deep Fry. If we are doing minimally invasive, then reproducing the open technique in minimally invasive is challenging. Like the way we do Fry in open, we can't do the same way in minimally invasive. So there we do Becker.
Becker with lateral drainage?
With longitudinal pancreatitis.
With lateral drainage. Any comments, dissenting views from the panel, from the audience? Would you agree with that?
You're happy with doing a bigger procedure, which is a more extensive going on the head?
Yeah.
Minimally invasive, but not Fry.
Yeah, in minimal invasive, because as we start from the anterior to posterior, so how deep, the moment up to that level of duct, we have a landmark. So we know, okay, where we are. The moment we go posterior to the duct, so we don't have landmarks, proper landmarks. So either you have to keep using intraop ultrasound or other modalities like ICG but without landmarks, doing that becomes challenging. So that's why if you have to do minimal invasive, there Becker is slightly, is preferable.
It's feasible, you mean?
Yeah, it's feasible. Obviously, the factors which we take into consideration is extent of extra pancreatic inflammation and also the vascular issues like portal hypertension, especially the involvement of portal vein. Splenic vein still is okay, but moment you have a portal hypertension or extensive extra pancreatic, then minimal is
Dr.
not
Kalayaresan, have you found a way to do something like the burn operation? Like if you, for example, the transection of the neck, reflection of the neck to the right, and finding this pseudo-capsular plane, it seems to be the key to do a Becker procedure, and you have demonstrated that so fantastically. That's terrific. But obviously, if you have portal hypertension, transecting the neck would be a hazardous procedure. Then we would probably have to come back to a limited Fry. Is that right?
No, in that scenario, better to do open, sir. No point in going in for minimal invasive. Because like minimal invasive in chronic pancreatitis is not something has to be done. We do it in patients where it can be done so that you offer the benefit. But whenever there are contraindications, do the standard open up.
So I've got 3 more subjects and 3 experts will deal with them, and I hope they will be brief because we want to finish ahead of time, and then we will be back on time. We will not be much late. The first is the role of endoscopic therapy, and I want Dr. Ismail to, you don't have to use all the slides if you like, but most importantly tell us, we've already discussed a lot of the endotherapy. Where will you definitely do it? Where will a surgeon also, and Dr. B. Venu is the devil's advocate, because you have to agree with everything he says, otherwise it's invalid. That where he would definitely do endotherapy, where he would definitely not do endotherapy, most importantly.
Endoscopic therapy can be for primary disease, basically if you have stones, strictures, or a combination of both in a dilated duct system. And it can be for complications also, which I am not going to in detail. Next slide. Next slide. I would like to make a strong statement here that which even the gastroenterologist will accept as a strong statement. Surgery should be considered over endoscopic therapy for long-term treatment of patients with painful chronic pancreatitis. endoscopy intervention is, when compared to surgery, is little low in long-term effects of effect for painful chronic pancreatitis. Endoscopic intervention is reasonable alternative to surgery if the patient is suboptimal for operating candidates, and those who favor a less invasive approach, assuming that they are clearly informed that the best practice advice primarily favors surgery. So even though I am an endoscopist, I would also, for long-term effect, would suggest surgery as first-line management. There are a lot of procedures which can be done by endotherapy, but the standard is pancreatic sphincterotomy, stone extraction, and stricture therapy, which is dilatation and stenting. And for large stones more than 5 mm, extracorporeal shockwave lithotripsy can be tried. Next slide. These are the different types of ducts which we encounter. One is normal ducts, dilated ducts, stricture at the head region, multiple calculi and strictures. Most of the endotherapy will work only for head dominant disease, whereas if you have a distal strictures, stones, next slide. These are the patients who will benefit with endotherapy. When you have a dilated duct, you can do endoscopic sphincterotomy and stenting. For stricture, you can dilate and put a stent, and for stricture and stone extraction plus stent. Next slide. If you have a distal disease, strictures and stones, the endotherapy may be unsuccessful in most of the cases. Next slide. That's all. So,
Dr. Roy, would you have anything to add to this?
No, I think we always discuss this problem with the patient. On long-term effect always will be the surgical option. So only in very selected cases we even tell about the endotherapy. The stones, single stone in the head region where you can easily take it out, or if you have, even if you want to do some laser, or it's a single stone, which is any stones beyond that, we don't usually do the endotherapy.
Will you say the same statement in ISG meeting also?
Yeah, definitely.
The patient who was treated by Dr. John actually was given the options, and also saw Dr. Roy, and then a concerted decision was done to do endotherapy. We're not saying it's a lasting solution or something. We're not saying even that surgery is a lasting solution for that matter. Any quick comment, because we have to move on?
I would like to quote, since Sir Baiju, we can do many things by endoscopy therapy, but it should be what is best for the patient. And even in gastroenterology, the statement I have taken is from gastroenterology guidelines.
So what is the stone size? What is your cutoff of stone size?
Normally less than 5 mm, but bigger stones we can do pulverize ESWL or even pancreatoscopy if it is dilated.
May I just try to stop this by saying that if there is no stricture proximal to that stone, a larger stone can be easily pulverized and removed. But if there are several strictures, or it becomes a difficult thing, even a small stone can be a big problem. So I think individualized approach. Dr. Venu, would you like to make a comment? Because you are the devil's advocate. Do you have any comments about everything? Everybody has been very reasonable, I feel, but you can say something more if you want.
Other than the definite endotherapy indications, if a patient, even if a surgical candidate, if they present with sepsis, that is cholangitis, then a temporary stenting may be needed. If the nutritional status is poor, to build up the nutritional status, you may temporarily place a stent. Yeah, that's what I can.
So now there are the second issue in the last three after endotherapy is portal hypertension, and I request Dr. Venugopal to summarize what we should do if we have portal hypertension and chronic pancreatitis. A horrible combination.
Manage portal hypertension in chronic pancreatitis is a difficult situation. There is no consensus regarding that, and portal hypertension can be either cirrhosis or prehepatic due to venous thrombosis adjacent to the pancreas. And earlier series has shown a very high incidence, but the recent meta-analysis shows that the prevalence of 11% only, and only a few percent of these patients present with GI bleed. So I divide the clinical scenario into 4 situations. Both can be asymptomatic. The portal hypertension can present with a bleed, and chronic pancreatitis can have isolated, painful, recurrent pain, and both can be symptomatic. So in a patient where both disease are asymptomatic, expectant line of management is a preferred approach. You just wait and watch. Next. In a patient with a symptomatic portal hypertension, that is a present with variceal bleed, the preference of treatment is endotherapy. And if endotherapy fails, interventional radiology has a role to play. If it is cirrhotic portal hypertension, one can place a TIPS stent. And if it is portal vein thrombosis, one can do portal vein stenting. And in symptomatic chronic pancreatitis, the indication for surgery is dictated by the symptoms and morphology of the pancreas and not by the presence of portal hypertension. So surgical strategy mainly determined by the pancreatic ductal morphology and if a mass is present or not. The problem here is because of the presence of collaterals, surgery would be a nightmare, severe bleeding can occur, blood loss. So meticulous surgical technique, controlling each and every bleed, exposing the pancreas, controlling the bleeding every now and then, and should be done to, and in some cases it may be impossible to do a surgical procedure and you may have to back out. And of course the morbidity and mortality is very high in this procedure. Prophylactic procedure for portal hypertension is debatable. If the patient has isolated splenic vein thrombosis, one may do splenectomy because it is curative. And in patients with the fundal varices, if they have blood before, one may add a limited devascularization of the stomach because esophageal varices can be easily managed by endotherapy. And if the patient has both symptoms, that is pancreatic pain as well as a variceal bleed, then again the treatment depends on the morphology of the pancreatic duct. And in patients with splenic vein thrombosis, one can do splenectomy. And revascularization usually occurs after resectional procedures. So resectional procedures are preferred over phrase procedure in these cases. And as I said, procedure is decided by the morphology of the pancreas. And as I said before, interventional radiology has a big role to play. This is a patient with head mass, underwent a Whipple's resection 10 years ago, presented with portal vein thrombosis and ectopic variceal bleeding, which was life-threatening, and it could not be managed endoscopically. She was conservatively managed in ICU, and the bleeding stopped. And then, after stabilization, she was taken up for interventional radiological procedure, and portal vein could be stented, and recanalization could be achieved, and she is asymptomatic after 1 year of follow-up. Anybody can guess why the portal vein is not visible in this, in the interventional radiology? Sorry, splenic vein is not visible. It's not covered, it is an uncovered stent. Nobody would place a covered stent. Because splenic vein is well visible on the left side actually. Yeah, exactly. Because it will show in the direction of flow only. So splenic vein is not in the direction of the dye injection. Next, to summarize, this algorithm was published by our moderator in 2008. Of course,
can we just leave it there for a minute, and I can ask you a question about this. If both are asymptomatic, you said you would do expectant line of management. Yeah. My counter argument is, I would still probably try to do endoscopic variceal obliteration because one day the patient may bleed. Yeah, the patient may get pancreatic pain.
Depends on the endoscopic finding. If there are high-risk bleeding signs like red color sign, of course you will go for it.
I'd like you to qualify that, because the patient suddenly gets pain and then you have to intervene on the pancreas and you have an additional headache of managing the portal hypertension. So generally wipe the portal hypertension to controllable levels.
The usual lines of management for esophageal varices.
Yes.
And to add to that, chemoprophylaxis has not been shown to be beneficial. So beta blockers has no role.
Although many people do give it, I find. I don't know why.
And this algorithm has been published in 2008, so some modification may be needed when the patient does not respond to endotherapy. Interventional radiological procedures should be added at the
Yes. So thank you, Dr. Venu. Any questions regarding portal hypertension? These are patients you much like they accidentally to be referred to another surgeon or another gastroenterologist. So we talked about a lot about genes. I think Dinesh mentioned it and others mentioned it.
Excuse me. There is one slide showing that after resectional procedures, portal hypertension improve. How does it happen? The third.
So that is a Isbicki paper. Dr. Venu, would you like to take that?
Because of the when you do resectional procedures, compression over the portal, mesenteric portal axis is lost and the vein recanalize. But again, the author has said it doesn't have any clinical consequence because those without recanalization also doesn't present with bleeding.
No, I think I was not very convinced by that. That paper said that, in fact, if they do a transection of the neck, it will help in decompressing the portal vein. It seemed very naive to accept.
He's talking about perivein fibrosis.
I don't know.
For the portal hypertension to happen, there should be significant obstruction or even thrombosis.
Yes.
So just by releasing the head.
I agree with Prakash's comment, and actually Venu also says the same thing. So the last segment of this presentation, and again, we just about have time, is that we've always been intrigued by the importance of genes and chronic pancreatitis. And I want to start by asking you, how many of you believe that genes, if you get the genetic code of the patient, you can prevent chronic pancreatitis? Anybody, hand raise, anybody who feels that? Nobody feels that. Yes, it could help in early intervention and family screening. Anybody? Nobody?
Sometime in future.
Yes, I would do that. I would put my hand up. Nobody wants to join me. It's too heterogeneous to make a difference. No, unless you find it out, how will you? I mean, even you want to screen the family and follow them up early. You want to find out early chronic pancreatitis, which you wanted to discuss. Find out at 12 o'clock in the afternoon or at 2 o'clock in the afternoon. Unless you discover it, you won't be able to manage it. So I think I would go for B. And can I ask Dr. Rajiv Jayadevan, who has been recently the president of the Indian Medical Association Kochi, and he's a brilliant speaker. I'm going to put some pressure on him by saying all this. And he's going to talk to us in a succinct way on genetic testing in chronic pancreatitis.
Genetic testing is both a verb as well as a noun. So Dr. Ramesh gives me 7 minutes, so you'll get 2 plus 5. 2 on the noun part and 5 on the 7. That is our agreement. So my disclosure is I do not speak or work for organizations doing any such research. I don't represent them. So here's the fireworks factory, which ships out fireworks into this happy village, where they celebrate Diwali. So that's your firework factory, and then you got your warehouse. And then let's see when the warehouse is and the transport mechanism also pancreas, and to the right you see the gut. So let's look at pancreatitis next. So that's pancreatitis. We do not want to see that. And if you look at the mechanisms, the things that can go wrong are A. The cracker itself can go wrong. You can either have a wrongly wrapped cracker that's going off, or it can get too hot and then it can just blow up. So that's a small fire. That's by trypsinogen activation, reduced degradation. And next slide. So that is controlled by the back, please. Back. Yeah. That's controlled by the PRSS1 gene, which is the superstar of the pancreatitis, chronic idiopathic hereditary pancreatitis gene workup. It was discovered by Professor Whitcomb in 1996. That is still the #1 gene. It is autosomal dominant. It has variable penetrance. You also have, you can see I've written CTRC there. Next slide, please. Now, when this trypsinogen is activated, the pancreas has a natural built-in fire extinguisher. And that, next slide, is called the SPINK1 gene. And when the SPINK1 gene is mutated, next slide, the fire extinguisher fails to work, so the explosion goes unchecked. And the transport mechanisms, specifically the calcium channel situation, is controlled by a couple of genes. Next slide. CFTR and one more, TRPV6, which is studied by CMC Vellore. Next slide. And then we have other environmental factors, extraneous factors. Next slide. And that's tobacco and smoking. So next slide. So we have a complete gene and environment situation that leads to pancreatitis. Next slide. So just for the audience, very quickly, a revision of genetics in 1 minute. If a gene is a car, It can come with all sorts of defects and dents and scratches, and each one of them is a variant. So some variants are disease causing, some are not. For instance, the CFTR gene is enormous. It is 189,000 base pairs. Next slide. So if you want to order a test, you can either order for a single test. Let's say you want to do PRSS1, just a single gene. You can do a gene panel of 4 or 5 genes, or you can do the whole exome sequencing. And what's an exome? Exome is basically all the genes that are actually working in making protein. The genome is everything together that includes the coding genes as well as the non-coding genes. Next slide. But for the last two, which are more extensive, you may bring up some surprise mutations, so you need to send the patient with genetic counseling with a qualified person. So who to test? If you look at all the guidelines, the US, the German, and the rest of the world, 2 things. Young people with idiopathic, recurrent, acute pancreatitis, and those with a family history. So that's the take home for who to test on an exam. But do we really have to do it is a question. The people who advocate for the test say that the advantages are you can facilitate earlier interventions. And I will use the word interventions in inverted commas there. You can also hope to reduce advanced stage chronic pancreatitis, because by intervening early, you are preventing further episodes of pancreatitis, and therefore you are probably saving the patient from a completely destroyed pancreas. Next slide. And then you can also eliminate wrongly attributed etiology. A person who drinks a glass of wine a day gets branded as alcoholic chronic pancreatitis. As Dr. Ramesh said, yes, the family screening is important, yes, and also the Western textbooks say for closure. Now that may not necessarily mean the same thing in the Indian context. More complete picture. In fact, the picture, instead of becoming more complete, could become a little bit more murky, as with Dr. Talukdar from AIG. He recently presented this twin case study. Next slide. 2 identical twins with pancreatitis. One twin had no pain and one had pain. In spite of both of them having the identical set of genes, why did one person have a different presentation? Likely environmental influence. Next slide. So here's a story. Professor Peter Hagi from University of Peaks, Hungary said that. He said they were contemplating pancreatectomy for an 18-year-old college student who had severe multiple recurrent bouts of pancreatitis and with these 2 mutations. So she was counseled, she was agreeable to it, but she said she wanted to get through the exams. And then she confessed that she would have a drink or 2 with her friends. So the professor said, okay, he told her don't drink. And then she stopped drinking, and the story had a happy ending. She lived with her pancreas, there were no more attacks, and it was actually not gene related. So this is again, these are real life stories again from Hungary. Next slide. So here's the verb part of it. What interventions do we have? Do we have a medicine, a magic injection that can make the faulty gene working, like in the case of cystic fibrosis? We don't. Even with cystic fibrosis, we know that the medicine that we use might in fact create worse outcomes in a certain subset of patients. No time to get into that. So we can ask people to stop smoking. Yes, we can ask people to stop drinking and follow a healthy lifestyle. Well, we do that for everybody, don't we? Next slide. So we give the same advice even without the genetic testing. You can save 20,000 rupees or more depending on the center, and then give them the advice. These people are already financially depleted from all the hospital admissions. Next slide. So here in India, there is ethnic variation which affects the gene mutation profile. The literature that I showed you earlier was predominantly Western. So the PRSS1 is primarily in the Caucasian, the white race. Whereas in India and in the African subcontinent and also in South America, the PRSS1 is less common. As Dr. Ramesh himself has said that he could not find PRSS himself. Dr. Nageshwar Reddy from a series of 198 cases in AIG could not find PRSS even single case. Next slide. Discovery of these mutations may sound very exciting, but it's not like H. pylori or, next slide, or like the germ theory of these famous men who made modern medicine what it is. We don't have a single cause for many of these things. These are all polygenic conditions with environmental factors. Next slide. So all these factors influence the outcome. Next slide. Can we give them closure? In fact, the brothers came to Dr. Talukdar with a question, Doctor, are we going to die? Is their concern. So it didn't give them any closure. The brothers were concerned that somebody did genetic testing on them and found something grossly wrong with the genes. So they were concerned. So when Western literature can talk about closure, we should really think about how it affects our own patients. Next slide. What are the insurance implications? You brand somebody with a congenital condition. What will happen to their marital prospects, their social implications? Next slide. Can we justify the cost? This is India. Yes, this is out-of-pocket expenses are known to devastate people. Next slide. So in summary, it's my opinion, being a I don't speak for any organizations that do this sort of thing, because the kind of accent you get from listening to those talks is different from what you heard me talk about. I believe, as do many other individuals, believe that more progress has to be made before it becomes standard of care. Thank you.
And on that somber note that we really don't have any special solution or magic password for improvement in outcomes in chronic pancreatitis, and that we have to struggle through our process, as indeed our patients struggle. If there are no pressing questions, I'd like to thank the panel and the audience for their patience and for your attention.
Now we move on to the video session. I invite Dr. Rajesh Gupta for the first video on retroperitoneal necrosectomy.
Start and control. Okay. So thank you, Dr. Ramesh, for this opportunity. And I start with the retroperitoneal necrosectomy. I actually have two videos. And you will realize the videos are more entertaining than a lengthy, prolonged panel discussion. And it was very intriguing, very intense, and so many things to understand in short span of time. Probably was not fair to all of us. So much of information to grasp. So this is a case which is a 54-year male who had severe acute pancreatitis, failed initial percutaneous catheters and irrigation, which is the usual step up that we do. And in the 7th week of operation, underwent video-assisted retroperitoneal drainage for the collection, which is mainly on the body and tail of the pancreas, but also extending into the head of the pancreas. So this is just a pre-ward image. So, what we do in video-assisted or ward is that we access the cavity through the drains which are already placed. Sometimes, and that is a challenge, accessing the cavity using this drain. Sometimes there are no drains, and how do you access that cavity is by using the transcutaneous ultrasound, which can help, because you have to save the organs which are surrounding this collection, and that is superiorly the spleen, posteriorly the kidneys, and anteriorly the colon. So you have to be right there. And also you have to position your first port, which is generally the camera port, in a way that you can also have another 2 ports for your hand instruments where you can work, and you can work without interfering with each other. So, once you have this plan in position and the CT images, then you go ahead. So once you start the procedure, like Seldinger's approach, which was discussed earlier, here also we open the skin incision around the pigtail catheter. We secure this pigtail, this tract by putting by putting a guide wire, so that the guide wire is in place, and then over this, now we have two options. Either, if it is a recently inserted pigtail, then this tract would be firm and would not be amenable to easy dilatation. So in that case, we probably would use dilators. Can go up to 30 French, and with those dilators, we achieve access to the tract. Otherwise, if these catheters are lying for a long time, then we can use the blunt-tipped artery forceps, reach up to the posterior sheath, and then dilate that tract. And I generally use my finger to further penetrate into the cavity, and then use this Visiport. I prefer putting Visiports because they have a blunt tip in front, and that cannot injure any organ. So that allows you access into the cavity. Once you have entered the cavity, then you can inflate this cavity, and we generally use up to 15, and pressure can, because this is a retroperitoneum, you can gradually increase the pressure even up to 20 also to increase the size of this cavity. But generally 12 to 15 is what we do. And after we have achieved the cavity, first entrance into the cavity, then we use first a needle to know that we are exactly in the cavity, and put the second instrument. And sometimes this alone is enough if the two are aligned very well. At other times, we probably will need a third instrument that can also be placed with this cavity using ultrasound and entering in a straight track to the this necrotic cavity. Once you enter this cavity, all you need to do is remove all the tissue which is coming out loosely. There are some fibrous strands, and those fibrous strands which appear as fibrous strands can be blood vessels, and if you try to use force, they can bleed. So what we generally do is remove these tissues gradually. You can rotate this tissue, and they get separated. It is helpful if this surgery is performed 6 to 8 weeks after the onset of the pain, because then they can get separated easily. The bleeding is less, and you don't damage the viable pancreatic tissue. So all you have to do now is remove this, and then we irrigate these cavities extensively, so that, this is what you remove. But then there are extensions in the paracolic gutter, as you see in this patient. So that was the retrogastric area, but now we are going into the left paracolic area. So you remove a necrosum from all these cavities, and you make sure that what you actually have is a clean cavity or a granulation tissue, but don't rub the instruments on these cavities because they easily bleed when you touch these surfaces. And at the end of this procedure, we leave generally 2 drains, and those 2 are mainly in line with each other, and one is used for ingress and other for egress. The drains actually are used for high volume lavage, which is instituted subsequently. We also carefully look for any suspicious vessel or any bleeder here, because which can subsequently, there can be pseudoaneurysms because of the procedure, and they can bleed subsequently. So we carefully look at whole of the cavity and make sure there are no visible vessels. Sometimes if there are, as you will see in the next next video of transgastric necrosectomy, you can take care of them by clips. So transgastric necrosectomy, we prefer doing these days in all those patients where the necrosum is retrogastric. And this is, I tell you, much better procedure than doing endoscopic necrosectomy. In endoscopic necrosectomy, the only advantage is we are not giving anesthesia, but all other disadvantages of doing it repeatedly and then letting the patient be in sepsis for a longer duration of time. Actually we are pushing them to the wall. So I think wherever possible, we should do transgastric necrosectomy. You can also deal with the etiology in 50% of the patients where cholecystectomy can be done. And the other advantage of doing transgastric necrosectomy is that we can also take care of, if there is disconnected pancreatic duct, we can also take care of this pancreatic fistula and provide a drainage, durable drainage to these patients. This is a short video. So this is a patient where the collection is actually confined into the retrogastric area. Generally, we will see the bulge after we enter the peritoneal cavity. But if not, a laparoscopic ultrasound is preferred to localize this, because accessing again this cavity when there is no bulge is a challenge. One can enter into a wrong area and can cause gastric perforation. So we need to avoid that. But if the bulge is there, then it is not a big problem. So after anterior gastroscopy, you do the posterior gastroscopy. The hole in the posterior gastroscopy is widened by using a stapler. We use 55 mm stapler to get a big opening into the posterior wall, where we can, easily take care of the retrogastric. And not only retrogastric, here you see now we are going into the paracolic area also. So even the paracolic area can be accessed through this transgastric necrosectomy, and we can remove necrosum as low as the right paracolic area. And this is what I was alluding to you when I was saying that this looks like a vessel which is probably not bleeding, no, but is likely, we're not sure, it looks like a vessel. So we just put a clip over there and ensure that there is no bleeding. And we leave the rise tube which we have put nasogastric. That tube is put into this cystic cavity to see that for the next 1 or 2 days there is no bleeding, and after that, that is also removed. Thank you for your attention. Are there any questions on this? Any questions about this technique? They're all tired. I can hear you. So the opening, which is the first opening, is of the PCD, right?
Sir.
So that is used for the camera port.
Camera port, yes, sir.
Now, what you have is, initially there will be a fluid which will be infected that will come out from that port. Okay. So use suction and remove that fluid. Then you achieve distension of this cavity by pneumo, and this pneumo you can go up to 15 also when you insufflate with carbon dioxide. So once you have this cavity, and then you can use transperitoneal or transcutaneous ultrasound and look at that cavity. This gas will not allow you to look at the cavity because ultrasound doesn't work when there is gas. So what we do is we instill fluid, clamp this, and then through the percutaneous, we generally have 2 catheters there.
Okay.
So the other catheter which we use, we instill the fluid, clamp this port, distend it, do ultrasound, look at this cavity, put a needle there, see that needle is actually entering into the cavity, and then in that tract of the needle, we put the first, second, and the third trocar.
So then, by ultrasound, you are seeing whether it is not going through other structures.
So we actually identify spleen above, kidney below, and colon is pushed anteriorly. Colon is not a problem because when you create that,
Space,
insufflation,
it
it is pushed forward.
Yes, sir. Okay, sir. Thank you, sir.
Thank you.
Thank you so much, sir. The next video is on laparoscopic pancreatic osteotomy by Dr. C.J. Varghese.
Good evening to all, and thanks Dr. Ramesh for the opportunity to be here. And going to the lateral pancreatic adenosine, this case which has been done in Najam Hospital, Thrissur. The patient in front position, the legs apart, surgeon standing between the legs, and the monitor at the head end, assistants on the both sides. And then coming to the port positions, usually it in a bucket handle type, like the camera port is a supraumbilical, and then 2 ports, working ports on the other side, and 2 ports for the retraction on, is it? Yeah, and 2 5 mm ports on both sides, and epigastric port if required for the retraction of the left lobe of the liver, it's optional. And now the ports are placed, the stomach is lifted up, and the gastrocolic omentum is opened, divided, and we are entering into the lesser sac. And now the division of this gastrocolic omentum is extended further to the both sides. And now we are going towards the head part of the pancreas. So towards the tail now. So this patient presented with recurrent pain, and then also has a biliary stricture. So this is a pancreas. The tissues over the pancreas is dissected, and the anterior surface of the pancreas is made free. So the anterior aspect is made free finally, then now the duct is open. The duct is felt actually, you run, as in the open surgery, when you run the instrument, if you feel a dip, and now when there is a confusion that spinal needle used, and we have actually know where the duct is, so it is open. Other option is of course to use a operative ultrasound. So here the fluid coming out, and now the opening is extended. So here, if you go in the wrong direction, so you can have problems, because even you can divide the pancreas, posterior part of the pancreas completely. Now we are extending. Now you can see the duct here. There's not much of stones in this patient. So we are using again monopolar here for the division. There's no high-end energy devices required. So it's now further extended towards the both sides. Now you can see that now we are coming towards the head side. Now the tissues over the head is cleared with the hook, and we have to be careful with the gastrocolic vessel, that vein. And if you come very close to the duodenum, then the pancreatic vessels may come across. So a part of the pancreatic tissue is taken off, sort of a phrase operation, but not to the classical extent of the fray. Now towards the head, then it is the duct is open. So the duct towards the head, you can have a view there. Now further extension and towards the tail. And here there was a small stricture-like thing, and we have gone beyond that, and the duct is not very dilated at that end area. So the extension is up to the tail, or the distal part of the pancreas. You can see, appreciate the duct there. Now, as I said, this patient had a stricture and a biliary dilatation, so the biliary anastomosis is being done in this case, the adhesions being separated from the gallbladder, and then the bile duct is made free. And classically, we know that we go for a biliary hepatico-biliary jejunal anastomosis from the bile duct. But here we are doing a choledochoduodenostomy, and we feel that is enough. And this benign type of obstruction that we have come across. So the cystic duct now is dissected out, and it is being clipped. Now you can see the bile duct and it is being opened, and duodenal opening also being done, and now the anastomosis being completed. You have barbed sutures being used here, running stitches, a single layer, and now we are going through the anterior layer, this thing, the bile duct to the duodenum. So it is being, there is no stent or anything like that. And here, another one more layer is being placed anteriorly so that your anastomosis become more secure, tension-free. There's no need for a hemlock because barbed sutures you can leave it alone, but still for extra safety we have put a hemlock. Then the gallbladder being taken out. So gallbladder is removed in a bag. Now we are coming back to this is a jejunal loop for the roux and wide loop. Make a clip so that we identify the limbs properly. Now after this, actually this part I have not shown that roux limb with a stapler has been created already in the laparoscopically only. And then it is taken out to the supracholic compartment through the mesocolon. And then now the first layer, that is outer layer with proline, it has been done. The proline is preferred because it can be pulled and tightened, comes out easily. The stitch parallel to the ductotomy, what you made, it is being done here. So even if you come across a bleeding, when you tighten it, stops, and if a big bleed is usually it can be cauterized, or if sometimes required with a suture need to be placed. Now coming towards the head part of it, you have to be really careful that you don't hit the vessels here. So going very close to it. Now the one layer is over. The making a enterotomy on the jejunal limb. You have to make it a little smaller than actually the size required because it gets stretched actually, jejunum. And this the corner stitch. Again with a barbed absorbable suture been taken. Looping also is there, done it. Now we are coming inside. And now the from mucosa to the duct, it is being done. Again, in this case, because the duct is a bit dilated, it is comparatively easy. So the 15 centimeters, this barbed suture is used here. If you use the 30 centimeters, then the thread handling will be more difficult. And simultaneously now I have not completed that inner layer, but I have started the outer, so that the end becomes somewhere in the middle at the end of the closure. Otherwise you will be ending in the most distal part of the pancreas, which will be technically difficult. So the one more layer, that is anterior layer, is being now sutured. So this is more easier, that is coming from the distal to proximal, found to be more easier than going from proximal to distal. Now we are continuing again with the inner layer. So continuing the stitches here. So again, when it comes towards the head, we may not be taking the bite on the duct. It may be the pancreatic tissue we may be taking, because the duct is at the depth actually here in this area. And I said that if the pancreatic duct division, that is enterotomy, if it is made equal to that of ductotomy, then what happens is that the length becomes on the pancreatic, the jejunal side, it becomes more. So that part you need to take care, because it has to match each other. So now the corner part of it towards the duct. So in spite of taking care, you can see that now the jejunal part is little longer, so that need to be adjusted while taking the stitches now. So this, it is being completed now. So the multiple stitches are used here rather than using a single long stitch. It is, I felt better than using, because it, as I said, that suture handling will be better. Now we are going to the last part of it. Secured with a hemlock, which is not a must actually, because of barb suture. Now again the last layer, that is the proline stitch. Again the vessels will be the pancreaticoduodenal vessels will be very close by. So you need to be very careful that you don't make a punctures on that. And this mesocolic, the rent that is sutured so that there is no internal herniation that will be taking place. So whatever, it's just what we do on the open surgery, it's just the same what been done the laparoscopically. Now the last layer being progressing, and it is completed now being. So usually I keep a drain. So definitely the lateral pancreaticoduodenostomy, it can be done laparoscopically, and with the same procedure that is being done by open surgery. But definitely when it comes to the phrase procedure, the classical resection of the head part or the head coring out may be little lacking as far as the laparoscope is concerned, that of compared to that of open surgery. Thank you very much.
Nice presentation. When will you do choledochoduodenostomy, all cases, or what exactly indication?
No, this patient had a biliary stricture, and the bile duct was dilated, and even intrahepatic biliary dilatation was there, but the bilirubin levels were not very raised. It was abnormal LFT, but marginally raised bilirubin and alkaline phosphatase, etc. So this we conclude as a benign stricture, and this instead of going for a Roux-en-Y, that is same limb, we could have given a biliary anastomosis also. That is, I think, the classical teaching. But here we preferred this because most of our cases we go for a choledochoduodenostomy. We think that there is not much of an alteration of the anatomy here. And in case of future the patient requires some Whipple or something like that, this becomes much easier to handle. Thank you then.
Next video is by Dr. Baiju Senadiben and on pancreaticojejunostomy laparoscopically.
Good evening. Thanks for the opportunity. I was wondering why they kept two videos at the same time back to back, whether it is for comparison or something else. But from the time which I perceived assignment, I thought it is part of the Whipple's procedure as well as lateral pancreaticojejunostomy. The time which was given was laparoscopic pancreaticojejunostomy. So I'll be mixing both the procedures. So technical challenges in laparoscopic pancreaticojejunostomy is it is one of the key steps in laparoscopic Whipples, and there are challenging maneuvers might be tailored to each case depending on mainly on the texture of the pancreatic stem, whether it is soft or hard, whether it is lean or fatty, whether it is thick or thin. So size and visibility of the main pancreatic duct is important. So this is an earlier video of pancreaticojejunostomy done almost 10-12 years back. So you can see the duct is reasonably dilated and the pancreatic substance is moldable. And you can see the jejunum is being prepared for anastomosis. So that is an anchoring suture to the jejunum which is prepared for anastomosis. You can see the hepatic artery and gastroduodenal artery which is clipped. So this is the posterior area which I am taking. Nowadays we don't use silk. This is 20 silk which I am using, and you can see that the silk is going easily because the pancreatic substance is somewhat moldable. So interrupter sutures to one surface to the other, and you can see the duct there, and opposite to the duct the jejunum is opened with harmonic scalpel, and stent is placed. Yeah, then 30 PDS is taken for the anastomosis, duct mucosa anastomosis. First, posterior layer, we usually put 3-4 sutures in the posterior layer and 3-4 sutures in the anterior layer. And again, the last layer, fourth layer, is being completed with black silk. So this is one of the cases where we could easily do the pancreaticojejunostomy. The pancreaticojejunostomy, the techniques can be modified depending on the toughness of the tissue, softness of the tissue, and the bulkiness of the pancreatic stem. This is another case where the pancreatic parenchyma is bulky, and we can see the posterior sutures are being taken with 30 proline, interrupted, and you can see the duct there. That is the duct, you can see very clearly. And that is the last corner stitch which is being taken in the posterior aspect. And on the upper corner also another bite is taken to secure the jejunum or the pancreas. And the jejunum is opened same as before, just opposite to the duct. And you can see that there is no stent placed. Taking through the parenchyma out, and taking to 3-0 muscular, taking small part of the mucosa. Here we are putting 4 sutures posteriorly. That is the second one. Because speediest we need to take 4 or 5 throws. That is the third one. And after the fourth one, I'm putting the anterior sutures and then the seromuscular on the anterior aspect. Now, recently we changed the technique to different, this thing you can see the posterior capsule is made, sutures are made and a stent is kept in the other one, pancreas. And ductal mucosa switches are taken with the stent in situ, and then the stent is taken into the jejunum. And you can see that the jejunum is made into a this thing cup, like the pancreas is lying like this, and the jejunum will be lying like this. Dr. Adar Chaudhary was suggesting this technique in open. So same mechanism here is, you can see that the jejunum is made into a cupping thing, so that you can secure the jejunum or the pancreas on all the sides of the pancreatic stump. We are able to do with very small duct also. I am not showing the entire video. You can see that the feeding tube is not going to the pancreatic duct at all because it's too small. So I'm taking a cannula sheath to check whether it is going or not. That too small, this thing. And it is for cannula sheath also it is very difficult to pass. And finally succeeding in passing the cannula sheath. So I am not showing the full video of this one. So recently we started adding glue reinforcement to the posterior aspect as well as the anterior aspect. This is how we apply glue or the anastomosis. We usually use Tissile 4 ml. And this is the part which I was showing in LPJ. You can see that the duct is widely open from the tail to the uncinate even. You can see the uncinate duct even. It is widely open. The row loop is already created, and it is taken through the mesocolic window into the, that is the row loop is being created. It is taken through the mesocolic window to the supracolic compartment. And you can see that as CJ was showing, it is long anastomosis. There is chance that the jejunum can twist on its own while taking the anastomosis, while doing the anastomosis. So I am using ethibond sutures instead of proline. You can use proline as well. This is the capsular and parenchymal sutures and seromuscular on the jejunal side. I think I can take one more minute. And the marker part is then opened. And Vicryl is taken for inner layer. As you are in doing an open surgery, corneal sutures are made. The inner ductal mucosa anastomosis is happening. You tighten it at the proximal part, then again come with another suture material from the, because the suture material will confuse you if you are starting from right to left. And we can see that the parenchyma is taken along with the duct. That is at the duodenal area, which is secured and tightened with the other suture material. Now, again, seromuscular with the pancreatic capsule and parenchyma with the same ethibond which we used for the first layer. And at the end of the anastomosis. So, to conclude, there is no simple perfect technique applicable to all pancreatistomes in pancreatoduodenectomy and PJ. May have to do dunking if PD is not traceable. Glue may help to hold the anastomosis in place, though solid data is lacking, and the experience matters. Thank you all. After the first layer, we flip the pancreas with the jejunum and to the left, then apply from above.
Thank you, Dr. Baiju. Now for the last video of the day, Dr. Kalerasan on robotic beggars.
Once again, I thank for the opportunity. So, I'll be presenting on the bile duct preserving pancreas head resection, which is actually a kind of modification of Beggars, in which we also add longitudinal pancreatic jejunostomy also. We all know pancreatic head is a pacemaker of pain, so it's important to have a good resection and decompression, and the Fry procedure is commonly performed. But when you attempt to reproduce this by minimally invasive technique, as I mentioned, doing head coring till post-pancreatic capsule is challenging. And if you see the most of the reported series, they are reported modified Fry procedure. So in this technique, we do a subtotal pancreas head resection, preserving the duodenum and bile duct, and also combine that with a longitudinal pancreaticojejunostomy. The aim is to achieve full decompression of the head. So these are the key steps. Doing neck transection. The critical step is the development of plane between the pancreatic parenchyma posterior capsule. Then the resection. Bile duct preservation are using fluorescence guidance and lateral drainage. So we had a good lecture today morning about the arterial and the venous drainage of the pancreatic head and uncinate process. So you have primarily from GDA and IPDA, and then you have 4 main veins draining the head and the uncinate process. So the reason why we should understand this anatomy
and also is about the posterior pancreatic capsule. Again, we had a discussion in the morning. In inflammation, you can identify this capsule very well. So, in this procedure, the anterosuperior pancreadural vein and the artery are ligated along with the anteroinferior pancreadural vein. So, rest of the vessels are preserved because you need vascularity for the duodenum and also the bile duct. So, typically it is done with 4 robotic trocars and 1 or 2 assistant trocar depending upon the anatomy intraoperatively. The first step is entry to lesser sac. Sometimes even this can be challenging in some chronic pancreatitis. One important point is you might enter into the transverse mesocolon. That is something which you need to avoid. So we take off the right colic vein. That's the right colic vein which was draining. Then we divide the gastrocolic trunk. Because the anterosuperior pancreadural drains into gastrocolic trunk, so that drainage will be now affected. Now taking off the gastrocolic trunk also helps us to retract with the right gastroepiploic veins. So now the stomach is suspended. We use this double sling technique. We take off the hepatic artery node just to identify the hepatic artery and also the suprapancreatic portion of the portal vein. Now this is the anterosuperior pancreadural artery, which is one of the terminal branches of the GDA, the other terminal branch being the right gastroepiploic. So this taking of that vessel allows you to safely resect the head. Now we can see here that's the GDA. We are defining the full length of the GDA. So this is actually another patient, just to show that in most of patients you will be able to identify the anterosuperior pancreadural artery, and we preserve the posterosuperior pancreadural artery because this supplies the bile duct. So you need to preserve that, and you take off only the anterosuperior pancreadural artery. The next is pancreatic neck transection. The key point to remember is don't try to make the tunnel in a patient with chronic pancreatitis. We just have to make sure that there is a space between the pancreas and the portal vein, and you start doing the transection, and under vision you need to carefully separate it off from the portal vein, because otherwise if you try to blindly create the tunnel, you might injure the portal vein. So you can see because of inflammation, but often when you are right over the vein, you will have the plane. So once this is done, as I told, the critical step is creating the plane between the pancreatic parenchyma and the posterior pancreatic capsule. So stay close to the vein and start creating the plane. So we always need landmarks. So how we know that we are going to reach the posterior pancreatic capsule? As we saw in the anatomy section, like all the veins, they run along the capsule. So as you go down, you can see here, now this is the inferior pancreadural vein. So once you see the vein, you know that you are close to the capsule. And just with another few millimeters, you will reach the posterior pancreatic capsule. So that is one of the landmark to know that you are reaching the posterior pancreatic capsule. And next is preservation of bile duct. So the landmark for bile duct here is between the portal vein, GDA and the pancreas. So there's a triangle, the portal vein, gastroduodenal artery and the superior border pancreas. So that is a location for the suprapancreatic portion of the bile duct. That's where it enters the pancreas. Obviously, using the endosynthetic fluorescence will allow you to constantly track the location of the bile duct so that you can safely perform the head resection. And when you come inferiorly, again, you can use, because usually we give the ICG the day before. So it would have entered the duodenum, and using that also you can know where is the duodenum, and you can define your inferior extent of the resection. And finally, the pancreatic duct, which is draining into the bile duct, joining with the bile duct, you transect at that location. So you can see here that's the pancreatic duct, and the bile duct can be clearly seen with the help of the fluorescence. So we can see, we give now again ICG to show the vascularity. You can see the two branches of the IPDA nicely preserved. because this ensures the blood supply to the duodenum is maintained. After that, we add the lateral pancreatic drainage, because it's important to completely drain the pancreas. This is something which we always do in India patient compared to what traditionally described by Becker. And anastomose. So we do anastomose the body and tail, do a lateral pancreaticojejunostomy, and also because you need small portion of the pancreas on either side of the bile duct, so we close the pancreatic duct and also drain this portion of the pancreas into the jejunum. So there will be two anastomoses, so that whatever remaining pancreatic tissue also are drained into the jejunum. Now this is a robotic. You can do the same laparoscopic also. So this was a case which was in last week. The same, you can see the posterior pancreatic capsule, and also this is the remnant pancreas. Now we are giving the ICG. You can see here again the bile duct can be seen. And then we give in IV ICG at this time to make sure you can see that's preserved vascularity to the duodenum through the branches of the inferior pancreadural artery. Now just to comparison, so this is the pre-op CT of the patient who underwent laparoscopic procedure. So these are the calcification in the head, and this is a post-op done on. You can still see there are some calcification towards that duodenal side. That is a portion which is left behind. So the final is the jejunostomy, and so probably we feel this technique could be a kind of a preferred minimally invasive technique if you don't want to compromise on the extent of surgery in chronic pancreatitis, but at the same time you want to do a minimally invasive procedure. Thank you. Any questions? Otherwise, good. Thank you.
Thank you, Dr. Kalai, for that wonderful video. Now we go on to the next speaker, Shiraz, on pancreatic transplantation, the reality in India. To chair this session, I would like to invite Dr. Fadil.
Good evening, all. At the outset, I would like to thank my teacher, my mentor, Dr. H. Ramesh, for giving me this opportunity. For many days, I was wondering, what should I talk about reality in India for pancreas transplantation? There's very scanty data. And the last thing I wanted that someone to call my presentation as Kalamutram. Those who are not from Kerala, we can explain them later what Kalamutram presentation is. And so I thought of devising this presentation in giving some of the main indications and outcome of pancreas transplantation. What is the Western perspective and what is the scene in India? Let me tell you a storytelling of a 39-year-old gentleman who was referred to us with a diagnosis of diabetes around 20 years. So he was in his second decade of life. Sooner than later, he developed tripathia and a visual impairment in his course of disease course. He was a BMI of 21. His insulin requirements was 13 a day, and he was started on a dialysis a year ago, which was definitely later than what the Western people would put a dialysis on. The threshold for dialysis in India is quite late, and he gets a breathlessness on just walking around 25 feet distance. He has an intense desire and liking for ice creams, chocolates, and other things, which he was obviously not taking. His blood routines were normal. His HbA1c was 6.5. That means he was very complying with the insulin and the dietary managements. On evaluation, his C-peptide level was 11.75. His GAD and insulin antibodies were negative. he was a single vessel disease and underwent stenting on dual antiplatelets. Now, this gentleman was seen by the endocrinologist who advised against the pancreas transplantation, keeping in mind that the C-peptide levels were high and suggested that you will not benefit from pancreas transplant. Now, the endocrinologist is spoken his heart out basically for this patient, and he hasn't seen pancreas transplantation. He has no experience in this entity, so he couldn't see what is not going around him. This confused the patient, and he came back to OPD, and we were also wondering, because if a patient and doctor and surgeon is not on the same page, and the operation can go wrong, and it can go wrong as the Rimal cyclone hit the coastal area. And so we were wondering whether to put him on a daily insulin and give him a kidney transplant and shut the case there. But he understood one thing, that the insulin he's taking is not preventing him from getting the tripathi. He lost a vision in his eye. He's a jewelry shop owner, and he had a loss in this business because he was finding that there is people doing a shoplifting in his shop. So pancreas transplantation, keeping in mind that it's being regarded as one of the most complex operations, and some people place it after the liver transplantation in that understanding. And so the SPK overall has evolved worldwide from a poorly regulated to a well-organized national practice. With the improvement in surgical techniques, increasing good outcomes has led to the increased demand, and which led to the increase the donor pool. Initially, only the DBD donors were used, and later on, DCD pancreas were also used with almost equal effects. So broadly speaking, the indication for pancreas transplantation is type 1 diabetes with an end-stage renal disease, or a type 2 diabetes with ESRD with a BMI of less than 30. The Indian data suggests, not data, but the Indian guidelines suggest like the BMI less than 28. I think it makes a sense. Our patient profile is definitely different than the Western patients. Or those patients, diabetes mellitus, post-living donor kidney transplantation, can benefit from pancreas after kidney transplantation if it is performed within a year. Why within a year, we can speak about it later. And the recommendations for both these indications are very strong. So the confusion between type 1 or type 2 diabetes has been sorted out by multiple publications and with equal results, and the C-peptide levels doesn't really matter if the patient doesn't have insulin resistance or doesn't have a very high BMI. Isolated pancreas transplantation in patients with a severe hypoglycemia with preserved kidney functions can benefit from this transplant, and diabetes with an end-stage renal disease who are deemed very high risk for SPK can go for an simultaneous islet and kidney transplantation. Though the numbers are very less, so it is not graded recommendation. For islet transplantation, the main indication is for the patients who have a problematic hypoglycemia, which needs to be defined as more than 2 episodes of severe hypoglycemia in the last 2 years with an impaired awareness of hypoglycemia. And the bottom line is that it should be despite the optical medical management, not a patient who is poorly managed with his insulin, gets into hypoglycemia, we ask him for a simultaneous, islet transplantation. Or type 1 diabetics who struggle after a kidney transplant to maintain their normal blood glucose levels. In UK, they perform around 20 to 30 islet transplants in a year. We will compare these things with our population profile in a bit. So problematic hypoglycemia must be an evidence-based approach to optimize medical management. We should not trivialize the islet transplantation being very less invasive and can be given to any patient. There are very and more strict guidelines for islet transplantation in UK. And this must include structured education, and a sensor-augmented insulin pump therapy is the first treatment option for these patients before we consider islet transplantation. Before I came back, I received this message from my chairman saying that how artificial pancreas can be a game changer. He was probably wondering in his mind, should he really call me back from, is artificial pancreas going to do the job of a surgeon? This is basically a sensor-augmented pump where it gives insulin as per the blood sugar levels, which is 24-hour monitoring in the patient, but it's very costly. It costs around 5-6 lakhs and 20,000-30,000 rupees a year. Now, the general understanding is that pancreas transplantation is only for a quality of life improvement, which definitely it improves the quality of life, but whether there's any survival benefit for these patients. Type 1 patients who have end-stage renal disease has shown a consistent survival benefit by many registry analyses from the Western world. And there was an argument that it may be because the SPK donors are young, so they receive a young kidney and young pancreas, so they may live longer and have less complications than the patients who receive the older kidneys. But subsequent survival benefit was from a large US registry analysis also suggested that there's a significant survival benefit in patients who receive simultaneous pancreas kidney than those patients who receive the living donor kidney alone. And for pancreas after kidney transplantation, the US data was initially showing inferior outcome in pancreas after, but subsequent data again showed there was a significant survival benefit even after the pancreas after kidney transplantation. Regarding type 1 and type 2 diabetes, there was no difference in the outcome as long as there was less than 30 BMI. Quality of life, initial reports were mixed because of more surgical complications, and later on multiple data from the West and Japan has shown a significant improvement in quality of life. And those patients who have gone for SPK transplant, their kidneys last longer than the patients who underwent only the living donor kidney transplantation, or if their pancreas failed in the post-op. These diabetic nephropathy in the transplanted kidney has been documented by histological examinations on a protocol biopsies, and they found that the increased basement thickness at 9 to 12 years of follow-up in the patients who received only the kidney transplantation. And the benefit of doing the pancreas after kidney transplantation was only in patients when it was done in less than a year time, because after the 1 and 2 years, they started having the thickness in the basement membrane. Now, the retinopathy, which our patient also was affected with, you can see that almost 70% of patients have an improvement or a stabilization of a non-proliferative retinopathy, and proliferative retinopathy gets stabilized in almost 90% of the patients. So if our patient would have been transplanted a bit earlier, probably would have been not so impaired physically. And peripheral neuropathy, if it is mild to moderate, it recovers in 6 to 12 months of time. And severe ones, of course, don't show any improvement. So is the gastroparesis, not much data about it. Some series suggested that there was an improvement in the gastroparesis after pancreas transplantation. For a macrovascular or what you call a coronary artery disease, macrovascular complications, there was a mixed data, but US and Norwegian registry data suggested a very significantly less death related to the CAD in patients with successful pancreas transplantation. Now coming to the main crux of this presentation was like, what is the scene in India? If you look at the diabetes prevalence in UK is around 4 million people, and type 1 diabetes around 400,000 patients. Incidence in children is around 1 in 1,000. The diabetic curve, the top one, is not showing a significant trend. Obviously, it is on an increasing size, but not very significantly. And the number of SPK transplants they perform in a year is around 150 to 200. There was a dip in the COVID era. And the SPK, the islet transplantation is more or less remains same, 20 to 30, not shown a very significant change or the trend in it. The pancreas only transplant around 10% of the series. Now, if we compare with the Indian data, our diabetes prevalence is around 74 million. That's more than the entire UK population, and these are the diagnosed ones. Undiagnosed would be even more. So if we keep the UK, suppose, as a standard of care, the data which is like unbiased because the government NHS data, the other factors do not play a role here. India should be performing around 3,000 pancreas transplants a year. The reported ones by the NOTO is around pancreas transplants. They are all in the single or double digits. The pancreas kidney transplants are also the same figures. The first successful pancreas transplant was reported by Dr. Guleria's team in 2005 from Delhi, and Amrita hit the first in Kerala. There were other reports from PI Chandigarh and some from Pune, Bangalore, And Tamil Nadu is doing a quite good number of cases because of the good number of donors available. I try to look at the type 1 diabetes incidence in India. We try to dig out the ICMR data, which was started in 2006, where they enrolled 5,000 patients from the tier 1 cities in India, like Delhi and Mumbai and Chennai, etc. Now, at the moment, there is around 25,000 patients enrolled in this study. They found the type 1 diabetes was seen, the prevalence was around 63%, and the young onset type 2 diabetes was seen in another 20% patients, which was probably our patient having the type 2 young onset diabetes, which is actually a more severe form of the disease, and it has a more severe progression of the symptoms and tripathy and vasculopathy in them. This is the data from the All Indian Institute of Medical Sciences, where they looked at around 55 patients and the timeline when they died in the disease course, and they've seen that the death as early as 7 years of life, and none of the patients reached their 50th birthday. Keeping in mind the life expectancy was around 70, is around 70, in those days. Another data from HGPGI looked into the same. They almost had 200 patients. They followed them for around 10 years, and the median duration of death at birth is around 10 years. So after they're diagnosed with type 1 diabetes, generally they die within the 10 years of the disease. And the most important, if you look at the cause of the death, is the CKD. That means that the kidneys are gone, and they need a kidney and pancreas transplantation. Septicemia and a DKI, they are all preventable by giving them a pancreas and kidney transplantation. This is another data from UCMS, which is unpublished data. I was listening to a talk from the head of the department, AIMS, Professor Tendon, done a tremendous work on collecting the data on type 1 diabetes, very, very astute clinician. But again, the same, if you see the stress they give in on is hyperglycemia and sepsis and DKI management from their point of view. It was about 1.5 hour talk, and I couldn't see him telling it once that these set of patients can be treated by the pancreas transplantation because the activity is not happening. So what we don't see around, we don't look at, into that kind of an option. If you look at this figure, out of 58 patients, 75% of these deaths are preventable by pancreas transplantation. And coming to the state levels, we have something in the Kerala called Mithai. It's a government of Kerala initiative, 2,000 patients registered till date with the type 1 diabetes. They provide them with HbA1c testing and the insulin for their treatment. So in conclusion, we need widespread awareness campaigning about pancreas transplantation, not only in the HPB or pancreas transplant groups, but probably with our endocrinologists, nephrologists. They need to be sensitized about this event. We need a strict regulatory body to monitor SPK activity and formulate the guidelines about it. We have to have a regular auditing of the units who are involved in pancreas transplantation, or for that matter, for any organ transplantation. There is a need for nationwide registry to enroll the patients to know the disease burden. And last but not the least is the promotion of organ donation, without which pancreas transplantation will remain a distant dream. Sorry.
Thank you, Shiraz.
Thank you.
Well-crafted presentation. Any question from the floor? Shiraz, how do you assess the graft pancreas is working?
Yeah, there's a protocol, and we follow that guidelines. Basically, it says we need to do a 6 monthly to 1 yearly. We look at the HbA1c, we look at the C-peptide levels, particularly in type 1 diabetes patients, and we compare the graft function in a good, poor, optimal, or failed. So if there's a C-peptide levels comes back to the 0 or undetectable, and HbA1c goes above, then we say it's a failure graft. This is how we monitor the graft functions. If there's any other question, thank you.
Ladies and gentlemen, before we go on to the piece de resistance of this evening, which is the keynote lecture, because Malayalis are sentimental, we haven't lit the lamp of knowledge today. We started off with a bang,
with anatomy and radiology and whatnot and landmark trials. So we want to have a 10-minute brief inaugural sort of function where I invite a few important people to come forward to light the lamp of knowledge. The first, of course, is the Managing Director of Lakeshore Hospital, VPS Lakeshore Hospital, Mr. S.K. Abdullah. Could he please join us on the dais? Without any doubt, Dr. Adarsh Chaudhary is the senior-most surgeon in our fraternity at this time, and he carries a wisdom beyond his years. And I have had the privilege of knowing him for over 3 or 4 decades now, so I would like to have him here. Dr. John Matthew Manipadam has worked tirelessly to make this event possible. And it's only proper that he lights the lamp along with the other dignitaries. This wouldn't have been possible except for the initiative of the Ethicon group, who actually came forward to say we wanted to hold a meeting. Then I actually threatened them that they would have to hold a meeting of high class, but they were game. What we did, the smart thing we did was to get all of you here, and once the smart people were here, the meeting's value automatically was enhanced. So I'd like Debjani Ghosh, who is the Associate Marketing Director of Ethicon Endosurgery, also to come to represent Ethicon. And if there are no objections, I'm happy to light the fifth light. Will Mr. SK do the honors? Is Shali here?
Very good evening. I think you are already behind the schedule, maybe early 1 hour, and running short of time. Second thing, of course, since morning, you are all having the scientific session with the presentations, and the audience were looking at the presentation, not at the speaker. Now, when we make the speeches, you will be looking at me or any other speaker, but you will not be interested to see more than 2-3 minutes. And the other thing, this inaugural session is only just, restricted for 10 minutes. So we have got 5 experts.
No one else is speaking. You're speaking for 2 minutes and that's it. So nobody else is speaking.
It is not fair. Anyway, if it is 2 minutes or 3 minutes, I will. Let me congratulate Mr. John Manipadam, first of all, for having successfully conducted this program. And let me thank all the invitees and faculties and the doctors who attended here with the invitation of Dr. John and Dr. Ramesh on behalf of Lakeshore and the organizing committee. And of course, Dr. Ramesh was asking me, or I mean, when I was entering, he told me that why can't you make a presentation or a speech on the managing the doctors? It is very difficult. Not to manage the doctors, to make a speech on the management of the doctors. As long as the patient and the bystanders are happy, there will be no problem for any manager to manage the doctors. If the patient and the bystander are unhappy, then the hospital management is in trouble. It is not because of any doctor's fault, I don't say, but that is a society, that is a system. So I don't want to make any speech on that one. So it is very happy, and I am, for the last 30 years, I am in the management. I am not a doctor. I don't have any basic knowledge about the medicine and all those things. This pancreatology and everything is a very technical term for me. I mean, even to mention all those things. And I mean, of course, the CMEs and the sessions like this, it is always to share the knowledge, to increase the knowledge, and the continuous education. I mean, even if you are a 70-year-old doctor or 27-year-old doctor, it makes no difference. So always education and the continuous education is very essential. And I should thank the organizers and the supporting sponsors also for conducting such CMEs. Actually, pancreatology is a field that demands any other field, any field, especially pancreatology is a field which continuous learning and collaboration which is required. It is through CME like this that we come together to share knowledge, exchanging ideas, and push the boundaries of medical sciences. Your dedication to advancing our understanding of pancreatic diseases and disorder is commendable, and your contributions to this field are invaluable. So let me congratulate all of you for attending this function, and you will have another one more day tomorrow. Let me thank once again all of you, and in the name of God, this formal function of the inauguration. Though you started in the morning, let me inaugurate in the name of God. Thank you very much.
Thank you, Mr. SK. That concludes the inaugural ceremony. We now come to, as I said, the piece de resistance of the evening. The landmark or session is what we had in the morning. The keynote address is now, and there's many lessons that experience has taught many people. Professor Adarsh Chaudhry is an old friend, but when it came to holding this session, the question was who would chair this session. Pancreatic surgery, pancreatology would not be possible without collaboration, interaction, and multidisciplinary approach. And I thought it would be appropriate to have the doyens of medical gastroenterology, anesthesiology, and pathology, with whom I worked for 3 decades, to come and chair this session. So may I have the privilege of calling upon Dr. Philip Augustine, Dr. Mohan Matthew, and Dr. Pushpa Mahadevan to come forward to chair this session. Can we get these chairs out, please, from here? And only 3 chairs there, please. Only 3 chairs there. PGI, what a year senior to me. He's a leader.
ഒന്നും അങ്ങനെ ചുമ്മാ അങ്ങോട്ട് പോകാം, അപ്പുറത്തിരിക്കാം.
Thank you, Ramesh. First of all, I thank the Lakeshore team for making me part of this update on pancreatic surgery. I'm as fortunate to be part of the progress of pancreatology in Kerala and beyond. And I have seen the growth of pancreatic surgery over the last 41 years. And 30 years of that with Dr. H. Ramesh and team. Before that, when I was an MBBS student, we had a team of Professor P.J. Givargis and Professor Matthew Verghese. That was the era where there was no investigative tools except a plain X-ray of the abdomen. So Professor Matthew Verghese operated on more than 350 patients successfully with just a plain X-ray. Now the whole scenario has changed. Technology has overtaken surgical techniques. Now you have seen robots and other things. But this has been a very interesting saga. I remember the senior doctors who were at that time proficient in pancreatic surgery. One was Professor Srikhande, Senior Srikhande. Shailesh is here. We used to interact when I was in Kothatolam. He used to interact with us from Bombay. Then Professor P.K. Jawar, and then in Pune, Professor Joshi. And the younger generation of surgeons, more brave people. I call pancreatic surgeons, I consider pancreatic surgeons very brave people because they are brave. I've seen less brave people getting into trouble trying to operate on pancreas. So there were centers mainly in the south and in Delhi and Bombay. H. Ramesh and team here, and people who have spanned out of that team. H. Ramesh Verghese we have seen, and B. Venu. And then Dr. Chaudhary. Of course, there were people like Professor Kataria, Professor Kaushik, and Piyush Saini. But 3 centers, if I am asked to mention, that will be the center in Cochin, the one in Bombay, and Dr. Chaudhary Center. So they have been publishing maximum, and they have been guiding the entire pancreatic surgery over the years. Today's program will tell you the story of the evolution of pancreatic surgery in India, and for that, I think the best person they have chosen, Adarsh Chaudhary, our great friend. He has been with part of our team actually. Wherever there is a program, Adarsh should be here. So thank you for coming, and I, on behalf of the organizers and the delegates, I invite you to deliver a talk on what I've learned over 40 years in my practice. Thank you.
Can I have my slides? I've been a surgeon for 40 years, but today only I think I realize I'm a real surgeon because getting recognition from H. Ramesh means a lot. The sort of person that he is, today I think I'm an expert. Earlier I had the expertise, but today I think I'm an expert because H. Ramesh has finally invited me without my asking him to invite me. Thank you, Ramesh. So, if you see the history of the world, no matter what it is, it's essentially a challenge and response theory which was postulated by the famous historian Sir Arnold Toynbee. That there is a challenge by the society, by circumstances, and an individual or a group of people respond to it. My story of pancreatic surgery is a story of similar thing. I started in GB Pant Hospital in 1986, where I was a young consultant, and thankfully, regretfully, my boss was incompetent. So I was forced to do pancreatic surgery. So I started doing this pancreatic surgery. Then I went to Gangaram Hospital, and now I work in Medanta. So in these years, I've been doing gastrointestinal surgery, but my basic area of interest has been pancreatic surgery. It is said that the best teacher is not the one who produces maximum number of students. The best teacher is one who produces the maximum number of teachers. And I'm very proud of the fact the students who have worked with me have been all over the country. I don't know what I taught them about pancreatic surgery. They are better human beings than me. They are value strong, they're skill strong. But in this process, I learned a lot. I've been doing pancreatic surgery. I don't know how much I taught, but my involvement with these patients with these diseases has made me a different person, and I'm going to share with you some of my philosophical thoughts. Because unlike the younger people in the audience, when we were students, there were no videos, there were no YouTubes. We used to go to the National Medical Library to see a reference. So from a pile of journals, we'd take out the journal to find out how to remove the uncinate process. And when we went to those pages were torn. So many times I've come from Chandigarh and went back to Chandigarh without getting a single article, because that's what used to happen. So we've had our share of problems, but in this process, the first thing I learned, which I want you also to learn, is that don't make permanent decisions on temporary feelings. Because science changes, and science is essentially a system of evidence synthesis, and evidence keeps changing. Like when I was in GB Pant Hospital, the entity of pancreatic necrosis has just come out. I'm talking of 1986. Beggar's articles had come. People in Norway had discovered the use of contrast-enhanced CT scan. And presence of pancreatic necrosis was an absolute indication for surgery. Then we realized, Peter Banks said, no, only if there's infection you put a needle and then you operate. So we said mostly we used to operate, and now we realize we selectively need to operate patients who have pancreatic necrosis. My training started with open necrosectomy, and when I was in GB Pant, we are probably one of the first ones in the country to do a lot of patients of necrosectomy, and the only procedure I knew at that time was to do an open necrosectomy, and we published way back in 1997 the loco-regional complications of pancreatic necrosis. And when I left GB Pant Hospital in 2003, our mortality was 17%. There was a reasonable amount of re-exploration, because those days we didn't have facilities for percutaneous drainage, and the hospital stay of patients used to be very long. GB Pant didn't have facility for dialysis. Our ICUs were not so good. So we had our share of mortality, but we continued to do that procedure. And later then we realized that open necrosectomy will push patients towards organ system failure, patients who are marginal. We are pushing them to organ system failure. And there was realization all over the world that open necrosectomy is a great physiological insult, and we should not do such major procedure on these patients. And then realization came that patients like this, who even had gas in the pancreas, could be managed conservatively, and Ramesh was one of the first ones in the world to publish that many of these patients could be managed conservatively. So you see how things change. When I was a student, if I saw this patient, I will not even wait till tomorrow, I will operate this patient. But now we know that we treat patients, we don't treat x-rays. So if a patient is doing well, we will manage this patient conservatively. So that's how science changes. And then we had this a study which came from a Dutch study which changed everything. And they brought up this concept. All of you know this concept of doing minimal necrosectomies, trying to postpone. But the interesting thing what happens in science is that a paper which was published much before that in American Journal of Radiology in 1998, Patrick Freeney published this article which showed that many of these patients could be managed conservatively. Unfortunately, this paper never deserved the attention it got, and W.H. Auden, who's a very famous poet, said something so beautiful that some books are undeservedly forgotten, but none are undeservedly remembered. So this paper was actually the turning point from which the whole Dutch trial was based, but Patrick Freeney never got the credit for that. So that's another lesson in life. Sometimes great work you do is not recognized, but that such is life. Life is not fair. It's we who presume that life should be fair. The problem is that now there is a stigma attached to open necrosectomy, that we should not doing it. Everybody is doing a step-up approach, but if you carefully analyze the step-up approach, it's not all that good. It is extremely resource dependent, expensive. Patients have to come to the hospital again and again. It's not a patient-friendly thing. And what's happening now is, because everybody is doing that, that itself has become a problem. Patients who need open necrosectomy are so delayed by the time they refer to us. This is what we are doing. Patients who are candidates for open necrosectomy, just because there are articles which say open necrosectomy is bad, 4 or 5 endoscopic necrosectomies, various sorts of percutaneous drainage procedure, no matter what happens, patients should not undergo open necrosectomy. That's what is happening now, because there's a Chinese saying which says, if you believe everything you read, you should stop reading. We should use our science to say, what is going to happen to this? The problem is the bandwagon effect. Surgeons are typical for it. You start talking about laparoscopic Whipples, everybody is doing laparoscopic Whipples. You talk about anything, we just want to do what everybody else does. Like they say, one dog barks, 10 other dogs start barking because that dog is barking. We need to put our mind to it, that what is it? Is open necrosectomy really bad? We are writing a paper on our experience, and we now realize that patients who undergo upfront necrosectomy, the selected group of patients, they do very well. I'm not saying these two groups are comparable, but we sincerely feel that open necrosectomy is a good procedure. It's not something which is so bad, and it's our belief that patients who have no impending or threatened organ system failure, who have large necrosis, more than 4 weeks, they should undergo open necrosectomy because of a simple reason that it's single time, it's effective, but the problem is that E. Cummings, a very famous poet in America, said, the greatest challenge is to be yourself in a world where everybody wants you to be somebody else. Today the buzzword is, are you doing minimal invasive necrosectomy? Are you doing retroperitoneal necrosectomy? Little realizing that in majority of our patients, if you do not have an organ system failure, you must stick to your guns and defend your data and say open necrosectomy is a good procedure because it's single time, it is complete, you can add a cholecystectomy with it, you can do a colostomy, feeding jejunostomy, and you put large sized drains which work reasonably well. And if you have a residual collection, these patients could be very effectively managed by percutaneous drainage. Another problem is the cost these patients incur. When you do the step-up approach, patients have to spend a lot of money. In our hospital, sometimes the bill of patients exceeds 60 lakhs. The avoidable thing which is that hospital stay can't be done, but the procedure costs like repeated percutaneous drainage, endoscopy, surgery in the end, so all these things add to the cost. We use unnecessary antibiotics. Patients are in the ICU, they get various sorts of cultures done, parenteral nutrition, so all these things put together add to the costs of managing patients of acute pancreatitis. Jerome Weiser, one of the brightest men in America, he was an electrical engineer. He was so bright that John Kennedy took him in his own cabinet to become the advisor. He said something that we as surgeons need to understand. The problem with us is we don't accept ambiguity. We want to find answers. If we do not find answers, we assume answers. And that's most dangerous. And to my mind, chronic pancreatitis is one such disease. At least the chronic pancreatitis we see, these patients are difficult to manage. We don't know what causes chronic pancreatitis in them. Pancreatic pain is extremely complex. These patients are smokers, they have personality problems, we have no validated scoring systems. How do you pronounce your procedure to be a success? There are so many biases of treating physicians. To my mind, that's a very difficult disease to manage because there are so many factors which are involved in causing pancreatic pain. To say a single procedure will work, that's very difficult. Presence of stones we know is not synonymous with pain relief. All of us have realized that pancreaticojejunostomy initially gave good results, but after 2-3 years, pain comes back. We try doing Baker's procedure. We also do head coring. So these patients do well. And we published a study which showed that most patients for 5 to 6 years will do well. Once we followed up these patients for long, more than 10 years, 15 years, you realize nearly 50% of these patients get their disabling pain back. If you see your data, a lot of patients of chronic pancreatitis die. They have suicides, they have accidents, they have cardiac problems. So that's the problem of chronic pancreatitis because in 50% patients our treatment works. In other 50% of patients, there are a lot of problems. And problems with surgeons is that we want to define our success, we change our definitions, we build up scoring systems which make our operations pronounced successful. That's what happens. If you study the history of art, there are a lot of paintings about crucifixion of Christ. There are thousands of paintings, but there is only one painting which says what our Lord saw. What Jesus Christ saw, this painting by James Tissot, the French painter, which is in the Brooklyn Museum in New York, is a fantastic painting. Jesus Christ is on the cross. He's seeing his devotees. He's seeing the onlookers. He's seeing the people who crucified him. That's what the patient of chronic pancreatitis, we have to see from his angle. Patients of chronic pancreatitis say that nobody understands me. The surgeon wants me to understand him, but my problem nobody understands. Another problem, if you see most discussions of chronic pancreatitis, nobody talks about the small duct disease. It's such a big problem, apart from one or two, Ramesh has written an article, but literature doesn't talk about it because it's a tendency of human beings. We want to run away from something which we don't understand. But this group of patients have problems. I asked a very famous pancreatologist from some part of India, I said, what happens to small duct disease? He says they get, eventually you follow them, they get into big ducts. I said, that's not the answer. It doesn't work just because you do not understand small duct, you can't let them grow into big ducts. The best thing is to say, I do not understand. So I have over years realized there are some things I do not understand. To assume answers, it's very dangerous. Another lesson I've learned is our goalposts keep changing. My priorities when I did Whipple's were different. When I started, I was just concerned that the patient should go out of the hospital alive. There should be no complication. I was least interested in long-term survival. Then I started thinking, once I mastered that there should be no anastomotic leak. Then when I became better, my short-term survival rates were good. Then I said, now I should look at long-term survival. So I went towards R0 resection. Once I understood that, then I said, how can we decrease the cost? Because I want to do more operations. A patient doesn't understand how good I am. Patients, at least in the north, compare rates. How much Whipple's cost here and how much Whipple's cost there. So I said, how can we decrease the cost? Then I wanted to improve patient selection, and now I'm working towards long-term outcome. So that's how our priorities change with time. This was one of the most beautiful books I've read, and this book changed my life. Cesare Pavese is a very famous Italian provocative author. He said, you must look at one thing to find many, and that changed my life. We wrote an article to see, because we were shortage of beds, so we wanted to discharge patients early. So we started doing an ERAS protocol, and we published this paper on how could we decrease the stay in our patients, and we realized obese patients and patients who had respiratory comorbidity, they had delayed discharge, everybody else can follow, and they can be discharged. Then it made us think, how can we use this knowledge for something else? Then we published this paper that we realized that the best advantage of these ERAS protocols is people who do not follow these, they may have a complication. So it became a surrogate marker for presence of a complication. Then we thought that if this is so, the ERAS protocol has been written for normal patients. Are elderly patients fit for ERAS protocol? And we realized, yes, age is no barrier to implement ERAS protocol. Then we said, one of the reasons patients stay in the hospital for long is that they get delayed gastric emptying. We have to give nutritional support. If we can identify those patients who need nutritional support, then we can preempt it and possibly add a feeding jejunostomy or do something. And then we published this paper to predict which are those patients who need nutritional support. We realized our data suggested patients who had gastric outlet obstruction or patients who are on antidepressants, they are more prone to get delayed gastric emptying. So you can add a feeding jejunostomy because we do not routinely do a jejunostomy in these patients. Another reason for delayed discharge would have surgical site infections. So we started working on what causes surgical site infections, what antibiotics should be given so that we can decrease the cost and discharge these patients earlier. So we started working towards cost of pancreatic duodenectomy, if we can forecast the cost. Then we started working on what is the problem that why don't patients eat their pancreatic enzymes? What is the role of various pancreatic enzymes in pancreatic surgery? The two books which are published in 1980, one was called Good to Great and second was called Built to Last. And everybody went gaga over these books. These are fantastic, very good knowledge. But actually when you realize what these two books did was, they found out 10 successful companies and they found out what methods they use, and they said if you use these methods, companies are successful. What a stupid way to write a book. There were 90 other companies which did the same thing but failed. That's not the way to assess. The way to assess is to read books like The Halo Effect and Fooled by Winners. What it means is you have to connect the right dots in life. We always look at people who are successful. You can get more knowledge by seeing people who fail. Because people who fail are definitely doing something more consistent. So once I read these books, we started finding out about the patients who died. So we have about a 4% mortality in us. So we said, why our patients died? So we started looking at realization, and one of our first realization was that our patient selection was not good. Once you start doing many procedures, you become more brave. Right now, our problem is not pancreatic leak or something. Our problem is that possibly we were overstepping our limits, operating patients with low cardiac who had cardiomyopathy, more comorbidities. So we realized we should select our patients better. And then we saw patients who were dying. We found that patients who had elevated liver enzymes before surgery, that was a poor prognostic marker. We are very interested in sarcopenia. So we thought that patients who are sarcopenic, they will die more. But that's not true. We realized sarcopenia is not an indicator of mortality. But yes, if a patient develops a complication, these patients do not tolerate a complication. So that's how we realized that once you start looking for one thing, it's like a domino effect and it takes you further. A lot of discussion is held on what pancreatic anastomosis you do, but once you start doing more of these procedures, you realize that immediate mortality you can conquer. So our current challenge is how can we improve the long-term outcome in these patients. Earlier, we were towards the left. When I was a student, I was told that you lift the superior mesenteric vein up and clear the superior mesenteric artery under it. Now, most of the resections we do are type 2. We take the vein to the right, so we work between the artery and the vein, so more and more resections are being done in that side. And earlier we were restricting to the right side of superior mesenteric vein. Now we are going to the left side of the superior mesenteric vein. In an attempt, if we can improve survival in these patients, all of us are doing more venous resections because we think aggression is the rule. But the question many times you need to ask is, what have we changed? Few days back, I was doing a resection and we're doing something. There was an observer who was observing standing on a stool. The vascular clamp slipped. There was bleeding. So we had to do some things. So after 5 minutes of tension, he asked me a question. is there any point in doing such a mutilating surgery? So I said, no, there's no point. So then I asked myself this question when I was going home, what is it that we are doing? Why are we doing such aggressive surgery? What are we getting out of it? Are patients living longer or they're not living long? All of you should watch this movie called Innocent Moves. There's a 7-year-old boy who loves playing the game of chess. His father is a frustrated man who himself wanted to be a chess player but couldn't win. So he sees his success in that boy and he wants this boy to win. And he gets him a teacher who's equally frustrated, Ben Kingsley, who tells him that you have to win at any cost. You must hate your opponent. You should be like Bobby Fischer. Hate your opponent, only then you will win. But this young boy doesn't have it. He loves the game. He doesn't play for the sake of winning. He loves the game. So there's another player, his name is Vinny, and he plays in the Washington Square just for fun. He's sitting there, he enjoys the game. So this boy becomes an understudy to him and learns the game much better. So that's what we need to do, that we are not operating to win or to lose. We do surgery because we enjoy doing it, and that's the best we can offer this patient. So our intention is to do our best. Trying to say we'll win, I think that's beyond us. What have my 40 years taught me apart from these things? There's a neuroscientific concept which is called as predictive coding. What it means is that our brain does not want to absorb and process all the information. It is just not possible. You go mad. Our brain wants that there should be no surprises. So if you stack your library with information and experience, you won't be surprised. If you are an expert, your predictive coding is very good. You've done a Whipple's operation and after 3 or 4 days, patient is not moving around. His abdomen is distended. Though everything else looks all right, your mind tells you this is not normal. You start searching for these things. So experts have predictive coding. They come to know that this is a cloud on the horizon. You need to develop that. Second thing is about expertise. There are 2 types of expertise. One is a routine expertise. You open the abdomen, you close the abdomen. Other is an adaptive expertise. Adaptive expertise means you need to understand when to change your technique. When you do a pancreatic anastomosis, when you're seeing the patient is bleeding more than normal, when you see the bowel is little edematous, you need to change your technique. And most important thing as surgeon is to learn the language of senses. When you get mature, when you transact the pancreas, you know that this pancreas is soft. You cannot describe it on a scale. As a potter, when he puts his hand on the clay, he has an exquisite sensitivity of the tissues. You need to think with your mind, your body, and your hands to come to know what is happening. These 2 pancreatic remnants are totally different. The second one, anybody can do. The first one, all of us know, are going to be in problems. So once you develop a language of senses, you get better. All of you should read this book. Many of you would have read The Zen and the Art of Motorcycle Maintenance. Robert Pirsig says, a mechanic, when he tries a bolt on a nut, he can either make it finger tight, which just means it is close to it, but it does not lose its elasticity. There is snugness, which means it's opposed, only the superficial elasticity is lost. And there is tight, where the total elasticity is lost. So we as surgeons need to understand how much pressure to put. Unfortunately, most of us are taught that intelligence and thinking is skull-bound. It's in our brain. Our intelligence goes beyond our brain. Our intelligence is in our hands. It's in our environment. It's in people you associate. When you start thinking that you're skull-bound, all your knowledge comes from your brain, is wrong. Our environment, our friends, our hands, our voice, they're all teachers. And once you include all of them in your day-to-day life, your results improve. In these 40 years, I've learned a bit, but some questions keep bothering me. That despite the fact that we do R0 resection, there is no improvement in survival. I don't understand why my drains get blocked, leak occurs, and delayed gastric emptying does not settle in VIP patients and in doctors' relatives. I just don't understand. Why do complications occur in a row? Why is it that in series you could do 90 operations and you start saying, I'm going to have 100 patients without a mortality, 95th, 96th, 97th will die. I just do not understand what's the science in it. And the most important question is, despite doing so much surgery, why am I still scared before each resection? Every night I operate, when I'm operating the next day, I always have the worst case scenario. I don't know why it still happens. Maybe it's me only, but I do not have a scientific answer. But my answer to this is what Charles Chaplin said in this movie, Limelight. That's what we all are, amateurs. We don't live enough to be anything else. Ramesh, thank you very much for inviting me.
Thank you, Dr. Adarsh Chaudhary. A fantastic talk. I'm sure all of you must be on the edge of your seats and trying to solve the problems which he has not been able to fix in 40 years. So looking at all of you, I'm trying to think, you're all placed with an enormous task in front of you where you may succeed, you may not succeed. I have seen this happening with Dr. H. Ramesh and over 30 years of pancreatic surgery. And I always think that initial necrosectomy, we have changed a lot. The years have made a drastic change. What Dr. Philip Augustine said about P.J. Verghese and Matthew Verghese, and then going on from tropical pancreatitis into severe acute pancreatitis. We do not have an answer still. Am I right, Dr. Adarsh? Yeah, so that's the thing. And how did we help him out? See, the problem is anesthesia also, over the last 40 years, has taken vast strides. Because when we started, Dr. Philip Augustine mentioned earlier, it was a plain X-ray abdomen. And we had nothing else except thiopentone, epidural, fentanyl, lignocaine. These things were obsolete. How did we manage to settle the pain which was produced by the surgeons and the patient? As Dr. Adarsh said, pain is tremendous in pancreatitis. First and foremost is to treat the pain. Once you treat the pain, the patient becomes more sure that he is in good hands. The next thing is the ERAS protocol, which he made a mention, that enhanced recovery post-surgery and the steps we have taken have definitely brought results. But by 2022, if you look, there was no Ryle's tube. Ryle's tube was taken out. But between 1999 and 2022, Ryle's tube was a routine in all pancreatic surgeries. Now we don't have the Ryle's tube anymore. So early feeding again is a big problem. Whom do you feed, whom not to feed? And so a lot of surgeons they're not sure what to do. And ERA says early feeding, early mobilization, thromboprophylaxis, pain relief, and these are all things which have improved the results of pancreatic surgery in the last 40 years. Thank you, one and all.
I thank Philip, Dr. Pushpa, and Mohan, for being present this evening and apologize for the delay. Thank Adarsh for making it really very enlightening. Before we conclude, I want to tell you a little bit about a 7 to 8 program in the morning. I think you guys need to wake up early in the morning. Apart from Adarsh's talk this evening, I believe that can be the most illuminating of all the sessions. One can learn endoscopy, we can learn pancreatic surgery in due course, but to live with the senses, as he said, you need to feel the senses of others. And we have, I don't want to, let the cat out of the bag. We've got 3 luminaries, in my opinion, who will share their thoughts of wisdom, and they will not be on pancreatic anastomosis, I presume. And every one of us will be enriched. And I see that in this hall there are so many people who are mentors, and so mentorship and mentorship is a constantly yo-yo phenomenon. I hope I never cease to be a student, and I hope none of you does. And therefore, I wish like all the mentors to be there as well, because I'm sure you would pitch in and add so many words of wisdom. So if everyone can get a wake-up call at whatever time you want, but at 7 you should be there. At 6:30, the breakfast in the hotel will start as a special gesture for all of you. And such of those from the city who haven't managed to grab something will get a bite of breakfast at the session. See you tomorrow after dinner, of course. Thank you very much. So there is a karaoke system. I believe that the members of this group are very endowed with musical skills, dancing skills, and they're all welcome to put their skills on display. And the system is available, and we are quite happy to listen.